hear clicking. I hear clicking. Okay, now.
Good morning. We're calling the meeting to order. Good morning, everyone. My name is Nina Zadeh, and I'm serving as the designated federal officer for the Advisory Committee on Immunization Practices. Welcome to the September 18 to 19, 2025 meeting of the Advisory Committee on Immunization Practices. I will now go over a few logistical items for this meeting. All presentation slides are available or will shortly be available on the ACIP website. For participants joining by Zoom, a few quick reminders. Please keep your line muted unless you're recognized to speak. When the discussion period opens, use the raised hand function in Zoom if you would like to be recognized. Questions will first be taken from voting ACIP members and ex officio members, followed by liaison representatives as time permits. The Advisory Committee on Immunization Practices is a public body, and transparency and engagement are central to our work. This meeting includes 2 oral public comment sessions, today at approximately 3:50 p.m. Eastern and tomorrow at approximately 1:45 p.m. Eastern Time. Requests to provide oral comments must be submitted online in advance. Priority is given to advance requests, and when demand exceeds available time, speakers are selected through a blinded lottery. 19 speakers were selected for this meeting and have been notified. We thank all who expressed interest in sharing comments. Members of the public were also invited to submit written comments through regulations.gov. The docket number for this meeting is CDC-2025-0454. More details on the public comment process are available on the ACIP meeting website. In accordance with ACIP policies and procedures, members agree to forego certain vaccine-related activities during their tenure. For activities that may enhance expertise, the CDC has issued limited conflict of interest waivers. For example, members conducting vaccine clinical trials or serving on data safety monitoring boards may present on those vaccines but may not vote on related matters. For other vaccines from the same company, members may join discussions but must abstain from voting. At the beginning of each meeting, ACIP members disclose any relevant conflicts of interest. We will now proceed with roll call, beginning with ACIP members, followed by ex officio members and liaison representatives. For ex officio members and liaisons, I will call your organization. Please respond with your full name and confirm your presence. We will begin with the ACIP chair, followed by the members in alphabetical order.
Good morning. My name is Martin Kuldorf. I have no conflicts of interest.
Thank you, Dr. Blackburn. And if you'd like to say something about the background, you can do that as well.
Awesome, great. My name is Hillary Blackburn, PharmD MBA, and I'm honored to join you all as the first pharmacist to serve as a voting member of ACIP. I currently serve as Director of Medication Access and Affordability at Ascension RX, and I earned my Doctor of Pharmacy degree from the University of Mississippi School of Pharmacy and completed a PGY1 residency at the University of Mississippi Medical Center. Over the last 15 years, I've worked across hospital, community, specialty pharmacy, and health plan settings. And as a practicing pharmacist, I have administered hundreds of vaccines and completed national immunization certification. I've held numerous leadership roles within professional organizations, including at the national and state level. Been a dedicated preceptor for student pharmacists and serve on the Dean's External Advisory Committee for 2 colleges of pharmacy. I'm honored to bring a pharmacist perspective to the important work that we do as part of the ACIP. And views are my own, not of my employer or other groups of which I am a part.
Thank you, Dr. Griffin.
Good morning. My name is Dr. Evelyn Griffin. I'm an OBGYN from Baton Rouge, Louisiana. I am board certified by the American College of Obstetrics and Gynecology, by the American Board of Lifestyle Medicine, and the Institute of Functional Medicine. I was amongst the first to be a gynecologic robotically assisted surgeon in the nation. In my clinical practice in obstetrics, I had been part of initiatives for maternal immunization, including diphtheria, pertussis, and tetanus. And in my overall practice, I feel like if I was to be given a label, I would call myself pro-informed consent because of medical ethics for discussing risks, benefits, and alternatives with the patient. During the pandemic, I myself was COVID vaccinated. I am honored to be on this community. Thank you for having me.
Good morning. I'm Joseph Hibbelin. I'm a board certified psychiatrist coming to this committee in part for the immense mental health aspects of vaccinations and diseases. I'm a distinguished visiting professor at the University of Bristol in the UK. I have 30 years of research experience at the NIH in basic science, animal, human, and epidemiological studies and data. I have 285 publications with an impact factor of 30. I had to look that up, figure out what that meant. Apparently, it's not only exceptional, but rare. So I didn't know about that about myself. The critical issues I bring to the committee are an appreciation of calculating risks and benefits of getting vaccines and not getting vaccines, backgrounds in immunology, neurodevelopment, and translational sciences. I've been on panels from NATO to the WHO to the National Academy of Sciences twice, to the dietary guidelines twice, to UK parliamentary inquiries, and the Department of Defense and the American Psychiatric Association. Thank you. And I have a neutral mind towards vaccines, approaching this with a scientific equity.
Thank you. We'll skip, or Dr. Levy will join us momentarily. Dr. Malone.
Thank you. Dr. Kirk Mellahone, I first got my PhD from UCSD in physiology and pharmacology, with my thesis being on the mechanisms for inflammation in myocardium. I went on to medical school at Jefferson Medical School, did my residency at Travis Air Force Base in the United States Air Force, then went on to do my pediatric cardiology training at UCSD Rady Children's Hospital in San Diego. Following that, I was served as a pediatrician, pediatric cardiologist in the Air Force. I also served as a flight surgeon and did 2 tours in Iraq as a flight surgeon. I have been board certified in pediatrics and pediatric cardiology for over 20 years. I have experience in vaccinating children and international medicine in over 23 countries, involving those without access to vaccinations. And I currently care for many of those who are suffering from post-vaccine syndrome. Currently, I am a clinical associate professor at Texas A&M College of Medicine, excuse me, and performing inpatient and outpatient cardiology at a children's hospital in Texas. I have co-authored 2 articles on the risk and benefits of COVID-19 vaccines, specifically regarding post-vaccine myocarditis. And it's an honor to be here. Thank you.
Mention whether you have a conflict of interest.
No conflicts of interest.
Thank you. Dr. Robert Malone.
I'm Robert Malone. I'm a Maryland licensed physician. I hold a MD from Northwestern University, a master's degree from UC San Diego in the Salk Institute, Molecular Biology and Virology Laboratories. I had disclosures and inventions, multiple patents in the late 1980s and early 1990s having to do with DNA and RNA vaccines. I've been involved in both bench research with numerous discoveries while I was teaching pathology to medical students for many years. I've also completed a fellowship in both pathology and a fellowship in global clinical research at Harvard. I've been involved in designing, developing, and providing oversight for approximately 40 phase 1 clinical trials, 20 phase 2 clinical trials, 5 phase 3 clinical trials. Served as medical director and medical monitor on phase 1 and 2 and 3 clinical trials, mostly focused on vaccines. I am a vaccinologist. I've spent most of my career developing vaccines. And that experience includes significant work with the Department of Defense, supporting a variety of vaccine products. I originally started off in HIV vaccines. I served here in Georgia as head of clinical for a $330 million BARDA contract for developing cell-based influenza vaccines focused on the clinical aspect of that. I have experience in plague, anthrax, V, tularemia, tuberculosis, Ebola, Zika, ricin toxin, botulinum toxin, and engineered pathogen vaccines. I hold or have been granted a secret clearance by DoD. I have over 100 papers, something like 15,000 citations, and have really extensive experience in public policy as it relates to vaccines, including serving in multiple times as study section chair for typically large contracts at NIH, been an advisor to the World Health Organization on multiple topics relating to infectious disease, and made presentations at WHO about vaccine technology, particularly for influenza. I have no conflicts of interest. I thank the CDC and HHS for the opportunity to serve here as an unpaid member of the Advisory Committee on Immunization Practices.
Thank you. Dr. Meisner joining us remotely.
Thank you, Mina. Let me say good morning or good afternoon or good evening. I'm delighted to have an opportunity to participate in the discussions today. I am an independent contractor with Tennell Government Services supporting BARDA, and I'm a professor at the Geisel School of Medicine at Dartmouth. Thank you.
And please state conflict of interest.
Thank you. I have no conflict of interest.
Thank you. Pagano.
Yeah, good morning. I'm James Pagano, a retired emergency medicine specialist with over 40 years of clinical and administrative experience. Over the course of my career, vaccines have provided significant and at times life-saving benefits to hundreds of my patients. These have included tetanus, tetanus toxoid, flu, diphtheria, pertussis, hepatitis B immune globulin, and yes, COVID. I've also been vaccinated myself numerous times against all these diseases and toxicities. So I'm not anti-vax. I am pro the intelligent and informed utilization of these potentially life-saving medications in a manner that reflects the current state of the art regarding their benefits, the target populations, optimal dosing and timing, and yes, of their potential adverse effects in some people, and I have no conflicts.
Hi, my name is Vicki Pebsworth, and my career began over 45 years ago. I started as a bedside nurse where I took care of patients who were sick with vaccine-preventable diseases, and I gave lots of vaccines. I eventually went on to get a degree in public health and health services organization and policy, and also nursing at the University of Michigan. I am recently certified in bioethics. I have previously served on 2 other vaccine policymaking committees for nearly 10 years. I was with the Food and Drug Administration's VRPAC committee, the Vaccines and Related Biologic Products Advisory Committee, and also served on 2 subcommittees at the National Vaccine Advisory Committee, the Vaccine Safety Working Group, and the 2009 H1N1 Vaccine Safety Risk Assessment Working Group. I've also served as a consultant to the CDC's Board of Scientific Counselors and also to the Institute of Medicine on the topic of vaccination and public trust. I have published peer-reviewed literature, and I serve as a peer reviewer for a couple of journals on topics related to vaccination, vaccine uptake, the effects of state laws, and vaccine safety. I currently volunteer as a director at the National Vaccine Information Center and the National Association of Catholic Nurses. My comments reflect my own opinions and not necessarily those of the organizations I am affiliated with, and I have no conflicts of interest.
Thank you, Dr. Paul.
Am I next?
Yes, please.
I'm Raymond Pollock. I'm a semi-retired consultant and former professor and head of the abdominal organ transplantation at the University of Illinois. I was also a principal investigator in multiple clinical trials, as well as a principal investigator in NIH-sponsored research in transplant immunobiology. I'm happy to be here, and thank you for the opportunity to be of service, and I have no conflicts of interest.
Thank you, Dr. Stein.
Hi, I'm Dr. Kathy Stein. I'm a professor of epidemiology. My PhD is in epidemiology and biostatistics, and I have a 20-year career focused in infectious disease epidemiology with over 115 peer-reviewed publications and several review papers and other things besides. I've also done some work in bioethics, especially focusing on informed consent. And I've mentored several master's and PhD students who have gone on to careers in public health and medicine. Much of my infectious disease research has been collaborative in the field of immunology and thus has had implications for vaccine design. I am a professor of epidemiology at Case Western Reserve University. My views are my own, and I have no conflicts of interest to report.
Thank you. We'll move on to our ex officios, starting with CMS. Please provide your name.
Andrew Johnson, Centers for Medicare and Medicaid Services.
Thank you. HRSA.
Captain Reed Grimes, Health Resources and Services Administration.
Thank you. IHS.
Matthew Clark, representing the Indian Health Service.
Thank you. NIH.
Michael Carilla, representing NIH.
Thank you. And FDA.
Tracy Beth Hogue, FDA.
Thank you. And we'll go back to Dr. Retzef. If you please do your introductions and state if you have any conflicts.
So first, I don't have any conflict of interest. I'm Retzef Levy from MIT. I'm a faculty there from 2006. I have a PhD in operations research, and I've been working for most of my career, academic career, on trying to think about risk-benefit trade-offs and optimization of them in many complex systems that operate under a lot of uncertainty with the great consideration to risk. And a lot of my work has been focused on human health. I've been working for many, many years with clinical teams on the ground, trying to optimize clinical and operational processes in large healthcare systems, working extensively with healthcare data. I've been working on using data to optimize the quality and safety of the manufacturing of biologic drugs, developed drug safety models, epidemiological models, also worked on issues related to access to healthy food, agriculture and food supply chains and their impact on health. And I'm honored to be here and work with my colleagues on the committee and the CDC and FDA today and tomorrow.
Thank you. I will now call the liaisons, and please state your name if you're on the phone. American Academy of Family Physicians.
Good morning, Dr. Laura Morris, representing AAFP. Thank you.
American Academy of Pediatrics. American Academy of Pediatrics. American Academy of Physician Associates.
Good morning, Dr. Sandra De Palma, AAPA.
Thank you. American College Health Association.
Good morning, Ashley Halberter, American College Health Association.
Thank you. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists. American College of Obstetricians and Gynecologists. American College of Physicians.
Good morning, Dr. Jason Goldman, board certified internal medicine specialist with over 25 years of clinical experience, clinical affiliate professor of general internal medicine at Florida Atlantic University, and president of the American College of Physicians, present.
Thank you. American Geriatric Society. American Geriatrics Society. America's Health Insurance Plans.
Good morning, Lori Kaloya, present.
Thank you. American Medical Association.
I'm Dr. Sandra Freihofer, practicing general internal medicine physician in Atlanta and adjunct associate professor of medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Barbara Resnick, I'm present representing the ANA. Thank you.
Thank you. American Osteopathic Association.
Good morning, Masood Mahmoudi, American Osteopathic Association.
Thank you. American Pharmacists Association.
Hi, good morning. Dr. Kelly Good, representing the American Pharmacist Association. Pharmacists and pharmacy personnel are the most accessible healthcare providers and serve as the primary immunizers for patients across the country. Our association represents these professionals and is committed to supporting science-driven, evidence-based recommendations that enhance public health. I appreciate the opportunity to contribute to this ACIP meeting. Thank you.
Thank you. Association of Immunization Managers.
Hi, good morning. Molly Howell, representing AIM.
American Immunization Registry Association.
Good morning, Rebecca Coyle, representing ERA.
Association for Prevention, Teaching, and Research.
Good morning, Chrissy Mullinger, representing APTR.
Thank you. Association of State and Territorial Health Officials.
Good morning, Dr. Meredith Allen, representing ASTO.
Thank you. Biotechnology Innovation Organization.
Phyllis Arthur, representing Bio. Good morning.
Thank you. Council of State and Territorial Epidemiologists.
For Christine Hahn, representing CSTE.
National Association of County and City Health Officials.
Yes, good morning. My name is Dr. Judith Schley. I'm a family physician at the Public Health Institute at Denver Health, and I am representing NACHO, which supports 3,000 local public health agencies in our country.
Great, thank you. Canadian National Advisory Committee on Immunization.
Matthew Tunis, present.
Thank you. Infectious Disease Society of America.
Flor Munoz, Infectious Disease Society of America, present.
Thank you. International Society for Travel Medicine. International Society for Travel Medicine. National Association of Pediatric Nurse Practitioners.
Good morning. This is Stacy Buchanan, doctorally prepared nurse practitioner, as well as instructor, professor at the Emory School of Nursing.
Thank you. National Foundation for Infectious Diseases.
This is Dr. Bob Hopkins, Medical Director for NFID. We're here for the science and for our patients. Thank you.
Thank you. National Medical Association.
Good morning. This is Naima Joseph with the American College of Obstetricians and Gynecologists. I was not unmuted previously, but we are present. Thank you.
Great. Thank you so much. National Medical Association. National Medical Association. Pharmaceutical Research and Manufacturers of America.
Yeah, good morning. This is Dr. Michael Barr. I'm a board certified and practicing emergency physician and chief medical officer at Pharma.
Thank you. Pediatric Infectious Diseases Society.
This is Grant Paulson with Pediatric Infectious Diseases Society.
Thank you. Society for Adolescent Health and Medicine.
Hi, this is Amy Middleman representing SAM and looking forward to hearing scientific evidence to recommendation presentations that are so critical prior to any public health recommendation. Thanks so much.
Thank you. Society for Healthcare Epidemiology of America. Society for Healthcare Epidemiology of America. Okay, thank you. I will turn it over to the chair.
Thank you so much. Good morning. I wish to welcome all of you with a special welcome to the 5 new voting members of this committee. Most of all, I would like to welcome members of the public who are listening to these proceedings. We are currently experiencing heated controversies about vaccines, and a key question is, who can you trust? Here's my advice. When there are different scientific views, only trust scientists who are willing to engage with and publicly debate the scientists with other views. With such debates, you can weigh and determine the scientific reasoning by each side, but without it, you cannot properly judge their arguments. For this reason, I lament that the American Academy of Pediatrics has ended their participation as a liaison member of this committee. Neither have they accepted my invitation for an open public debate on vaccines with equal time for each, nor an invitation for private conversations. A few weeks ago, the CDC director was removed and 3 members of the CDC leadership resigned, citing divergent opinions about vaccines. On vaccines, this committee is the key advisor to the CDC director, but during her short tenure, she never contacted me as the ACIP chair about any of her questions or concerns, which would have been natural if she had such concerns. Neither was I contacted by any of the 3 CDC leaders who subsequently resigned, except for receiving a good suggestion by Dr. Daskalakis during the June ACIP meeting, which we adopted. Of the 4, Dr. Jernigan has done important research on influenza vaccines, but the others are not vaccine scientists. Why would these CDC leaders ignore us instead of seeking advice from fellow scientists who have spent decades studying vaccines? With other CDC staff, I've had frequent and excellent interactions since I became the chair of this committee, as well as going 20 years back working with CDC. Some are very good, and the rest, they are fantastic. All are hardworking, and I cannot thank them enough for the work they're doing. After the 4 CDC leaders departed, 9 former CDC directors wrote an op-ed in New York Times, falsely claiming that members of this committee are quote, unqualified individuals with, quote, dangerous and unscientific views. This committee has a wide variety of vaccine expertise. Other committee members have already described their own credentials. As a professor at Harvard Medical School, I developed epidemiological and biostatistical methods for post-market vaccine safety studies that CDC regularly uses, including 3 methods used for CDC presentation at our last ACIP meeting in June. I have authored dozens of scientific articles about vaccines with vaccine scientists at CDC, FDA, at leading universities. And I dare to think that my contributions to vaccine research is highly regarded by my colleagues. Since we authored the same scientific articles, are my co-authors also unqualified and unscientific vaccine scientists? Of course not. The majority of our many vaccine safety studies did not find problems with vaccines. So by dismissing us as unscientific, the former CDC directors are de facto questioning not only us and our scientific research, but they're also questioning the safety of many childhood vaccines that we have shown to be safe. The fact is that we are honest vaccine scientists that let the data speak whether the results go in one direction or the other. That is always how science should operate. In April 2021, when CDC instituted a pause on the Johnson & Johnson vaccine against COVID, despite a vaccine shortage during the middle of a major COVID wave, I was the only vaccine scientist to publicly object to that decision, one that I believe led to unnecessary death among older Americans. After noticing blood clots in post-vaccination young women, it was reasonable to advise them to take another vaccine. But the decision to remove the Johnson & Johnson vaccine from all ages must be viewed as one of the most disastrous vaccine decisions ever made by CDC. Because of my public objection, I was fired from the CDC committee that was monitoring the safety of COVID vaccines. But 4 days after firing me, CDC lifted the pause as I had suggested. At this time, I was clearly the most pro-vaccine scientist in the country, while becoming the first person fired by CDC for being too pro-vaccine, simply because I chose to debate the science rather than go along with the crowd. As this committee clearly stated at our last meeting, we strongly support the use of vaccines. At our last meeting, all our decisions were pro-vaccine. This includes the vote to remove mercury for vaccines. Mercury is a known toxin, just like lead and cigarette smoke, and we should minimize exposure to such toxins as the effect is cumulative. If you had to choose between buying similar hot dogs with or without mercury for your kids, raise your hand if you would pick the mercury-containing hot dogs. Nobody would? FDA has banned mercury from beauty products such as skin creams and soaps. Vaccines are more important than cosmetics. Since there are equally good mercury-free vaccines, removing mercury has only positive public health consequences, while increasing the integrity and trust in the vaccine program. One of the CDC leaders that resigned cited our vote to remove toxic mercury from vaccine as a reason for his resignation. I found that surprising. In contrast to that, I want to take this opportunity to thank the many mothers and fathers who over many years have fought hard to remove mercury for vaccines. You have falsely been called anti-vaxxers, but your stance is not only pro-children, but also pro-science, pro-public health, and pro-vaccines. The members of this ACIP committee are committed to reassuring the public and restoring public confidence by removing unnecessary risk and harms whenever possible. That is a pro-vaccine agenda. While all of Western countries recommend important vaccines, such as the one against measles, there is a wide variety in the recommended vaccine schedules. This does not make some countries anti-vaccine countries. The votes that we will take at this meeting falls well within the natural variability seen between countries. We welcome scientific critique of any of our votes, as there are gray areas due to incomplete scientific knowledge. But false accusations that we and other respectable vaccine scientists are unscientific and dangerous anti-vaxxers, that just adds legitimacy to anti-vax positions, damaging both public health and the confidence in vaccines. Such false accusations are only logical if their purpose is political. Again, I suggest that you should only trust scientists that are willing to debate fellow scientists with different views. I hereby invite each of the 9 former CDC directors to have a live public debate with me concerning vaccines. They are Drs. Besser, Cohen, Fauci, Frieden, Copland, Roper, Satcher, Schuchat, and Walensky. If they are unwilling to engage in an open and honest debate with a chair of this committee, that they are so severely criticizing, then I advise that you should not trust them. I also make the same invitation to the recently departed CDC leaders. If they want to be trusted, they should all accept. Thank you very much, and then we can proceed with the regular program of this meeting. We have a short update on working groups. We have a number of working groups that are working hard, and that's where a lot of the actual scientific work is going on. And you will hear from some of these, the deliberation from some of these working groups at this meeting. We also have 2 new working groups that we are setting up. One working group on vaccines in pregnancy, and the other one is the childhood and adolescent vaccine schedule. Most of the working groups consider a singular vaccine or a group of related vaccines. But it's also important to look at interaction effects, or if it's best to do one vaccine before another, or concepts of the whole vaccine schedule. So that is what this new working group will be looking into. And of course, vaccines during pregnancy, we always have to be very, very careful and considerate, as with not just vaccines, but with drugs, of anything that we give to a pregnant mother, because of risk of, for example, birth defects. So we will have those 2 working groups, and at some point in the future, we will be discussing the results of those working groups at these ACIP meetings. The first topic that we're going to talk during these meetings is the measles, mumps, rubella, and varicella vaccines, they're called MMRV. This is the vaccines where protecting against all these 4 diseases in one vaccination, in one needle. And that is the vaccine that was developed to replace 2 separate needles, one for measles, mumps, rubella, MMR, and then a separate needle for varicella to reduce the number of needles that a child receives. We're first gonna hear about the background on MMR from Dr. Arjun Srinivasan from here at CDC. So please.
Thank you, Dr. Koldoff. Good morning. I'm Arjun Srinivasan, Acting Chief Medical Officer in the National Center for Immunization and Respiratory Diseases at CDC, presenting today the background on measles, mumps, rubella, and varicella vaccine. Do we have those slides? There we go. I want to mention up front that this presentation does not include data on safety related to M vaccine, either pre or post licensure. Those data will be discussed next by Dr. Su. Next slide, please. Measles, mumps, rubella, and varicella cause significant health burden pre-vaccine in the United States. Highlighted on this slide are several severe consequences of these diseases. During the last major rubella epidemic in the US in 1964 to 65, in 1 year, 11,000 pregnant women lost their babies, 2,100 newborns died, and 20,000 were born with congenital rubella syndrome that causes deafness, heart defects, and developmental delay. Before the introduction of the measles vaccine, each year an estimated 48,000 hospitalizations and 400 to 500 deaths were due to measles. Pre-vaccine, mumps was the leading cause of viral encephalitis and sudden onset deafness. And for varicella, each year in the early 1990s, 10,500 to 13,500 hospitalizations, and 100 to 150 deaths were varicella related. Next slide, please. The introduction of vaccines to protect against these diseases in the form of monovalent and combination measles, mumps, rubella, MMR, or measles, mumps, rubella, varicella, or MMRV, coupled with attaining and maintaining high coverage rates for more than 90%, led to dramatic reductions in disease burden in the U.S. Elimination of endemic measles in 2000, elimination of endemic rubella in 2004, a 99% decline in mumps cases by early 2000, and a 97% decline in varicella incidence by 2019. Next slide. Two options are available in the U.S. for measles, mumps, rubella, and varicella vaccination. Combination MMRV vaccine or MMR vaccine plus varicella vaccine. Vaccination is recommended as 2 doses, with the routine ages being 12 to 15 months for the first dose and 4 to 6 years for the second. The MMRV vaccine available in the U.S., ProQuad, manufactured by Merck, was licensed by FDA in September 2005 based on non-inferior immunogenicity of the antigenic components compared with simultaneous administration of MMR vaccine and varicella vaccine. The efficacy of the measles, mumps, rubella, and varicella components of MMRV vaccine was previously established in clinical studies with the monovalent vaccines. At the time of MMRV licensure, the burden of disease for these diseases was too low to perform efficacy clinical trials in the U.S. Of note, immunobridging trials are an established approach for the development of vaccines. Next slide. Immunogenicity after the first dose of MMRV vaccine versus MMR plus varicella vaccines in children aged 12 to 23 months was assessed in 4 randomized clinical trials. 5,446 people received MMRV vaccine, and 2,038 received MMR plus varicella vaccines at separate injection sites. In these studies, the endpoints assessed, seroconversion rates, and geometric mean titers were similar between the 2 groups and met the pre-established criteria for non-inferiority. Immunogenicity after the second dose of MMRV vaccine versus MMR vaccine with and without the varicella vaccine in children aged 4 to 6 years was assessed in 1 randomized clinical trial. 399 people received MMRV, 205 received MMR plus placebo, and 195 received MMR plus varicella vaccine. Findings also met pre-established criteria for non-inferiority. As you heard during the last meeting, an ACIP working group assessed the evidence for safety after MMRV compared with MMR plus V in 2008 and 2009. Their assessment on vaccine performance was that given the non-inferior immunogenicity, effectiveness was assumed to be equal. Next slide, please. This slide illustrates the timeline of recommendations for MMRV vaccine use in the U.S. Upon licensure in September 2005 for use in children aged 12 months through 12 years, MMRV vaccine was preferred over separate administration of MMR and varicella vaccines, consistent with ACIP recommendations at the time on preferred use of combination vaccines. In February 2008, a preliminary vaccine safety finding from 2 post-licensure studies that found an increased risk of febrile seizures after the first dose of MMRV vaccine led to ACIP removing the preference for MMRV vaccine use versus MMR and varicella vaccines for both dose 1 and dose 2. After further examining the safety and other evidence, including use of MMRV vaccine has the benefit of requiring 1 less injection than the alternative of MMR plus varicella vaccines, epidemiology of febrile seizures, parent and provider input, and consultation with ethics experts, in June 2009, ACIP issued updated recommendations. Next slide. These updated recommendations are the current recommendations and state that for the first dose of measles, mumps, rubella, and varicella vaccination at age 12 to 47 months, either MMR vaccine and varicella vaccine or MMRV vaccine may be used. Providers who are considering administering the MMRV vaccine should discuss the benefits and risks of both vaccination options with the parents or caregivers. At the time of the publication of the recommendations, CDC provided implementation guidance that, Unless the parent or caregiver expresses a preference for the MMRV vaccine, CDC recommends that MMR vaccine and varicella vaccine be administered for the first dose in this age group. For the first dose at age greater than 48 months, and for the second dose at any age through 12 years, that is 15 months through 12 years, MMRV is generally preferred over separate injections of MMR vaccine and varicella vaccine. Next slide. No post-licensure vaccine effectiveness estimates are available for the MMRV vaccine used in the U.S. With measles and rubella being eliminated in the U.S., mumps and varicella at very low levels, there are not enough cases of disease or outbreaks in children to assess vaccine effectiveness in the U.S. Those vaccinated with MMRV or MMR and varicella vaccines continue to have very low rates of disease for measles, mumps, rubella, and varicella in the U.S. There have been no reports to CDC indicating concern for lower MMRV vaccine effectiveness compared to use of the separate component vaccines, consistent with the immunogenicity results seen in the clinical trials. Next slide. As far as utilization, MMRV vaccine accounts for 15% of first dose measles, mumps, rubella, and varicella vaccination among children aged 19 to 35 months. In most states, MMRV vaccine is used for about 10% to under 20% of first dose based on the first and third quartiles. In children aged 4 to 6 years, MMRV vaccine accounts for 75% of second dose vaccination. Next slide. To conclude, MMRV vaccine is one of the two options for vaccination of U.S. children for protection against measles, mumps, rubella, and varicella. As the ACIP assessed in 2008 and 2009, given the balance of risks and benefits of a first dose of MMRV vaccine compared with the first dose of MMR vaccine and varicella vaccine, and the importance of individual values and preferences in weighing these risks and benefits, maximizing choice is an important ethical principle, and decisions should be made by providers and parents or caregivers on a case-by-case basis. The two vaccination options, MMRV vaccine or separate injections of MMR vaccine and varicella vaccine, are considered equivalent in terms of protection against disease. Due to the current recommendations, most MMRV vaccine in the U.S. is among children aged 4 to 6 years for the second dose of MMR and varicella vaccination. Vaccination for measles, mumps, rubella, and varicella has led to at least a 97% reduction in all 4 diseases compared with the pre-vaccine era. Thank you.
Thank you so much for that presentation. From the members, do we have any questions or comments? Please, Dr. Milone.
Yes. Could you address the issue of how much adjuvant there is in an MMRV versus an MMRV and varicella that are used separately? Is the adjuvant similar or different?
Thank you. I'm going to ask my colleagues. We have a number of subject matter experts on the line who might have that information. Do we have the CDC SME room on the line? Does someone want to address that?
Hi, thank you. This is the NCIRD SME room. There is actually no adjuvant in either of the MMRV or the MMR plus V vaccines. Thanks.
Thank you. Joe?
As many of the members have been interested in risk-benefit assessments, you've described a great deal of the benefits, and you mentioned febrile seizures as a risk. What is your opinion about the risk-benefit ratio of harm from febrile seizures or harm from side effects versus the benefits for the individuals in the population?
Dr. Su is going to present on the risk profile. It's not my position to comment on the risk benefits. Thank you.
Dr. Malone?
Yeah, I just have a blanket statement regarding this topic area. Because of my prior work as an expert witness in the case of Kraling versus Merck having to do with mumps vaccines, because I signed an agreement to allow me to view extensive internal communications within two vaccine manufacturers, I am legally bound to not do any research or have opinions relating to these products because they include the mumps component. So I just wanted to make that clear. I won't be voting, and I have no opinion on this consequent to pre-existing legal agreement from my years ago service as an expert witness in the case of Kraling versus Merck. Over.
Thank you for that clarification. Vicky?
Could you please clarify the difference in the amount of antigen for varicella in the two different options?
Let me turn to the CDC SMA room and see if someone has the answer to that question. Thank you.
Hi, this is the NCRD SME room. Can we have our backup slide number 12? Thank you. On the screen is the amount, and we have another SME that can comment further.
Yeah, so the viruses and viruses for measles, mumps, and rubella, it's the same between MMR and MMRV. The V component of MMR The V component of MMRV is the same virus as in single antigen varicella, but it's at a higher potency. You can see there are 399 logs PFUs versus about 3.13. So it's about 7 times higher the amount of VZV in MMRV. But the viruses are identical between the two vaccines.
I want to remind everyone to please state your name before you speak. Thank you.
Dr. Levi?
Yeah, just as a follow-up question. So is there a biological or clinical reason for that different amount of antigen? Why when it's being given as part of the MMRV, you need more versus separate? When it's given separately, what is the rationale for that?
Yes, this is Dr. Mona Marin from NCIRD. The initial clinical trials done by the manufacturers had the same amount of V from the single antigen in the MMRV. And the antigenic response, the immunologic response to the V component was suboptimal. Therefore, manufacturers did several clinical trials with different potencies of VZV, and they ended up with this as the best in terms of immunogenic and adverse events. When this issue was discussed in 2008, 2009, the evidence seemed to lead to a potential interference between the measles virus and the varicella zoster virus when they are put in the same vaccine, in the same syringe. We have a stronger response, immunologic response to the measles virus, more fever, more measles-like rash. But we have the same immunologic response after the single antigen varicella vaccine. So that's the reason. It was based on obtaining similar immune response.
And what do we understand of the mechanisms that explains that? Like, I understand the outcomes that you describe. It seems that you observed some outcomes, but do we have a deep understanding of the biological mechanisms that can explain why we see different responses with different vaccines and different combinations?
Yes. There is a final answer if the manufacturer is on the line and can elaborate further.
I think the manufacturer is scheduled to talk later, so maybe they can respond then if they're not available now. Okay, so we'll hopefully get that answer later on. So we're going to continue.
Corey Meisner.
Yes, I know. So before we continue with the next, one more question. Okay.
Yeah. Could you clarify the evidence on immunogenicity after the first dose of MMR if the majority of children develop protective antibodies after that initial dose? What is the scientific basis for recommending a routine second dose? Is it mainly to address primary vaccine failure, waning immunity, or both? And in that context, is there consideration in using antibody titers to verify response after the first dose rather than universally giving a second dose?
Let me ask the CDC SME room if someone has an answer to that. Thank you.
Hi, this is Sarah Oliver with NCIRD. Happy to start, and then we may have another SME who can add. So I would say that antibody titers are one aspect of the protective response. We do know that you see higher antibody titers after 2 doses, and so that is a component of it. We know, especially for the measles component, that the second dose helps pick up the kids who did not have a protective response to that first dose. So 2 doses are recommended. That was what was studied in many of the efficacy studies. And we know that 2 doses provides that additional protection overall.
And do you have the percentages?
So if you want to pull up extra slide 15. That has the seropositivity rates, the percent fold, rise in titer, and the geometric fold for multiple doses for the Proclad, which is the MMRV, or you can see the MMR plus Veravax in the bottom of each of those groups is the separate vaccines.
Do you have any from the primary? This is after the second dose. Do you have any after the primary dose? The sero uptake?
Yes, sorry, slide 13. That is after the.
Pretty good uptake.
Thank you very much. Dr. Cody Meisner, I have you for 2 topics. So if you address the MMRV Q&A now, and then the other one about the roll call, we'll do a little bit later.
Thanks, Dr. Kuldorf, surely. I want to thank Dr. Serenovan, and I'm not pronouncing that correctly, but thank you for that overview. I wanted to add one comment in terms of the MMR component. And a lot of attention recently has been focused on the importance of the measles vaccine, but you also noted how important the rubella vaccine is. The last pandemic in the United States was in 1964 and 1965. And there were thousands of infections in pregnant women. And as you correctly pointed out, there were 11,000 fetal deaths and 20,000 infants who were born with congenital rubella syndrome. This is a devastating illness with congenital heart disease, retardation, eye problems. It's devastating. And then in 1969, Dr. Stanley Plotkin and his colleagues at the Wistar Institute developed the rubella vaccine. And that has been so effective. There are usually in recent years, fewer than 5 cases of congenital rubella a year in the United States. And those are primarily among women who were born in countries that do not administer the rubella vaccine. So I think it's important to focus on the absolute importance of making sure that every child is vaccinated against not only measles, mumps, and varicella, but also rubella. Thank you.
Thank you for that. And now Dr. Phyllis Arthur.
Thank you. No, actually, my question was answered. Thank you.
So thank you for that, and thank you for the excellent presentation and a good discussion. That's exactly what we want to have at these meetings. Before we go to the next presentation, I think we're going to do a roll call for missing persons to see if they have arrived late.
Thank you. American Academy of Pediatrics. American Geriatric Society. International Society for Travel Medicine. National Medical Association.
Hi, Ken Schmader for AGS.
Thank you. Society for Healthcare Epidemiology of America. Thank you.
And thank you for all of you. We are very grateful to have the vast majority of the liaison members here with us today. Dr. Cody Meissner.
Thank you, Dr. Kuldorf. I just wanted to express my appreciation for the societies that are particularly focused on infectious disease and vaccines. Dr. Goldman, Dr. Freihofer, Dr. Manoz, Dr. Paulson. It's so important that they're here. And as I said last time, I think it's a grave mistake for the American Academy of Pediatrics not to participate in these discussions. I think what the AAP is doing is moving themselves to irrelevance. And the importance of the AAP is going to wane if they refuse to participate in these conversations. Over.
Thank you very much. And now we're going to continue with the presentation on febrile seizures following MRV vaccine by Dr. John Su. So please.
Thank you. Excuse me. Are the slides being displayed on screen? Excellent. Thank you. Next slide, please. So the ACIP chair requested from the Immunization Safety Office a presentation on febrile seizures post-administration of MMRV versus simultaneous administration of separate MMR and varicella vaccines by two different age groups, 1 to 2 and 4 to 6 years old. Please use data both from randomized trials and from the Vaccine Safety Data Link, or VSD, presented from the VSD project. The next slide, please. So the material in the next few slides have been covered by Dr. Srinivasan, so I'll be brief. MMRV vaccine was licensed in the US in 2005. Interim recommendations in 2008 removed the preferential recommendation for MMRV, and updated recommendations were made in June 2009. Next slide, please. During February 2008 through June 2009, the MMRV Vaccine Safety Working Group reviewed multiple sources of data, including 2 post-licensure studies from Merck and VSD. Next slide, please. In brief, the 2009 updated MMRV recommendations included guidance stating that unless the parent or caregiver expresses a preference for the MMRV vaccine, MMR vaccine and varicella vaccine be administered for the first dose in children aged 12 to 47 months. MMRV vaccine remains generally preferred for the second dose. For more details on these recommendations, please see the May 2010 MMWR recommendations and reports. Next slide, please. The next few slides provide some background on the MMRV vaccine and on febrile seizures. Combination vaccines, like the MMRV vaccine, decrease the number of injections a child receives, increase vaccine compliance, and increase vaccine coverage rates. Currently, the MMRV vaccine is licensed for children 12 months through 12 years of age. The vaccine is routinely recommended for the following ages. First dose is recommended at ages 12 to 15 months. The second dose is recommended between the ages of 4 and 6 years. ProQuad is the MMRV vaccine product licensed for use in the United States. Next slide, please. Febrile seizures are defined as seizures that occur in febrile children or children with fever. By 5 years of age, 2 to 4% of children have had at least one febrile seizure. They occur primarily between the ages of 6 months and 5 years, with peak occurrence between the ages of 14 to 18 months. Like any seizure, febrile seizures are distressing and can be worrying. However, febrile seizures are typically short, lasting less than 15 minutes, and the majority resolve without complications. Febrile seizures occur most commonly with fevers caused by common childhood illnesses, such as middle ear infections, viral upper respiratory tract infections, and roseola. They can be associated with any condition that results in fever, including vaccination. Also, a family history of febrile seizures increases the risk of febrile seizures. Next slide, please. Pre-licensure studies of MMRV vaccine among children aged 12 to 23 months observed that fever and measles-like rash were reported at a significantly greater rate during 0 to 42 days following vaccination in children who received a first dose of MMRV vaccine than in children who received first doses of separate MMR vaccine and varicella vaccines at the same visit. Fever was observed in 21.5% of MMRV vaccine recipients compared to 14.9% of separate MMR vaccine and varicella vaccine recipients, with a risk difference of 6.6% and a 95% confidence interval between 4.6% and 8.5%. In light of these findings, CDC and Merck initiated separate post-licensure studies to evaluate if an increased risk for febrile seizures might be associated with the first dose of MMRV vaccine. Next slide. The following slides describe findings from these post-licensure studies. Next slide. On this slide, post-vaccination interval is shown in the left column. The middle column shows data from a VSD study, and the right column shows data from a Merck-sponsored study. Almost all participants were aged 12 to 23 months. The studies were among different populations and used different methods, yet both found significant associations in the first 2 weeks after vaccination. The VSD, after review of medical records, confirmed an increased risk of febrile seizures during days 7 through 10 after MMRV vaccine compared to MMR plus varicella vaccines. The attributable risk was 4.3 per 10,000 doses administered. The Merck-sponsored study also observed an increased risk of febrile seizure during days 5 through 12 after MMRV vaccine, with an attributable risk of 3.8 per 10,000 doses administered. During the 0 to 30 days post-vaccination, the observed relative risk for the VSD study was 1.4 with a 95% confidence interval of 1.1 to 2.0. For the Merck-sponsored study, the relative risk was 1.1 with a non-significant confidence interval. Next slide, please. This slide shows outpatient visits in VSD for fever after vaccination among children aged 12 to 23 months during 2000 through 2008. The x-axis shows days after vaccination, and the y-axis shows the number of outpatient visits for fever per 100,000 doses of vaccine. The different colored lines represent the different vaccines. The chart shows that visits for fever increased after any measles-containing vaccine during days 7 to 10 after vaccination. The greatest increase occurred after MMRV vaccination. Temporal scan statistics revealed significant clustering during days 7 to 10 for all measles-containing vaccines, all with a p-value less than 0.001. There were no temporal clustering of fever visits after varicella vaccination alone. Next slide. This slide shows the same data, but for number of seizures after vaccination among children aged 12 to 23 months during 2000 through 2008. As with outpatient visits for fever after vaccination, seizures after any measles-containing vaccine peaked during days 7 to 10 after vaccination, with the most seizures after MMRV vaccination. Temporal scan statistics revealed that seizures clustered most significantly during days 8 to 10 after MMRV vaccination, with a relative risk of 7.6 and a p-value of 0.001, days 7 to 10 after MMR and varicella vaccination at the same visit, with a relative risk of 4.0 and a p-value of 0.001, and days 7 to 11 after MMR vaccination alone, excuse me, with a relative risk of 3.7 and a p-value of 0.001. No seizure peak or significant temporal clustering was observed after varicella vaccination alone. Next slide, please. When we examine the biomedical literature for post-licensure data on febrile seizures following MMR or varicella vaccination, one study identified a significant increased risk of febrile seizures during 8 to 14 days after vaccination as compared with unvaccinated children. The results suggested approximately one additional febrile seizure per 3,000 to 4,000 children vaccinated with MMR vaccine. No increased risk of febrile seizure among children aged 12 to 23 months after varicella vaccine was observed during the 0 to 30 days after vaccination. Next slide, please. A systematic review and a meta-analysis published in 2015 addressed risk of febrile seizure following MMRV vaccination and included studies that used Priorix Tetra MMRV vaccine or Proquad MMRV vaccine. The analysis included both clinical trials and post-marketing observations. Some studies included participants as young as 9 months of age. The clinical trial review and analysis showed no significant differences in incidence of febrile seizures between MMRV and MMR with or without varicella vaccine after any doses across multiple risk windows. Additionally, receipt of concomitant use of MMRV and other pediatric vaccines was not shown to be a significant predictor of febrile seizure. However, post-marketing review and analysis showed an approximate twofold increase in risk of seizure or febrile seizure during 7 to 10 days or 5 to 12 days after MMRV vaccination in children aged 10 to 24 months. Next slide, please. A Cochrane review of MMRV in children was published in 2021 and included analysis of risk of febrile seizure after MMRV vaccine compared to separate MMR and varicella vaccines. The analysis included 5 cohort studies, 4 of which addressed first dose vaccination only. Overall, there were significant findings of increased risk of febrile seizure in children receiving MMRV vaccine compared to separate MMR and varicella vaccines during the 0 to 42 days following vaccination and during the 7 to 10 days following vaccination. The review also analyzed the risk of febrile seizure after MMRV vaccine grouped by brand compared to separate MMR and varicella vaccines. Of the 5 cohort studies included in this analysis, 1 studied Priorix Tetra MMRV vaccine and included the study's original findings as well as post hoc explanatory analysis of results. The findings for risk of febrile seizure with Priorix tetra MMRV vaccine compared to separate MMR and varicella vaccines were not significant. The 4 other cohort studies in the analysis showed significantly increased risk after Pro-Quad MMRV vaccine compared to separate MMR and varicella vaccines during the 0 to 42 days following vaccination and 7 to 10 days following vaccination. Next slide, please. In summary, post-licensure studies, both in the United States and in Europe, have assessed febrile seizures in children aged 12 to 23 months who received the first dose of MMRV vaccine and compared to children who received separate dose 1 injections of MMR and varicella vaccines at the same visit. Despite using different methods, populations of children, and different formulations of MMRV, the studies show remarkably consistency in findings. Next slide, please. In conclusion, studies have identified an increased risk for febrile seizures following dose 1 of MMRV as compared with dose 1 of MMRV plus varicella only during the 1 to 2 weeks after vaccination. The risk of febrile seizures occurring during other periods after vaccination is similar between receipt of the first dose of MMRV and MMR plus varicella given on the same day. Next slide, please. And next slide, please. MMRV is licensed as a 2-dose series with routine recommendation for the second dose of MMRV vaccine between ages 4 to 6 years. The risk of febrile seizures is lower among children aged 4 to 6 years than among children aged 12 to 15 months. In the Merck pre-licensure trials, lower fever rates were observed among children aged 15 to 31 months receiving the second dose of MMRV compared to after the first dose of MMRV. Similar rates for fever were observed among children aged 4 to 6 years receiving second dose MMRV compared with second dose of MMR and varicella on the same visit. Next slide, please. In the Merck-sponsored studies, among children aged 4 to 6 years, no febrile seizures were observed in either comparison arm. Next slide. In a VSD post-licensure study, very few seizures were identified by ICD-9 codes in the electronic data after measles-containing vaccines, with no significant differences observed 7 to 10 days after MMRV, MMR plus varicella, or MMR alone, although rates were higher after MMRV. Next slide, please. Electronic medical record review of the 4 seizures occurring 7 to 10 days after MMRV revealed that 2 patients were diagnosed with afebrile seizures and 1 record was considered improbable as whether fever or an acute seizure had occurred was unclear. Thus, only 1 febrile seizure diagnosis was confirmed, and the absolute risk for febrile seizure 7 to 10 days after second dose of MMRV was 1 febrile seizure per 86,750 doses with a 95% confidence interval of 1 per, with an upper limit of 15,570, or 1.2 febrile seizures per 100,000 doses of MMRV. The upper limit of the 95% confidence interval indicates the risk 7 to 10 days after MMRV is no higher than 1 febrile seizure for approximately every 15,500 doses. Similarly, the risk of febrile seizures 7 to 10 days after MMR plus varicella is no higher than 1 febrile seizure for 18,282 doses of same-day separately administered MMR plus varicella. Next slide, please. The systematic review published in 2015 included analyses of the incidence of febrile seizure and risk following the second dose of MMRV vaccine. Data from pre-licensure studies showed no statistical differences in the incidence of febrile seizure in children receiving MMRV alone compared to children receiving MMRV vaccine and 1 or more other pediatric vaccines at the same visit. Similarly, there were no statistical differences in the incidence of febrile seizure in children receiving MMRV and one or more kinds of other pediatric vaccines at the same visit versus those who received one or more other pediatric vaccines without MMRV vaccine. The systematic review also addressed the post-licensure VSD study from the previous two slides, which concluded that MMRV and separate MMR and varicella vaccines were not associated with increased risk of febrile seizures among children aged 4 to 6 years. Next slide, please. In summary, among children aged 4 to 6 years, data do not suggest that children who receive dose 2 of MMRV have an increased risk of febrile seizures after vaccination compared with those who receive dose 2 as MMR plus varicella vaccination at the same visit. Next slide. So to conclude, there's a small increased risk for febrile seizures after first dose of MMR and MMRV vaccines. The risk is slightly higher with MMRV combination vaccine after the first dose. Studies have shown a small increased risk for febrile seizures during the 5 to 12 days after a child has received their first vaccination with MMR vaccine. Studies have not shown an increased risk for febrile seizures after the varicella vaccine. There is no increased risk of febrile seizures after vaccination with MMRV vaccine in children aged 4 through 6 years. Next slide, please. I appreciate the opportunity to present these data and be happy to answer any questions. Thank you.
Thank you, Dr. Super. Thank you, Dr. Super, for that very clear presentation. I have one question. So you mentioned vaccine coverage rates and that can be affected by whether you take one vaccine or another. And I think you can go maybe in both ways. In one way, children they don't like needles. So fewer needles might mean that it's more likely that they get vaccines. But also, if there's adverse reactions to vaccines, then that can create questions about vaccines, not only among the parents, but siblings or neighbors or cousins. So it seems to me that the aspect of vaccine coverage rate could actually go in either direction. So are there any studies that sort of shows, that quantifies these two things of what coverage could how it could be influenced by the number of needles versus seeing adverse reactions that then get talked about in the neighborhood? And if either of those is bigger than the other, are there any of those studies that sort of try to quantify what those two effects are, which ones is bigger?
So if I understand the question, Dr. Koldorf, you're asking if there's a correlation between vaccine coverage, use of combination vaccines, and occurrence of adverse events. For that, I believe that there may be some experts in the SME room who may be able to address coverage.
Let me ask the SME room, because I know we do have some data. I think, Dr. Koldorf, this might be helpful. There was a survey that was done on parents and providers to get some sense of some of these issues. I don't know if there's data addressing exactly what you're saying, but let me ask the SME room if we could have the backup slide on the survey that was done and any comments you have on this coverage issue. Thank you.
Hi, this is the MCIRD SME room. I don't know if we have data specifically addressing that question. What we do have some data from the National Immunization Survey. This was published in 2024, and this was the National Immunization Survey Child COVID module. It did ask parents to please think about all other routine vaccines, such as those for measles, polio, and tetanus. And then overall, how hesitant are you about those other vaccines for your child? And the results showed that only 14% of parents with children aged 6 months to 4 years expressed hesitancy about those other routine childhood vaccines.
So is that among the parents whose child had a febrile seizure, or what was the population there?
This was a random digit dial survey, so children, all comers, not specifically targeted towards parents whose children had a febrile seizure.
So my question is, if a child has a febrile seizure, so it's one of 2,000 who has a febrile seizures because of MMRV instead of MR plus V. So how does having the child having that febrile seizure, how does that affect the parents' willingness to give children subsequent vaccines for that child, or vaccinating the siblings, the younger siblings later on? Or how does it affect, because they're going to mention this to the neighbors or the people in the preschool or whatever, how does it affect sort of then their friends, the neighbors or friend circles, or their siblings' tendency to get vaccines, or their cousins or whatever? So that the fact that there was an unnecessary febrile seizure, how much that influenced the hesitancy or tendency for others around them, as well as their family, to get vaccinations, because that affects the coverage. It's not just the number of needles, that also affects the tendency to coverage of vaccines.
Yeah, thanks, Dr. Koldover. This is Sarah Oliver back in the NCRD SME room. If we could go back to the background slides from our presentation, it's a slide 27. From the background on MMRV presentation. So I would say we don't specifically have data from a survey where children had previously had febrile seizures. However, the work group in 2008-2009 that was discussing this, there was a survey specifically for parents. Yeah, slide 27. There we go. There was specifically a study among mothers who asked, where this question was asked. You can see that down there at the bottom, it said almost a third of mothers would be resistant. About a quarter were neutral, and around 40% would accept. So it really was a range across the board. What I would say is that when the work group discussed this previously, and what we know from vast experience with vaccine administration, is the best discussions about vaccination and risks and side effects occur between the pediatrician and the child and the parent. So what the decision was at the time was that the parent should have the choice and should have the option for MMR and varicella separately, or the MMRV. The risks were made known, and the recommendation from CDC was that the pediatrician include that in the discussion, but that the parents should have that discussion. So the pediatrician is the best one who would be able to understand that family and know the balance of benefits and risks for that specific child in that specific situation.
Thank you. No, I understand that we don't. Thank you. I understand that we don't have data, and that it's very hard to sort of quantify how much vaccine hesitancy would increase through these additional febrile seizures. So we have a few other comments. We have Dr. Cody Meissner first.
Thank you, Dr. Kuldorf, and thank you, Dr. Su, for your presentation. I will just add the perspective that this discussion is really a deja vu for me, because we had extensive discussions on this very topic 15 years ago, approximately. And it's one of the very few settings where the recommendations from ACIP differed from the recommendation from the American Academy of Pediatrics. That is, the ACIP felt that the doctor could administer an MMR plus a V. And it was interesting, the American Academy of Pediatrics did not express a preference for the 12 to 15-month-old dosing of these vaccines. The feeling was that, and I remember that someone did a calculation, and a pediatrician who had a busy pediatric practice would perhaps see one patient who had a febrile seizure after receiving MMRV at 12 to 15 months, rather than the two being separated. So first comment. Second comment, and Dr. Su and Dr. Oliver, correct me if I'm wrong, but I think of febrile seizures after just an MMR vaccine given at 12 to 15 months as about 1 per 3,000 doses. Am I correct on that? And so if one uses, instead of MMR plus V in 2 different arms, one administers MMRV in one arm, the risk of a febrile seizure is essentially increased by 2-fold. Is that a reasonable way to think about it? Thank you.
If we could see slide 13, please. So in this slide, previous studies have demonstrated that after MMR, there is observed additional risk of 1 per 3,000 to 4,000 children vaccinated. So when you say 2-fold increase in risk, that is correct, sir.
Right. And then the other point regarding an MMRV at 4 to 6 years of age is that, and I think you said this, that more than 95% of febrile seizures occur before 4 years of age. It's only a couple of percent that occur in children after 4 years of age due to any cause. Is that correct?
I would ask for the SME room to provide details, but I'd say that risk of febrile seizure after 5 years is rare.
Thank you.
Thank you, Dr. Retsev-Lawai.
Yeah, three quick thoughts. And so just to follow up on the first question by Dr. Koldruf, I would think that there should be data on this, right? Like we know which, it's probably documented in diagnosis, which children had the seizure, and we know what their future, what after that, what vaccines they took and when. So I think we can actually, we don't need service for that. We can just look on the data. And I guess that's also potentially can affect what we see in the second dose, because potentially there's a subset of children that is more sensitive to the immune response to these vaccines. And since they experience such an extreme response after the first dose, maybe they don't go to the second dose as quickly or not at all. So I just would caution the fact that we don't see after the second dose does not necessarily mean that there is no potential mechanism here, but potentially it's a kind of a survival bias thing. But maybe one thing that bothers me is that we are focusing on symptoms, and I'm not sure we have a good mechanistic understanding of what's going on here. It seems that on the face of it, it seems that there is one vaccine with higher level, higher dose, higher quantity of the antigen that seems to cause, at least for some of the children, a more extreme immune response. And we are measuring it through fever and seizure, but potentially there are other things that are going on. So my question is, did we ever test those children that had the seizure to see if they have a unique immune response with other biomarkers that just to try and understand the mechanism of what's going on here? Because from a safety perspective, I'm very concerned when we just focus on what we measure and we don't try to get to understand the biological mechanisms that are taking place here. And yeah, I know it's not easy, but it doesn't look like we are making any real effort to understand this.
I'd like to echo that, because children who are very young like this may have a heightened IL-1. IL-1 is the cytokine that causes fever. And so the question for the manufacturer and for those who study this is whether IL-1 or other cytokines were measured in the serum of these children who were febrile. And did they look at cytokine gene polymorphisms or other genetic predispositions to febrile responses, which then segues to your second concern, is that looking at downstream at the second dose, there may be a selection bias in eliminating those children, because most pediatricians, to the best of my knowledge, will not revaccinate somebody who's had a prior history of febrile seizures. So we may be looking at a selection bias in looking at the second dose. So the question then for the what we would have to consider as a recommendation is what to do with the child who has had a history of febrile seizures. How do we manage their vaccination schedule the second time around?
With regard to biological mechanisms,
Yeah, were IL-1 levels measured by Merck or any other investigators in looking at febrile seizures or the genetic makeup of these children?
I would defer to experts perhaps in the SME speaker room with regard to biological mechanisms.
And then the second question was to emphasize what Rithip said was, is there a selection bias then in looking at the incidence of febrile seizures for the second dose?
So we don't have to get a response to every comment here, so that's perfectly fine. I think that Dr. Lever's comment is excellent, that the data is there. If you wanted to look at if the effect of a febrile seizure in the child that affects either subsequent vaccination for that child or vaccination for the younger siblings. I don't think that has been done, but it's certainly the data exists if you wanted to do it. I think next on the list is Dr. Milhan.
Yes, thank you. I just wanted to remind everybody that a febrile seizure is diagnosed retrospectively. A seizure happening to a family for 15 minutes is an enormous long time for a child to seize. So just when we talk about these things, and do I see in my practice that if a family has had a febrile seizure, are they excited to get the next vaccine? No. Am I excited to give them the next vaccine? No. It opens my eyes. Do we know that a natural occurring fever from a viral that is brought on not through a vaccine has the exact same mechanism as a fever that comes upon by a vaccine that is for a virus that in rare cases causes encephalopathy? We know that increasing temperature decreases the seizure threshold in all people. Right? That's well known. Is there an additive from the measles vaccine decreasing the seizure threshold more? So I think that's a question that's reasonable to ask, but to your point, Dr. Koldorf, I think families are very concerned. I think there's an increased hesitancy through all families right now. And I think that that's what we're here to do, is try to give them the best risks, benefits of these things as we can. Do we know, have the febrile seizure children seen first dose? Do we have a long-term follow-up on all those kids?
The ask of us was to present data on risk of febrile seizure. I would have to go back and look at data with regard to longer-term outcomes.
Thank you. And next on the list is Dr. Stein.
Thank you. So I'm curious how the risks are communicated. Like, how is that actually done? Because I find it striking that a lot of this data you have existed before the guidelines, and so the guidelines were informed by those data. And then you also presented a lot of data that have been generated and published after those guidelines. And so I'm curious, since there is a parental choice here, how is that risk communicated to the guardians?
Ask if anyone in the SME room has the knowledge of that from the MMWR. Was there language in there on how to communicate, or has CDC produced documents on how to communicate? I'm not sure. I'm seeing if anybody knows.
Yeah, NCIRD SME room. We developed one-pagers for providers, how to talk to the parents. It was in a table format. These are the risks, these are the benefits, this is what it means. And we also, I think we developed a one-pager for parents to be aware of this increased risk with MMRV versus MMR plus V. Yes, we provided, call them communication materials to help pediatricians discuss this risk in a way that the parents would understand.
And this is Dr. Oliver. If we look at the usage data too, we know that 85% of the kids who are getting these vaccines are getting them separate at that first visit. So it's 15% kind of on average of kids that are getting MMRV at that first visit. Presumably after, again, the discussion with the pediatrician and the provider over kind of the risks and the benefits. Thanks.
Thank you. Next on the list is Dr. Griffin.
Thank you. Thank you for your presentation. There are studies that are suggesting lasting neurologic impacts in children. So I was wondering if there are any studies that the manufacturer or others are performing for children education performance.
You mean children after seizure?
After febrile seizure, I'm sorry, yes. And I have a comment afterwards.
Okay, I would again defer to experts within the SME room, please.
Hi, this is Julianne G. From the SME room. We are not doing any long-term safety studies, but if the manufacturers are available, they may want to comment on this.
And my comment to this would be, the product has been licensed since 2005. It would be helpful for parents to have that awareness or that reassurance that these studies are performed. A secondary question I would have is, are any of these studies tested against a true placebo, a saline placebo?
I'd have to get back to you on that one. There are most of the studies that I've seen are in comparison with MMRV versus MMR plus varicella separately. There were one or two studies where, well, I'll hold over there and I can get back to you with a firmer answer if desired.
It is difficult to decipher then the risk if we're comparing MMRV versus MMR plus V. Then does this not automatically hold us to a confounding factor? The retort to this typically is that it is unethical to hold a vaccine versus true placebo study because it's unethical, because the sentiment is that the vaccine is considered safe and effective. However, I think that is probably the most ethical thing to do in a day and age where parents are, through full informed dissent, not getting their children vaccinated. And I will share from a perspective, I have seen parents who have opted to not vaccinate their children be some of the most educated people I've spoken with, bringing in studies and showing their rationale for not vaccinating. And so in this day and age where we do have, I believe, a rising percentage of parents who are not vaccinating in an informed manner, I feel that it is ethical to invite those parents for such a study and say, okay, since you are making this informed choice, let's study this. So I think I would invite that idea to have a true placebo study. Thank you.
Let me ask the IRD SME room if they have a comment on on this issue. Thank you.
Yes, we'd like to add that a placebo study would be a randomized control trial. And in that case, you cannot, if you select only people who avoided vaccination or who expressed an interest to not being vaccinated, there may be confounders introduced. They may, the children, maybe they had some experience with adverse events. So you cannot select participants based on their willingness. They have to agree to be part of either the study group or the control group.
Yeah, the point of a randomized controlled trial is that they have the exact same likelihood of receiving the placebo or receiving the vaccine. So the families would have to consent to that. And I think at a time where we're seeing the highest measles cases we've seen in many years, it would be concerning to ask parents to risk the chance that they would receive a vaccine that would not end up protecting them from measles, mumps, rubella, or varicella disease.
Yes, thank you. I do appreciate that answer. I would push back that in today's day and age, parents are asking for more such studies, and even if it is in more observational studies of vaccinated versus unvaccinated, that the populace would welcome this.
Thank you. Just one comment. One way to do ethical vaccine trials with the placebo control is to randomize them to the timing of the vaccine. Different countries recommend the MMR vaccine at different age. So one could randomize it, for example, giving them at age 12 months versus giving them at age 18 months, for example. So one can do randomized placebo control trials in an ethical manner to also then, so that's possible. But we'll continue with the list here. Dr. Blackburn.
Yeah, so in reviewing the studies on MMRV or MMR plus V, I noticed that they were designed with both vaccines given on the same day. Could you explain the rationale for conducting the trials this way? Wouldn't simultaneous administration of the MMR plus V yield similar adverse results, similar febrile rates as the combination product MMRV? Whereas evaluating these vaccines when separated by at least 28 days might provide clear insight into differences in potential adverse reactions. Given that the typical pediatric visit schedule includes visits at 12, 15, 18, and 24 months, there would be opportunities to administer the vaccine separately. And was that considered in the study design?
I'll ask if anyone in the SME knows, if SME room knows if that was considered in the study design.
The studies were designed to compare MMRV with MMR plus V because MMRV is designed to replace two vaccines or two injections in one. So the comparison needed to be between the what if we give them separately, what if we give them in the same syringe. But there are some studies, I mean, the same studies looked at comparing with the MMR arm, with an MMR arm or with a V arm. But the bulk of the studies were comparing the two vaccination options to see if you give one injection, would you get the same immunogenicity? How would the adverse events be? For the vaccines, then you don't need a combination vaccine. You can give MMR at 12, you can give varicella at 15, but that would not be replaced by one injection. The children will still get two injections.
Thank you, Dr. Pemsworth.
I have a question and a comment related to the vaccine information statement for MMR, MMRV. Is there language in that statement that prior febrile seizure or seizure of any sort after vaccination is contraindicated? I'm not sure. I somehow don't think that it's a contraindication. This goes to the informed consent issue. Also, I noticed, and to what Dr. Pollack mentioned about selection bias in potentially what we're seeing, the data related to the second dose of MMRV at age 4 to 6 years of age. I noticed that the VSD data did note both febrile and afebrile seizures, although it was not statistically significant, but it kind of raises the question about non-significance, maybe because of selection bias. But also, I feel like we need to address the assumption, it sounds like, that febrile seizures are largely benign. I'm not sure what the clinical significance is of these seizures. what do we know about them? And this goes back to, should that end up being a contraindication to ever getting that vaccine again?
So with regard to the information statement, I would defer to the information statement, the information contained therein. If there's an SME on the line, perhaps someone could
There is.
indicate
Yeah.
if it's on there.
Go ahead. We have a comment, question on the vaccine information statement. Let me ask the IRD SME room to comment on that. Thank you.
Yes, we can report that the vaccine information statement for MMRV does contain a sentence that says, talk with your healthcare provider if you have a history of seizures or has a parent, brother, or sister with a history of seizures. Contraindications are set by FDA.
And also in the same VIS, under risks of a vaccine reaction, there is a bullet with a few sentences. Seizures, often associated with fever, can happen after MMRV vaccine. The risk of seizures is higher than after separate MMR and varicella when given as a first dose. And then your healthcare provider can advise you of the appropriate vaccines.
Thank you, Dr. Meissner.
Thank you. Thanks, Dr. Kuldorf. 2 points I'd like to make. First of all, febrile seizures occur in 3 to 5% of all children. They're common. And every pediatrician is experienced in febrile seizures. And we know that the prognosis is excellent. The major concern, as Dr. Kuldorf has pointed out, is the anxiety it generates in other family members. And that's entirely understandable. And it's a very frightening experience. But I think people are very comfortable in saying that a febrile seizure is not associated with any sort of impaired performance or neurocognitive development or school problems. It's I don't know if I can call it a frequent occurrence, but every pediatrician is quite familiar with febrile seizures. Number two, the issue I think we're discussing, it really comes down to, should parents get 2 doses or should they get 1 dose of these measles, mumps, and rubella and varicella? And the disadvantage of giving 2 doses, or as was suggested, separating the 2 doses, is that we know compliance falls. And the advantage of combination vaccines is that children and adults are more likely to complete the vaccine requirements if it's given as a single dose. So the second, and then the argument against giving MMRV at 12 to 15 months is that there is this very slight increase in febrile seizure activity. And I think the way it is currently stated by the ACIP in the MMWR is quite appropriate. If a parent is more concerned about a febrile seizure, she can have the vaccine administered in different arms. If she's not, if she's more concerned about reducing the number of immunizations by 1 dose, she can have the combination vaccine. And I think, as Dr. Oliver pointed out, about 85% of children are now receiving the a vaccine in each arm. And that's fine. I think, I mean, I'm not quite sure where we're going with this discussion. I think that the current wording is appropriate. Over.
Thank you. And Dr. Levy?
Yeah. So I guess I feel a little bit unease because it seems to me that we are making a lot of assumptions that we really understand what we are seeing. And I want to remind ourselves that we call a lot of the time, it turns out that we call different things the same just because we did not understand the underlying mechanisms that could be very different, but the way we measure them made us believe that we're actually seeing the same thing. So I think just building on the comment that we heard before, it's not clear to me that a seizure, febrile seizure that comes after a viral infection is the same as what we are seeing here. And I think we need to investigate that because if it's not, potentially our assumptions about the long-term and the short-term implications may not be true. So I think we need to adopt a little bit a safety approach that doesn't just limit ourselves to what we measure, but also recognize that what we measure is limited, and we need to try and understand the mechanisms. And I have to say, I'm listening to discussion, and my impression is that we don't really know what's going on, other than that the fact that a vaccine that has a higher level of antigen seems to cause more frequent events like this. So I would really encourage all the agencies that are responsible for this to really launch more investigations that include some measuring the kids that had seizures and following them long term. I don't think we can just stay with the mindset that safety of vaccines is limited to the 30 days, 40 days after vaccination. Because the essence of vaccines is actually to make long-term biological impact on our body and give us long-term immunity, which is the benefit. But if we assume that the benefit is long-term, I think we also need to consider the fact that some of the adverse impacts could also be long-term.
Can I answer, Dr. Ritzef?
Yeah.
And I thank you for that comment. I think it's a very well taken point, Ritzef. My response is that febrile seizures are pretty well defined. We know, for example, that a febrile seizure obviously occurs when a child, usually less than 5 years and usually less than 4 years of age, has a fever. It's a generalized seizure. That is, it doesn't involve one limb or another. We know that it lasts, or it's been defined as lasting less than 15 minutes, and usually they last just a few minutes. So they also do not recur within 24 hours as part of the definition. So we have a pretty reasonable definition of febrile seizures, and the vast majority of febrile seizures do not occur in association with vaccines, as we're saying. So just for one, I'm not sure putting limited resources into this activity will give us the greatest bang for the buck. I think that we're so familiar with, as a pediatrician for more than 30 years, we're so familiar with febrile seizures, and I think most pediatricians would say that the prognosis is excellent, apart from the emotional impact on the family. Over.
Thank you. We have time for two more persons, and then we're going to have to end so we can move forward to the statement from the vaccine manufacturer. So the next is Dr. Milhon.
Thank you. As someone, I'm not sure how many on this committee actually do an electronic medical record. I know that there's a lot of dependence on the ICD codes that are generated. And I've heard that some people consider if there isn't an ICD code generated on a certain condition of a child, then that didn't happen. I will tell you, as a practicing physician, the amount of time I can spend trying to look up ICD codes to make sure that every one of them is there and exactly the precise ICD code that the child has is often time prohibitive. I think that it's important that when we look at data, we look at clean data. And I think the cleanest way to have clean data is to have an ICD code that is febrile seizure temporally related to a vaccine. And then you have a febrile seizure that's not. If we're going to be looking retrospectively at ICD codes, I think this is very important, but I also encourage people who are not in clinical medicine, who are using ICD codes to generate research, that these are not perfect. These are not a perfect data set. So those are my thoughts.
Thank you. And the last now from Dr. Petsworth.
I just want to thank you, Dr. Meisner, for your comments and your clinical expertise on this. But I want to push back just a little bit and note that there is a study out there published in 2023, the long-term neurodevelopmental outcomes of febrile seizures and underlying mechanisms, that states both clinical and animal studies show that febrile seizures have detrimental effects on neurodevelopment that cause attention deficit hyperactivity disorder, increased susceptibility to epilepsy, hippocampal sclerosis, and cognitive decline during adulthood. However, the mechanisms of febrile seizures and developmental abnormalities and disease occurrence during adulthood have not been determined. So it goes on, but I think this is a topic that merits being put on the agenda at some point to evaluate as part of the safety work that we need to be paying attention to.
Thank you so much. And thank you for a very good discussion. And again, thank you for that presentation, Dr. Su. The next one is, I think we have a comment from the MMRV vaccine manufacturer. Are you on the line?
Yeah, can you hear me okay?
Yes.
Yeah, thank you.
Please go ahead.
Yeah, this is Rick Haupt. I'm the head of infectious disease and vaccines, medical and scientific affairs at Merck. And for the record, I'm a pediatrician and saw many children die from infectious diseases that included pneumococcal, Hib, and varicella. And now these are all vaccine preventable. I'd hate to go back in time to a period when we saw invasive diseases. ProQuad MMRV has been evaluated through well-designed, high-quality clinical trials and post-licensure effectiveness and safety. And those data have been shared with regulatory authorities, public health agencies, medical societies, and have been published in journals. This issue of febrile seizures, the slight increased risk after the first dose, was initially described by an observational study that we conducted with Kaiser in 2009. So this has been something that's been well described for 15 years now and has led to the current recommendations, which are that there is no risk for the second dose. So it's preferred to give MMRV for the second dose. But for the first dose, the preference is for separate MMR and varicella vaccination to be given. But the language allows for a provider and or family to select MMRV as the dose given in the first dose. As we've discussed this morning, that has led to about a 15% utilization, but the vast majority of children receive separate MMR and varicella at 1 year of age. It's important to note that evidence indicates, and major public health organizations and professional societies agree, that combination vaccines improve completion and on-time vaccination, leading to higher adherence and fewer delays in disease vaccination, or disease prevention, sorry. And recent CDC surveillance data reveal a troubling decline in kindergarten vaccination coverage, where rates for measles, mumps, and rubella, potentially serious and fatal diseases, have fallen below 95% threshold which is required to sustain measles herd immunity. Considering these trends, any policy decision that compromises the clarity or consistency of vaccination guidance for MMRV has the potential to further diminish public confidence. I think that's really important in your deliberations, and I thank you. I can go back and answer some of the questions that you may have had for us. The one point I would make is that there was one question about what do we understand about the immune response and why was there a higher amount of antigen for varicella that was put in MMRV. And it's important to note, the increased antigen was only for varicella. There was no change to the antigen content for MM or R in the combination vaccine. And it's essentially related to what was needed to demonstrate an appropriate immunological response to show non-inferiority of the immune response of MMRV compared to the separate MMR and V. And it's very likely that this relates to local interference of the antigens when they're given in the combination product. That's all from me. Thank you.
Thank you. I would like to make one correction to make sure that credit is given to where credit is due. The discovery that MMRV had an excess risk of febrile seizures compared to MMR was done here at the CDC. So it's the CDC that deserves the credit for finding that out. It was done through the Vaccine Safety Data Link and its rapid cycle analysis, where the CDC evaluates new vaccines with weekly data feeds. And it was detected, I think, after about 25,000 doses. So it was a very quick detection, and it shows the excellent work that people here at CDC and in this particular VSD is doing to monitor the safety of vaccine. Are there any other comments or questions on this presentation? Dr. Hibbelin.
A brief comment concerns that we are looking at a risk benefit of febrile seizures, which may or may not have long-term consequence, likely not, as compared to falling below a 90% coverage rate for herd immunity. And the consequences of that are devastating for pregnant women losing their babies, newborns dying, and having congenital rubella syndromes. And that it seems that we have to be very careful of driving this non-vaccination group below 90%. Appears we have to be very conscious that this may be driven by fear and may be driven by most people, the fact that most people don't think about, they think of vaccines being either good or evil. And either I should have my child vaccinated or not vaccinated. And they don't understand the discussion of the subtleties that we're going through. So if we make a major change in what has been a very vaccine campaign, I think we have to have a darn good reason as to why we're making that change from what Corey Meisner out and access. We had better have a very good reason as to why we'd change that advice.
Thank you. And I think we can move forward now to the proposed recommendations and a discussion of those. If we can get those proposed recommendations up on the screen, that would be great. I would like to stress that in this vote, we are not voting on any changes in what diseases children are vaccinated against, nor are we proposing any changes in the timing of these vaccines. So that's not part of the vote or discussions. One can have different views on that, but that's not part of what we're doing today. So the vote is on the pediatric vaccine schedule should be updated to reflect the following change. For measles, mumps, rubella, and varicella vaccines given before age 4 years, the combined MMRV vaccine is not recommended. And 2, children in this age group should receive separate measles, mumps, rubella vaccine, and varicella vaccines, MMR plus V. And again, we are neither voting on children above 4 to 6 years because we know that there's no difference in the risk of seizures among those older children. So this is the vote, the proposed vote. Do we have the discussion now then, before we do? Oh yeah, okay. But we have the discussion now of this, and we are voting not until the end of the day after public comments. Dr. Stein?
Could you clarify how this is different than the current recommendation? Because the 2009 recommendation sounds like the two separate shots.
So there's two main differences. One is that the current recommendation says that both are recommended with the preference for MMR plus V. The other one is that some children get a second dose before age 4. For example, if there's an outbreak, a child might get a dose at 7 months of age, but then they have to be, because it doesn't have the efficacy, so it has to be, then get a dose again at 12 or 15. So then that's the second dose. So they will also, so right now, so they will also change so that everybody who gets the dose, whether it's the first or the second dose, it will be not, MRE will not be recommended, whether it's first or second dose. Those are the two differences. Dr. Levi?
Yeah, so the way I think about it is, let's say that someone would guarantee us that the adherence would be the same. Let's just for the sake of discussion. It seems to me quite reasonable that most of us would think that the separate vaccines are better because there is some harm or adverse events that are being caused in access. I think some of us maybe feel more kind of comfortable that they know and they understand that it's just like a local impact of that event, and some of us are more concerned. But I suspect that if we would somehow be guaranteed that all things are equal between these two options, the adherence is the same, I think the choice would be clear. So that kind of brings to me, in my mind, the discussion to what extent we believe that two separate doses are going to have materialistic impact on adherence. And I'm not fully convinced which fact. We are all concerned on reduction in adherence to vaccines, but it's not clear to me that the fact that we see a reduction suggests that the reduction would come or would be affected by the fact that we separate these two vaccines for the first dose. In fact, I actually tend to believe more that safer and less adverse events are going to increase trust and adherence. So that, given that at the very best, I don't think we have good evidence either way, I would go with the option that seems to be safer, that also gives lower quantity of the antigen to the children. I think that that's something that makes sense to me.
Thank you, Dr. Petsworth.
I just want to clarify that currently 85% of the first dose is MMR plus V. So we're talking about 15% of vaccinations at 12 to 15 months is currently MMRV, correct? Okay.
Yes, that is correct. And I want to sort of give praise to the pediatricians because they have both options, but 85% is choosing to administer the MMR plus V because of the fewer seizures. And just an anecdotal thing, when my twins were vaccinated, I asked the nurse if it was the MMRV or the MMR plus V, and she said, "Oh, it's the MMR plus V because," and she gave us exactly the correct reasons for why that is the case, without knowing that I do vaccine stuff. So she knew her stuff, and of course the physician in the office knew his stuff. So I think we should praise the pediatricians and the nurses who are 85% are sort of trying to minimize these febrile seizures. I think we're actually a little bit ahead of schedule, so that's a good. Oh, okay, Dr. Meissner.
Thank you, Dr. Kuldorf. And let me make two comments here. First, I would like to go back to your statement, which I agree with, just to clarify that the recommendation to give measles, mumps, and rubella before 12 months of age is for young children who are traveling with their family to an endemic area and might get exposed to measles. And that should not be included as part of the two-dose series. That a child who gets an MMR before 12 months of age, as you correctly pointed out, still needs to get a second and a third dose. And but I just wanted to make sure that was clear to everybody. And I also want to point out that the MMRV vaccine, that is the tetravalent or quadrivalent vaccine, is not licensed before 12 months of age, and it's not licensed after 12 years of age. So it can only be used in that window. The second point is that I wanted to say is that just taking the other side of the first bullet here, what we're saying is we don't trust parents to make a decision. Some parents don't want to administer 2 doses of a vaccine if they can receive one and get the same degree of coverage. And I'm not sure, I mean, I prefer that families have the option to make a selection. And if we go with the first bullet here, that won't be an option. We know that most are getting, as we've said, 85% are getting the 2 doses. But if a parent wants to get a single dose, why are we taking away that option? Over.
Thank you, and Dr. Goldman.
Thank you so much. I will reiterate the question I asked at the last meeting. Are we going to have a thoroughly vetted evidence to recommend framework presentation that looks at all the harms, benefits, acceptability, feasibility with input from practicing clinicians and liaisons in order to make an informed decision? I would argue that this recommendation is going to create more confusion among the public. It does not involve the aspect of actual practicing clinicians and how we deal with vaccine hesitancy and how we talk to our patients. And also, when you make this recommendation, you now give license to insurance companies and the Vaccine for Children's program not to cover this vaccine. And finally, you are taking away the choice of parents to have informed consent and discussion with their physician on what they want to do for the health and benefit of their children. So I urge this committee not to change the recommendations if they truly want to give the power to the parents to decide what is best for their child and allow them to make the choice in consultation with their physicians. And if we are going to have these recommendations, I urge the committee to go back to the very well done evidence to recommend framework that we have been using for years to make sure all data is done transparently so we can have that debate and discussion that you requested at the beginning. Thank you, Mr. Chairman.
Thank you. And Dr. Hopkins?
My comment was very similar to Dr. Goldman. I will cede the time. Thank you.
Thank you. Dr. Middleman?
I would also like to echo Dr. Goldman's cogent comments. It is critically important that we present all available evidence to make these decisions in one coherent, scientifically vetted presentation so that all providers and patients can understand the full breadth of information. It's so important to talk about what the evidence shows versus what people may believe that is not necessarily supported by the evidence. Thank you.
Thank you for that. My personal view is that we had two very excellent and informative presentations by Dr. Srinivasan and Dr. Su, so I thank them for that very much. We will have one other short presentation from the VF.
So can follow-up question on this?
Okay, yeah.
I would be interested, really, truly, can you articulate what information is missing from that was not discussed or considered? Because it seems that you made very strong statement that suggests that there is information that is not being considered here. Are you disputing the evidence that there is increased fibrous seizures after the MMRV, or what is the additional data that you feel was not considered currently?
Well, if I may, it's more than just the data considered. It's also the clinical experience, the work groups, all the liaisons have been removed from the work groups. You do not have those subject matter experts with the real world experience to understand the implementation of these vaccines and the concerns of the patients. You don't have the voice of the patients we take care for. You're not looking at all of the aspects of how we evaluate vaccine implementation. You're looking at very small data points and misrepresenting how it works in the real world and how we take care of our patients. So no, this was not a thoroughly vetted discussion. I want to see how we implement it, how it's accepted by the population, what's the feasibility, what's the equity, what are the harms and benefits. You have not considered all of those aspects in this presentation. There's something to be said about physicians' real world experience with their patients.
Dr. Middleman?
Sorry, I had taken my hand down because Dr. Goldman was handling it beautifully, but I echo his comments. And we really need to see all of the data together with the vast breadth of scientific data that does not just include the few studies that were presented here.
So I just have to respond to that I trust the CDC staff that they brought all the relevant data to the question. I'm sure we can trust them. And I also look, and some of my colleagues, and I think that some of them are pediatric doctors and have experience in caring for patients. But if you will be able to articulate missing data, I think all of us will appreciate hearing about this. So thank you.
May I respond to that?
We'll have Dr. Hopkins first.
I certainly appreciate the data that was presented by our CDC colleagues as being thorough and informative, but we've not considered issues around equity. We've not considered issues around the implications of these decisions for our patients and for the practicing physicians who are carrying out these actions. Those missing elements in going through the full evidence to recommendations framework does not provide us a full opportunity to review all of those elements. Thank you.
Dr. Goldman?
Dr. Hopkins said it perfectly.
Okay, so thank you, and I'm glad we're having this discussion. We will now move forward to a short presentation by the VFC. I'm not sure who is presenting from. Okay, I think it's in the process here, so take your time. And if you give your name before you start the presentation, good, thank you. Okay, while we are waiting, we have another comment from JSHLAY. So if you can go ahead.
This is Dr. Schleif representing NACHO. I just want to bring up one comment that I think is important for the practicality of this recommendation. At that age of 12 months, the young children are getting a number of vaccines. So we're adding now an additional one. And some parents want to have fewer injections. We can be giving up to 7 vaccines at one time for a child. And so we want to make sure that we have informed consent about what the parent wants. And that's a very important consideration. For me on the front lines giving vaccines, that's very important when you have children that need so many at a certain time.
Dr. Stein?
So I pulled up the vaccine information sheet, and it does say that there is an increased risk of febrile fever and seizures after the combined shot versus the 2 separate shots. And I understand the epidemiologic concepts are really hard to explain to most people. I'm just wondering, and since we have the medical professionals on the line, like, how is that actually communicated? And is there sometimes, I'm very seriously curious, is there sometimes a rush? Like, is it hard when you have a line of patients coming in to clearly provide informed consent on that? Yeah, that's good too.
I think that you could hear from a doctor and we might say one thing. I think what would be fair is to ask the patients how many times they felt all the risks and benefits of any vaccine or medicine was given to them. When we gave them Bactrim, do we tell them the risk of Stevens-Johnson syndrome? Do we talk about all the different things about when we treated an illness we thought was probably virus but might have some viral activity? Do we tell them when we gave them amoxicillin they might get a rash from that if it's EBV? I think the people who really know this are the parents. And what I hear from the parents most of the time is, I didn't hear anything. I think that's honest. And I think if they were to say that we're doing the best we can for your child, this is the best thing. This is what's been recommended. This is the best thing. Okay, it's a busy practice. I think if we're honest about informed consent between physicians, PAs, extenders, pharmacists, I believe we are probably failing to meet the standard of true informed consent.
Thank you. We're going to try with the VFC. Do you have it ready to go?
Martin, can I
We'll
make
do that now? We'll go with the VFC right now. Thank you.
Good afternoon. My name is Jeannie Santoli. I'm going to walk you through the VFC resolution update. Next slide, please. So we're going to go through this, and everything that's shown in red font is the change from the resolution that's currently approved. Next slide. So the purpose of the resolution, of course, this is all new, and the purpose of the resolution is to update guidance on the use of combined measles, mumps, rubella, and varicella vaccine. Next slide. Because there's 3 types of vaccines in this resolution, there are 3 components. There's one for the measles, mumps, rubella, one for varicella, and one for the combined. So we're going to walk through these. There are no changes in the first 2 components of the resolution. Next slide. So this is the eligible groups for the MMR component. Next slide. This is the recommended schedule for the MMR component. Next slide. This is the dosage intervals and dosage. Next slide. This is the contraindications and precautions. Next slide. For the varicella component, the eligible groups, no changes. Next slide. For the recommended schedule and dosage intervals, no changes. Next slide. For the dosage, contraindications and precautions, no changes. Next slide. Now for the combined measles, mumps, rubella, and varicella component, the eligible groups would change. Children at least 4 years through 12 years. This had previously been 12 months on the lower end. Next slide. For the recommended schedule and dosage intervals, we will be removing a link to a previously approved recommendation. And the language that you see here is the language that was just voted upon. I'll give you a minute to look at it.
We didn't vote.
Oh, I'm sorry. I know, okay, I'm sorry. And you're not voting now. My apologies. It's the language you just discussed that for a potential vote. My apologies. Sorry. Next slide. And then for the dosage intervals, we're also removing a link to a previously published statement. There's no changes to the recommended dosage or the contraindications and precautions. Next slide. This final statement is included in the VFC resolutions in general, that things that are published after the fact within 6 months are incorporated by reference. There was a typo here, and it was 12 months and it was supposed to be 6 months. I was using this opportunity to correct that typo. And that concludes my presentation.
Thank you very much. And as is common, when we do vote, there will be 2 votes. First, 1 vote, and then there will be a vote on the VFC. So that's a sort of standard procedure that it does that, similar to what we did in the June meeting. So we have Dr. Griffin. We have a few more minutes before lunch break. So
Thank you. As far as practical experience is concerned, I'd like to echo comments of Dr. Mulhone. As a mother, it was often just commented as I came in with my children, it's time for their shots. And no additional description. VIS, the vaccine information statement, was given to me at times, not consistently every time, with the expectation, of course, that you read it when it's in hand, but not explained. I understand this may be a bias because I'm a physician. What could have been understood or expected that I understood this already. But I asked many of my patients and friends that are non-physician or not in the medical field, and they had a very similar experience almost across the board. And this is, of course, anecdotal. As far as the extra data, I believe everyone in this committee would be very open to extra data to review. And I will echo my earlier comments regarding, and I apologize if I misspoke, regarding a randomized controlled trial. I understand and know that, of course, the ethics behind the conduction of these trials. That is why I feel that we need to expand the studies that we look at and the raw data that we look at in our considerations, to that point of having more considerations, more experiences. All of these collated statistical analyses started from one anecdote. And that's how we look at these children, is individuals that then collectively have either rendered benefit or succumbed to risks. Thank you.
Thank you. We have time for two more before lunch. Dr. Schley?
Yes, I just wanted to comment. When I'm just going to speak in our clinic at the Public Health Institute, Denver Health. We run a large-scale immunization program. We give the VIS form beforehand. We go over it and then we vaccinate. So people have informed decision about vaccines. It is the requirement that the VIS is given prior to vaccination, and that's something that we follow. And I think local public health agencies throughout the country do the same thing. I can't comment on anecdotal information, but that is the requirement, and we try to uphold that.
Thank you. I'm going to correct myself. We will do two more from now. So Dr. Middleman.
Thank you so much for recognizing me. I just want to be really, I just want to make sure that people understand in the public that there is a breadth of data, many studies that address the process that used to take place, the evidence to recommendation process that the Advisory Committee on Immunization Practices specifically used to make sure people were aware of all elements of a public health discussion. A public health recommendation should never be based on anecdotal evidence because, as you all know, the physician has to worry about an individual patient, but public health providers have to worry about the health of the entire public. It's really important to make sure all elements of public health are considered, including the public health import of the disease, the risk and benefit of the intervention, the feasibility of the intervention, the acceptability of the intervention, and the cost-benefit ratio, as well as equity. I would urge the committee, I haven't heard any information about urgency related to this decision. I'm not sure why it has to be made today. I would urge the committee to follow the methodical process of an evidence to recommendation process before voting on something that affects the public health to this degree. Please do that for public confidence and in order to make sure the science is adequately and appropriately vetted. Thank you.
I guess I should apologize for that anecdotal thing about my twins when they got vaccinated. But I think we have had a very good discussion here, very science-based. We had excellent presentations from our CDC colleagues, and I think there's been an excellent discussion about a variety of aspects of these vaccines. So now the last person is Dr. Petsworth.
I just wanted to say that I do recognize that at the 12 to 14 month visit, I believe it was the liaison from NACHO mentioned that many vaccines are given. And so that is impressive in the sense that already 85% of pediatricians and parents are choosing the MMR plus the V separately. So there's that. The other question I have is sort of a technical one. The language that was posted for the vote, it says recommends. Does that doesn't mean though that the MMR-V that is licensed by FDA is prohibited from being given to certain patients? So I just want to make sure that the pediatrician or whomever would have the option of choosing to give a licensed product that do you know what I'm trying to ask? Yeah.
So this committee recommends or does not recommend. It is FDA who decides what can and cannot be used.
Right.
That is the case for all vaccines. Our vote does have consequences sometimes on insurance coverage, including from CMS. So that is a factor. But it is FDA always who decides what is allowed to be given and what's not allowed to be given. that is not redo recommendations. So thank you. So I think it's time for.
It might be useful to have our VFC colleague comment on how the ACIP recommendations impact the vaccines for children, because they pay for a large number of pediatric vaccines.
Please do.
Sure. Thank you. So actually, a recommendation that says something is not recommended means that it will not be covered by the VFC program for use in children. If there are ways to talk about individual-based decisions where you can actually have that coverage, but as it is written now, the VFC program, if the resolution that I shared that you will vote on later, I know you have not voted yet, actually would mean that VFC would not cover this vaccine, even if a parent chose that was what they wanted with their physician. And
yeah, that is the correct information. So thank you for saying that. From CMS, can you state your name?
Yes, Andrew Johnson with CMS. I would also further add that it would have coverage implications in the Medicaid and Children's Health Insurance Program, and could also have in individual and group markets have effect for either coverage overall under the first bullet category, or could have impacts for out-of-pocket copays, for example.
Thank you for that. And just to be clear that this is coverage for the MMRV vaccine. There will be no changes in the coverage for the MMR vaccine nor for the varicella vaccine. So they will be fully covered just as before. There will be no changes there.
That's correct. It would not have any on the second. There would be no implications there. Simply on the first.
Yeah, nothing, no implications either on the second dose. Correct. We're most of
on the second dose. You are correct, Mr. Chair.
So we do need the lunch soon because I think many of us are hungry. But Dr. Hebel.
So just to be clear, in the point for the proposed change that measles, mumps, and rubella vaccine given before 4 years of age is not recommended, that means that it would not be paid for.
in the Vaccines for Children program, it wouldn't be covered
It wouldn't be covered.
for children who are under 4 years of age.
Okay, so that implies that the parent's choice, unless they want to pay for it themselves, the parent's choice is taken away. If parents would choose to have one jab and one vaccination,
It would
for
not be
whatever
covered by the
reasons, if
VFC
they have
program.
hard time accessing
Mhm.
clinical care, if they understand the risks and benefits, that option is basically taken away from them in many.
Right, VFC would not cover
Okay,
the vaccine for
got it.
those children. Yes.
Okay.
Yes, sir.
So thank you, everybody, for this very interesting, thoughtful, deep, and spirited discussion. That's exactly what we want at this ACIP meeting. We will now break for lunch, and we are reconvening here at 5 minutes past 1 o'clock. So thank you very much, everybody.
That's an exotic experience of 2 or 3 families. Chosen consequence. You might be interested in something.
So how do we usually handle?
20 minutes. So got it. Awesome. Mark, you ready? Let's go and keep moving along. It's something.
Tracy, can you hear us online?
Loud and clear.
Do testing.
Oh, I just have to format the risk. Yeah, I was gonna do this section. Yeah. Are you going to bed? Need more snacks? You know. Let's go one home. Really. This.
Not too much. So before it.
But you've seen you in the basement. I'm Laura. What? Oh, nice to meet you. Jason. How you doing? I know, just come to you, Mr. McDonald. Like the singer?
What's up, nerd?
Not much. This is a.
You guys should mute your mic.
Huh?
Did you get them? No.
You get one?
No.
You want a firehouse oven?
I got a granola bar. Healthy. Yeah, and you got the comments of 2 comments. Okay.
Welcome, Lord.
Yeah, I.
As of like a week and a half.
Well, I'm really excited to. I heard this was I'm used to the basic news on like. Oh, no. In the room. Being this very brief. Yeah. I think it's. But your wires don't be on big, but I.
Yeah. It's just. Oh, thank you.
I don't know how they.
I hope that you all enjoyed your lunch break and that we will now continue with this meeting. So if you please sit down. That was a very nice and informative discussion about the MMRV vaccine. We're now going to do a different vaccine, a hepatitis B vaccine. There are many things that one could discuss about the hepatitis B vaccine, but what we have been assigned to do today is very specific, and that is one, we're only considering the birth dose of the hepatitis B vaccine, that is the one that's given within 24 hours of birth. And we only consider that for women who have tested negative for hepatitis B. So if a woman tests positive for hepatitis B, or if it's unknown, we are not considering any changes for that population. So that's not on our sort of what we have been assigned to do. We've only been assigned to evaluate the birth dose of hepatitis B if the mother has been tested and if she tested negative. So thank you very much for that. And we have two presentations. And the first one is from Dr. Adam Langer from CDC, who's going to presentation on hepatitis B birth dose vaccination. So please go ahead, Dr. Langer.
Did I not hit that? There we go. Good afternoon, everyone. I'm Dr. Adam Langer. I'm the Acting Principal Deputy Director for the National Center for HIV, Viral Hepatitis, STD, and TB Prevention. It's my pleasure to be here with you today to talk to you about the hepatitis B birth dose vaccination. To not have to say 5 or 6 words, I'll strung together all at once. I'm just going to call it the birth dose. Infection with hepatitis B virus, or HBV, causes the disease that we refer to as hepatitis B. In 2022, there were an estimated 254 million people living with the hepatitis B worldwide. Some HBV infections will clear with no long-term impact to health. However, many infections will progress to long-term or chronic hepatitis B infection. Chronic hepatitis B is incurable and can lead to severe liver disease, liver cancer, and death. Next slide, please. HBV can be transmitted to infants in several ways. I'll start with focusing on mother-to-child transmission, also referred to as perinatal transmission, and later get into household or community transmission. Without any medical intervention, up to 85% of infants born to women with hepatitis B will become infected. Risk of progression from acute to chronic hepatitis B is related to age. Children infected early in life are most likely to progress to chronic infection. About 90% of infants perinatally infected with HBV will develop chronic hepatitis B, and about 25% of people infected with HBV during childhood will die prematurely due to hepatitis B-related complications, including liver cirrhosis and liver cancer. However, what is less well understood is that perinatal transmission is not the only reason why the birth dose is important. And I'm going to cover those other reasons over the course of this presentation. One quick note for clarity. For the purposes of this presentation, when I use the term childhood, I'm referring to the first 10 years of life. Before any potential exposures to HBV from sexual contact or drug use that might occur during adolescence. And the term infant, as everyone knows, refers to the first year of life. Next slide, please. Up to 2.4 million persons are living with hepatitis B in the United States, half of which are unaware of their infection. About 70% of people with chronic hepatitis B in the US were born in countries with intermediate to high prevalence of hepatitis B and were predominantly infected at birth or during early childhood. Historically, hepatitis B was relatively common among children in the US. However, decades of evolving hepatitis B vaccination recommendations among infants and children have resulted in the bulk of reported cases now being reported among unvaccinated adults. In 2023, 14,400 acute hepatitis B cases were estimated to have occurred in the US, with the highest rates among adults aged 40 to 59 years. Next slide. While illness and death are obviously the most serious outcomes of chronic hepatitis B, there are also very high lifetime costs to individuals in the healthcare system. Nguyen and colleagues analyzed claims data during 2004 to 2015 for adults diagnosed with chronic hepatitis B. The amounts shown in the figure represent mean annual costs adjusted to 2015 dollars. The figures in the yellow box are adjusted to 2025 dollars. The estimated annual costs on a per person per year basis of treating one patient with hepatitis B in the US, adjusted to 2025 dollars, are up to nearly $94,000 for those with less severe disease, and up to nearly $325,000 for those requiring a liver transplant. Other cost data sources also tell us that more than $1 billion is spent on hepatitis B related hospitalizations in the US every year. Next slide. Two types of products are available for prevention or prophylaxis against perinatal HBV infection. The hepatitis B vaccine, which provides long-term protection against HBV infection and is recommended for both pre-exposure and post-exposure prophylaxis, and hepatitis B immune globulin, or HBIG, which provides temporary protection and is indicated only in certain post-exposure settings. Combined, hepatitis B vaccination and HBIG are highly efficacious in preventing mother-to-child transmission, preventing transmission in about 94% of children born to women with hepatitis B. Hepatitis B vaccination is the cornerstone of hepatitis B prevention and control And the sooner that the hepatitis B vaccine is provided after birth, the greater its effectiveness in preventing perinatal transmission. The table to the right side of the slide shows the results of several studies which have consistently found that the sooner that the birth dose is given, the more effective it is at preventing mother-to-child transmission. Next slide, please. The hepatitis B vaccine was the first vaccine to prevent infection with a cancer-causing virus and has been available in the U.S. for more than 40 years. 2 single-antigen hepatitis B recombinant vaccines are FDA approved for the vaccination of persons starting at birth. Recombavax HB, which was approved in 1986, and Engerix-B, which was approved in 1989. An extensive body of literature resulting from more than 40 years of use demonstrates that the hepatitis B vaccines are safe and effective in protecting infants from hepatitis B. Several Institute of Medicine reports, as well as the WHO's Global Advisory Committee on Vaccine Safety, have concluded that the hepatitis B vaccine is safe and effective. Additional safety information will be delivered later by my colleagues in the Immunization Safety Office. Next slide, please. Full hepatitis B vaccination is a multi-dose series, typically consisting of 3 doses with increasing seroprotection after each dose. The proportions of infants with protective antibody responses after each dose were obtained through a systematic review of 43 studies. Typically, antibody levels were measured 1 to 2 months after administration of each dose. Among healthy infants, 25% and 63% achieved protective levels of antibodies against hepatitis B surface antigen after the first and second dose, respectively. However, full protection is only achieved with the complete vaccine series. The 3-dose hepatitis B vaccine series produces a protective antibody response in 98% of healthy term infants and 95% of healthy infants overall. Seroprotection from vaccination lasts for decades. In one Alaska-based study, over 90% of participants were estimated to still have protective immunity for more than 30 years after vaccination. Next slide, please. Since 1988, universal hepatitis B screening by testing for the presence of the hepatitis B surface antigen has been recommended for all pregnant women in the first trimester of pregnancy, as has testing later in pregnancy for women who have risk behaviors that increase the risk of acquiring hepatitis B, as well as testing at delivery for women whose test result was unknown. While hepatitis B laboratory testing is a complex subject, for simplicity, I will refer to testing for hepatitis B surface antigen as just testing. Hepatitis B vaccination has been recommended at birth for all infants born to women with a positive test since 1984. It was further specified that it should be within 12 hours of birth in 1988. And among all infants born to women with unknown test results since 1991. Similarly, HBIG has been recommended to be administered within 12 hours of birth for all infants born to women with a positive test since 1984, and among infants weighing less than 2,000 grams born to women with unknown test results since 2018. Next slide, please. In 1991, the U.S. adopted a strategy for universal hepatitis B vaccination of all infants. The timing of the first dose of hepatitis B vaccination among infants born to test-negative women has evolved. In 1991, the recommendation indicated that it was preferred that the first dose be administered before the newborn was discharged from the hospital, but no later than 2 months of age. Beginning in 2005, the first dose was recommended to be administered at the birth hospital, and this was subsequently updated in 2018 to specify that the dose should be given within 24 hours of birth. Next slide, please. Universal birth dose provides a critical safety net for infants who may have unrecognized exposure to HBV infection during pregnancy or early childhood, which can result in catastrophic outcomes. Reasons for gaps in post-exposure prophylaxis among infants born to test positive or unknown mothers include lack of prenatal care, gaps in prenatal screening and testing, and administrative errors, including errors in interpreting the test results, all of which can lead to missed opportunities to intervene. As an example, one case report involved a pregnant woman who was test positive, but had results miscommunicated in the record, and as a result, her infant did not receive post-exposure prophylaxis. The infant later presented at 3 months of life with fulminant hepatitis, which unfortunately resulted in the death of the child. This was not a one-off event, unfortunately. The Immunization Action Coalition documented over 500 other HBV transmission events during 1999 to 2002, where appropriate post-exposure prophylaxis was not administered. Next slide, please. In the US, analyses of available data find that a range of about 12 to 16% of pregnant women receive inadequate or no prenatal care. A similar percentage are never tested for hepatitis B during pregnancy. Additionally, despite a robust national perinatal hepatitis B prevention program, the program is estimated to identify less than 1/2 of infants estimated to be born to test positive women each year, further highlighting the role of universal birth dose vaccination as a critical safety net against gaps in protections against perinatal HBV transmission. The figure on the right side of the slide compares modeled estimates of the number of infants who are born to HBV-infected mothers in the US each year during 2009 to 2017 to the number of such births that were actually reported to CDC's National Perinatal Hepatitis B Prevention Program. The dashed line between 2014 and 2015 represents a change in the modeling methodology. Next slide, please. As I mentioned earlier, birth dose vaccination provides protection to infants against perinatal transmission and acquiring infection in early childhood. This is a really critical point that is often overlooked in discussions of the birth dose. HBV transmission occurs through percutaneous or mucosal exposure to infectious blood or body fluids. The virus can remain viable for over 7 days on environmental surfaces at room temperature, and exposure to only a tiny microscopic amount of blood or fluid is enough for a child to be infected. Unvaccinated infants are at risk of HBV infection if they live with a person who has chronic hepatitis B, not necessarily their mother, if people come to visit their homes who have HBV infection, or if they go to daycare or other places where even minuscule amounts of infectious blood or fluids might be present. About half of people with HBV infection are unaware of their infection, so they could unknowingly expose infants that are in their care. There are many more ways that a child can become infected with HBV other than sexual or drug-related exposures. Prior to widespread implementation of birth dose vaccination, studies found that among certain groups of US-born children born to immigrant mothers with no evidence of HBV infection, 7 to 11% of those children tested positive. With no evidence of maternal infection, these infections had to be attributed to community or household exposures. The sooner that an infant starts the hepatitis B vaccine series, the sooner that the baby will be protected against these early childhood exposures. The current recommendation is to start the hepatitis B series on the very first day of life because there are important benefits even among infants born to test negative mothers, and there is no evidence that the risk of already rare adverse events is any greater among newborns than among older infants. Next slide, please. Next slide, please. Technical difficulty, please stand by. So we can go ahead and move to slide 13. Great. 3 decades of data-driven, evidence-based, evolving hepatitis B vaccination recommendations among newborns and infants have paralleled marked reductions in acute hepatitis B cases in the U.S. Following the 1991 recommendations, which included providing hepatitis B vaccination within 12 hours of birth for infants born to women with unknown test results, as well as introducing universal hepatitis B vaccination for all infants, the total reported number of acute hepatitis B cases in the U.S. dropped 69%, from 18,003 cases reported in 1991 to 5,494 cases reported in 2005. Further, following the 2005 recommendation specifying that the first dose of universal infant hepatitis B vaccination occur prior to hospital discharge, and the subsequent specification that it should occur within the first 24 hours of life, the reported number of acute hepatitis B cases fell an additional 60%, from 5,494 cases per year in 2005 to 2,214 cases in 2023, which is the most recently available year of data. Remember, though, that after adjusting for ascertainment and underreporting, the estimated true number of cases in 2023 was actually 14,400. Next slide, please. Potential risks of rescinding the universal hepatitis B recommendation include increased cases of perinatal HBV transmission that raises the lifetime risk of chronic liver disease, cirrhosis, hepatocellular carcinoma, fulminant infantile hepatitis, and liver transplant. Increased administrative complexity and failure points for providers and health systems. A lack of a safety net given gaps in access to prenatal care, HBV screening, and HBIG access. Disproportionate harm to patients who don't have insurance or have low healthcare engagement. Lower rates of hepatitis B childhood vaccine series completion. And higher lifetime healthcare costs from missed opportunities to prevent and eliminate hepatitis B. The potential benefit to rescinding the current recommendation is a potential reduction in the already rare cases of birth dose vaccination adverse effects. When they do occur, these adverse events tend to be mild. The worst adverse event you could imagine, anaphylaxis, has been very rarely reported at only 1.1 cases per 1 million vaccine doses administered. Next slide, please. Prior to this meeting, CDC was asked to address 4 specific questions today related to the hepatitis B birth dose. We will address the first 2 questions now, and my colleagues from the Immunization Safety Office will present data in response to the other 2 requests. The first request was to survey hepatitis B vaccination recommendations in developed countries with a focus on at what age is the first dose recommended for 1, children born to test positive mothers, and 2, all other children. Also, in these countries, what is the prevalence of HBV infection in pregnant women? Next slide, please. This map depicts the birth dose vaccination policies by country. The countries in green recommend hepatitis B vaccination at birth universally to all infants, regardless of the mother's hepatitis B status. The countries shown in the orange color recommend hepatitis B vaccination at birth only among infants born to mothers with HBV infection. The countries in yellow recommend birth dose universally, but only in select regions of the country, not the entire country. And the countries in red do not have a policy calling for the administration of a birth dose. There are 43 countries without a recommendation to administer a birth dose. With support from Gavi since 2024, many have either initiated introduction of the birth dose this year or expressed interest in introducing the birth dose in their immunization schedules in the next 3 to 5 years. Next slide, please. This slide shows hepatitis B vaccination policies and schedule in the 38 countries that were requested by ACIP, including the US. Among infants born to test-positive mothers, 36 countries, including the US, recommend the birth dose to be given at birth simultaneously with HBEG, either before discharge from the hospital or within 24 hours of birth. There are two exceptions, Ireland and Denmark, although both countries primarily do provide the vaccine within 24 hours of birth. For children born to test-negative mothers, 8 countries provide a universal birth dose vaccination to all children within 24 hours, following the same schedule as children born to test-positive mothers. Of the 38 countries assessed, 26% provide the birth dose only to infants born to test-positive women, but they do recommend universal infant hepatitis B vaccination to other infants at the ages shown on the slide. Canada's schedule differs by province. There are only 4 countries among the 38 that provide the birth dose only to infants born to test-positive women and also do not have universal infant hepatitis B vaccination. Those countries are Denmark, Finland, Iceland, and New Zealand. These countries are not included in that lower portion of the table for age of first dose for children born to test-negative women. Next slide, please. This slide presents the 2023, or the most recent public data estimates in the last 10 years, for prevalence of test positivity among pregnant women in the 38 requested countries. Birth dose vaccination policy is also depicted for each country. Prevalence estimates of hepatitis B among pregnant women were available in 20 countries. 9 countries had less than 0.5% prevalence among pregnant women, and all of them have selective birth dose vaccination policy, while 8 countries reported a prevalence ranging from 0.5 to 0.9%, and 3 countries reported a prevalence greater than 2% among pregnant women. There are no data available on the prevalence of hepatitis B in pregnant women in the US in the last 10 years. Only 6 of the 38 selected countries have national registries that can track hepatitis B screening among pregnant women and estimate prevalence on an annual basis. The other 32 countries, including the US, do not track the prevalence of hepatitis B during pregnancy on a regular basis. Next slide, please. Following on the information presented in the previous slide, which shows the lack of data on the prevalence of hepatitis B among pregnant women in most of the 38 selected countries, this slide shows the most recent available data, either from surveys or national databases that present the percentage of pregnant women who were tested. Of the 37 countries selected to compare to the US, only 19 had publicly available data on the percentage of pregnant women who had been screened for hepatitis B. The green bars show countries where the 2030 global hepatitis B elimination screening target of 90% or greater was met. In the US, it is estimated that 14% of pregnant women are not screened for hepatitis B. The US is one of 5 countries among the 38 not meeting the 2030 global screening target, and one of 3 countries, which are shown in the red text, that do not have universal health care coverage. In summary, most of these selected countries cannot track whether they are succeeding in preventing perinatal transmission of HPV. But unlike the US, they provide universal health care to all the population so that everyone has access to free prenatal care and vaccination services, leading to high screening rates among pregnant women and timely administration of hepatitis B vaccination and post-exposure prophylaxis. This is a critical difference between the US and the countries that allow for selective birth dose. As previously mentioned, one of the primary reasons for recommending universal birth dose in the US is to serve as a safety net for infants born to mothers with unknown test results. Also of note, to date, no country in the world has reverted from universal to selective birth dose recommendations. In fact, as mentioned earlier, several countries are working towards a universal birth dose recommendation. Next slide, please. The second question that was posed requested a systematic review of the results from randomized trials concerning the administration of the hepatitis B vaccine within 24 hours of birth. Next slide, please. The existing published systematic review search returned 833 studies, and the updated systematic review returned 1,390 studies. These were further assessed using the inclusion criteria that came with the request. 17 studies met the inclusion criteria, 7 from the previous existing systematic review, and 10 from the updated review. Next slide, please. This slide shows the Cochrane risk of bias judgment results stratified by domain across the 17 included studies. Across the individual domains, there was a high risk of overall bias, primarily due to the domains of randomization and measurement of outcomes. All studies were randomized, but it was not always specified in the study methods how exactly the randomization occurred. Similarly, for bias related to measurement of outcomes, limitations were likely assigned due to poor reporting regarding whether the study investigators were blinded to the study outcomes. As you know, unblinded investigators may potentially skew study results. Next slide, please. The 17 studies were categorized by intervention study type, including evaluating efficacy, timing of vaccination, product or formulation differences, dose and schedule, or HBIG co-intervention. Specified outcomes of interest, including seroprotection, efficacy, and safety outcomes, were evaluated within each category. Other intervention characteristics included the vaccine type administered, such as Engerix, Recombavax, or other hepatitis B vaccines, as well as the dose and schedule. Next slide, please. Beginning with 2 efficacy trials that evaluated seroprotection, the birth dose achieved high levels of seroprotection among infants born to women with hepatitis B, with infants who received the birth dose vaccine and HBIG having higher seroprotection versus vaccine alone. The comparative efficacy study on the bottom of the slide also shows high levels of seroprotection across both hepatitis B vaccines that were given at birth to infants born to test positive women. Next slide, please. In these 2 efficacy studies, that is efficacy at preventing pediatric HBV infection compared to infants who did not receive the intervention, among infants born to test positive women, we see up to a 94% reduction in transmission with birth dose vaccine alone, and up to 99% reduction when birth dose vaccine was paired with HBIG. Next slide, please. In the one efficacy studied in the group that examined adverse events, the birth dose resulted in few systemic adverse events, with most adverse events being characterized as a mild fever. Next slide, please. In the timing of vaccination study, hepatitis B vaccine was either given at birth, 2 months, or 6 months of age, compared to the comparison group who all started receiving the vaccine series at the end of the trial at 18 months of age. This trial was conducted among infants who were born to test negative women. This study showed high levels of seroprotection at 91%, with no significant difference in adverse events reported based on the timing of the first dose of vaccine. Next slide, please. Many of the return search results were product or formulation trials which compared different products and formulation to each other to demonstrate non-inferiority. Across the 7 product or formulation trials that reported seroprotection, high levels of seroprotection were demonstrated. For the 4 studies reporting efficacy, there was equivalent efficacy in the prevention of perinatal transmission between the intervention and comparison groups. And among the 5 studies that reported safety, There were few local or systemic adverse events among infants in either arm, which is shown here on these forest plots. Next slide, please. For the 4 dose and schedule trials, we assessed seroprotection among infants born to both test positive and test negative women. The studies demonstrate high seroprotection in the intervention and comparator arms, except for the Gorar study, which had the comparator arm as no birth dose at all. However, the Gorar study demonstrated 96% seroprotection in the intervention arm 8 weeks after the last dose of hepatitis B vaccination. Next slide, please. For the 2 dose and schedule trial studies that reported efficacy, efficacy was equally high among infants born to both test positive and test negative women. Next slide, please. For the 1 dose and schedule trial study reporting safety outcomes among infants born to both test positive and test negative women, there were very few local or systemic events reported and no difference in local or systemic adverse events between the intervention and the comparator arms. Next slide, please. The updated systematic review did not identify any new placebo-controlled trials assessing efficacy. Given that the efficacy of the hepatitis B vaccine was established in the 1980s, this is unsurprising as many scientists consider it to be unethical to withhold a proven safe and effective intervention simply to include a placebo group. There were also limited reporting outcomes for preterm, low birth weight, and extremely low birth weight infants, and there were no reported morbidity or mortality outcomes reported in the updated rapid systematic review. The studies were heterogeneous, and many of the studies were done before the wide application of the consort statement, which seeks to improve the reporting of randomized trials. The risk of bias was primarily due to the domains for randomization and outcome measurement. Although bias is always a concern, studies having a high risk of overall bias can still provide useful information, especially if the directionality of the outcome is consistent across studies and the magnitude of the effect is large. Next slide, please. So in conclusion, the body of evidence in the existing systematic review and the updated systematic review include outcomes in seroprotection, efficacy, and safety for birth dose series in infants born to test positive and test negative women. The CDC hepatitis program's interpretation of these data is that the birth dose induces high seroprotection, demonstrates efficacy, and is safe. These findings continue to support the comprehensive decision by the ACIP to recommend universal birth dose vaccination, first in 1991, and then further strengthen it in 2005 and 2018 as part of the nation's larger strategy toward hepatitis B elimination. I want to thank all of you for your attention and for your interest in the topic. We do have a number of CDC hepatitis B experts on the line, and we'd be happy to answer any questions you might have. Thank you.
Thank you very much for that presentation. And I think we have Dr. Griffin, please.
Thank you for your presentation. A question regarding your mention at the end regarding bias. Of the 17 studies that you had used, how many of them had declared a conflict of interest, I wonder?
I'm sorry, do you mind repeating the last part?
Of the 17 studies that you had cited in review of the study, how many of them had declared a conflict of interest?
I'm going to actually ask one of our experts on the line who helped to conduct the rapid systematic review to address that.
Yes, hi, I'm Melissa Yandak. To my knowledge, there was not reported conflicts of interest, but we will, I'll get back to you on that. I don't have that immediately available. Over.
Okay, I had looked at the 17 studies, and we don't, as an ACIP group, we don't have a open access, but what I could find, because I would like to share that in order, if you do not have journal access, to get access to any one study costs It can be anywhere between $45 to $60 each study. So when we're reviewing these matters, we can be looking at hundreds of studies that we'd like to review. So in particular, these 17 that were used here, just doing my own search, there were declarations of 8 out of the 17 conflicts of interest. The one that were specifically used that were in the study for adverse events, 5 out of the 8 had conflicts of interest that were declared. There could be more of them. The other 3 I was not able to assess. So this is a concern. This did include pharmaceutical conflict of interest where the pharmaceutical company funded the study and provided the vaccination. Just wanted to point that out. I appreciate in the study the tragic anecdotal report on slide 10 regarding the death. That was a tragic event from 1999. I am wondering, what is the death rate from hepatitis B from the time that the product the hepatitis B vaccination was approved, and what is it now in comparison?
I'm also going to ask one of the experts on the line to address that.
Was the person trying to respond muted, or we'll try again, or should we go to the next person? Okay, we'll go to the next person. Dr. Levi, please.
If I may, I apologize.
Okay, please.
If I may, per CDC numbers, death rates of hepatitis B, and I ask this question because, of course, it can vary depending on population assessments, U.S. population. If we're looking at it in 1991, there were 912 deaths. 1991 is when this product was approved, and then 2021, it was 1,740. Percentage rates would show that this is an increasing death rate despite adoption of the vaccine. Thank you.
May I just, I'll update the conflict of interest. My team's aware of 3 studies that reported conflict of interest, so correction to the record. Thank you.
And this is Carolyn Wester from the Division of Viral Hepatitis. And as Dr. Niendek said, we will look further into the question about the death rates. But I do want to point out, for surveillance purposes, death rates that are reportable are through the National Vital Statistics System. And there's been an evolution of reporting over the several decades that were just acknowledged from the beginning to the ending points.
Thank you. And now, Dr. Levi, please.
Thank you. Can you go back to the slide with the red curve that shows the incident rates over time of acute Hep B? Please, thank you.
13. I believe that was 13.
I think it's
13.
Number 3. Number this one. 13. Yes. Okay. Great. Thank you. So I'm looking at this, and we see the reduction, and I think I've seen a slide. I don't know if you have it at the back on the backup slides that break these cases into age groups. Do you have it in the backup slides that we can take a look at it, or maybe?
We do not have that in the backup slides right now, but we can certainly get it for you.
Sure. I think we can put it back, put it up. I think this is the slide that I. Sorry for the delay. So go to the next one. There's okay, great. So this is the break. I believe that this is the data that was provided to us as background here. I believe the data is breaking it out into age groups that I think are telling an interesting story, unless I misunderstand the graphs. So it does tell us that the introduction of vaccination of babies born to Hep B positive women had a significant impact on the decrease in of the cases. And you see that the bottom graph, the 0 to 19 is going down. However, after 2005, when the universal vaccination was on the day of birth was introduced, there is no more visible reduction in the lower ages. In fact, most of the reduction is coming from the older ages. And maybe I'm misreading that, but to me it says that this is a very, very important vaccine that should be given to the high-risk populations. And the high-risk population seems to be babies born to Hep B positive mothers and other populations that, drug addicts and other populations that are at high risk, that we should try and vaccinate them to prevent this horrible disease. But I'm not sure I see the impact of universal vaccination and definitely not on the day zero of life. In fact, I don't see even I don't even see where's the argument to vaccinate even younger children at all that live in a normal environment. So it will be good because you mentioned these other mechanisms of infections. Do we have even data? We have data that suggests that children are actually getting infected, assuming that they were not born to Hep B positive moms and live in kind of a normal environment, or even, I don't know at all. Because when you look on your own data, again, maybe I misunderstand the data that I see here in front of my eyes, but I'm not sure I see the case of why vaccinate every kid, every baby, regardless of the status of the mom, is so important. And I do see, by the way, that the vaccine is absolutely critical to those that are born to Hep B positive and other people that are at risk. Absolutely critical. Horrible disease. We need to prevent it. But I'm just not sure I see the data that suggests where is the benefit. Maybe I'm misreading this. So.
Thank you very much, Dr. Levy. I believe I heard two questions in there. One was, why are we seeing the declines in the older age groups as you move from left to right? And you don't see it so much in the younger age groups. And then there was the question about is there data around showing that people are being exposed through these community and household exposures. So the first one, I think what you're observing is the result of the birth cohort effect. So if you think about someone who was born in 1991 and who received vaccination at that point, in 2011, they would be 30 years old. And so they would not show up in the younger cohort. They would be in that third 30 to 39 cohort. And so as time goes on, the people who benefited from the change in policy at the very beginning of the policy are moving into different age groups.
Okay, so, but I'm just doing the math here. 2005 is when the universal started. So the youngest will be, based on your assumption, that we should still not see any impact of this, because these babies born after 2005 are not going to be in those higher level ages, right? Higher ages. So it seems to me that at best we can maybe be optimistic to hope that will have a tangible impact in the years to come. But I'm not sure we have currently data that suggests any meaningful impact of it. Again, maybe nobody knows what will be in the future, right? So,
Adam, could I add something?
We'll take it in order. So we'll put you on the list, Dr. Middleman. The next person is Dr. Stein.
Thank you. And so I have two questions. I'd like to re-ask one that Dr. Levy asked about the occurrence of hepatitis B in children born to mothers who are confirmed hepatitis B negative. Because in terms of incidence, I think that would be really helpful. And the second point I'd like to make, you did a really lovely job of pointing out, summarizing all those studies, all the clinical trials. And my recollection or the notes in front of me show that only 2 of them were specifically stratified out, children born to hepatitis B confirmed negative mothers, but they were both quote high bias, right? And you explained what that means, and I understand what that means. And so the question tied to my first one is, what is the data? How good are the data about incidence of hepatitis B in children born to hepatitis B confirmed negative mothers?
I'm going to go ahead and ask one of the experts on the line to address that.
Yeah, thank you, Melissa Yandak. Thanks for the question. So I think you're referring to slide 30 in the deck, looking at comparative efficacy on hepatitis B surface antigen negative moms in the dose and scheduling trials. And the risk ratio there demonstrates equivalence between the intervention and comparator arms for efficacy. So the high efficacy highlights that there was efficacy in both the intervention and the comparator arms. The randomized efficacy literature is primarily focused on Hep B surface antigen positive moms, where the effect size for the outcomes of interest, including seroprotection, efficacy, and safety, are measurable and actually have larger effect sizes. And infections of infants of Hep B surface hepatitis B surface antigen negative moms typically arise from missed or late maternal infection or early horizontal exposure from an infected household member or potentially a caregiver. So really, this is why there's always been a push around the universal birth dose policy to be this larger safety net to address these gaps. We did cover, I think, some information there about in one of the slides on the 7 to 11% prevalence rates around community or household spread in certain communities. And so this is why, again, going back to the recommendation for universal birth dose provides this critical safety net. And this is based on ongoing risks to infants in the window between birth and the eventual first dose. And I think also that the universal hep birth dose was put in place because after targeted risk-based vaccination strategies failed to prevent perinatal and early childhood transmission. And in fact, only 26% of people report a risk factor. So in fact, among reported cases for acute Hep B, 26% report an associated risk factor. So over from my side, thank you.
Thank you very much. And I'd actually put myself on the list. So I had 2 comments. One is, if we go to slide 18, what is the prevalence among women here? We can see that in Western Europe, it's less than 1%, and in some cases less than 0.5%. So the most important country, though, is the United States, and there was no information there. So I tried to figure it out from the previous slides. So if we can go to slide number 3. So since there was no data available for pregnant women, I figured the prevalence among pregnant women is probably approximately the same as the prevalence among the general population of women around ages 20 to 40. So we can see from this graph that the prevalence among people from between 20 and 40 is between 0.2% and 0.9%. But that's, so that would be an average of maybe about 0.6 or 0.5, 0.6%. Now, this is both men and women, and we know that the prevalence among men is higher than women. So I think women has about maybe 2/3 of the prevalence. So if we do for women, we will get to about 0.4 to 0.5% estimate. So that means that the US is actually among the lower compared to the Western European countries. So we should be proud of that we have fairly low rates and not because of CDC and many others. So congratulations. We can also see from this graph that we have the total infections are the orange, and then the blue ones are immigrant infections. So about 80% would be immigrant infection, while 20% would be US-born women. So if we then take what is the prevalence among US-born women, that will probably be less than 0.1%. So that's very, very low, which is very good. And of course, we don't, So I just wanted to sort of point out that in comparison to the European countries, which do not have a birth dose, because among the Western European countries, it was only Portugal that have a universal birth dose. But US, we're doing quite well. We have very low rates compared to even the Western European countries that do not have the universal birth dose. So that was one of my comments. My second comment is on slide 27. So obviously the concern here is about adverse events at the day of birth. And usually we sort of accept that vaccines later in life can sometimes give a fever or rash. I think we are all a little bit even more concerned about that at the first day of birth, if they have a fever or so on. So if we look at these adverse events, we have two groups here. One is the localized symptoms, where there were 5 among 178 in the vaccinated group. And in the systemic symptoms is 10 out of 178. And I asked CDC if there was an overlap, but they didn't know. So, but if we don't know if some of these 5 were also among the 10. And in the non-vaccinated group, it was 3 and 4. So if we do a simple statistical test here, if we pool these two groups, the localized and systemic, then we get a p-value of 0.054. So it's just borderline statistically significant. And of course, the sample size is very small here. The relative risk is about a little bit over 2. So it's clear that there are some adverse events, I think, or more adverse event for those who get their dose at birth. So I think that's one of the many considerations that we have to take when we make this vote later today. And I think there were more comments than questions. So
Can I ask a quick question about this? How long were these clinical trials? So the safety data comes from what is the surveillance time? Are we watching them for how long we are watching the babies? These results for what kind of monitoring time window?
I think these are short-term adverse events, but doing any of the doses, yeah.
What is short? Like 2 days, 3 days, 5 days, 1 week? What's short mean?
I think 5.
5 days? So what we can say that over the first 5 days, there may be higher adverse event, and beyond that we don't know basically because we never looked. Is that kind of the bottom line of?
If you would like, they can answer the question.
Okay, please, Adam, please.
The one of the SMEs on the line, I believe, has an answer to your question.
Yes, please, if you could go to the last slides, the extra slides, slide number 44 and slide number 45, please. You'll see both the sample size and the latest follow-up period in months. Most of the safety signals were done because this was after the first dose. We were asked to look after 24 hours. So, but the latest follow-up period is shown all the way to the end of the time period shown for each of the studies. Over.
And there is data about those longer periods of time that can be looked at. Like what the data? What is the overall comparison of the adverse events over the longer period of time?
This is as long as the study went.
Excuse me, I guess the question is if you're following someone up, what are you following them up for? What signals specifically were they looking for that might be a adverse reaction to a vaccine, which may now be confounded with an entire schedule? So I think that's the question, is if there's a 24-month follow-up period, what were their criteria? Was it hospitalizations? Was it additional fevers? Was it hepatitis? I guess that's the question I would have. Is that fair? Dr. Levy?
That's what I was trying to ask. Thank you for helping me clarifying the question.
Yes, if you could turn to slide 41 of the extra slides, and you'll see the time points used for these studies. So seroprotection reported the first time point immediately following the last dose in the series. Efficacy was the latest available time point with the ongoing intervention, and safety at birth was the closest time point immediately after the birth dose, as requested by the question. Thank you.
So it was for seroprotection, not side effect. Did I understand it correctly?
That's
The follow-up
correct.
period?
That's
Okay,
correct.
thank you.
Just to make sure that I understand, so there is no follow-up of side effects beyond the very few days after birth? I just want to know the fact. Thank you, if you can clarify this.
Yes, it was different across the studies, but I can get back to you on that. Thank you.
Appreciate it. Thank you.
Thank you so much. And we had on the list also CDC SME, if you wanted to make some comment, not just a question here, but
Thank you. This is Carolyn Wester from Division of Viral Hepatitis. I just wanted to respond to some of the comments or questions that were raised on slide 18 regarding seroprevalence in the US. And yes, first of all, in the context that was mentioned during this slide, there's not disease surveillance registry that would answer this question. However, there's a national survey, and NHANES, the National Health and Nutrition Examination Survey, and the 13 to 2018 data estimated that the national prevalence in the US was 0.3%. Now, there is concern that that may undercapture populations with the highest burden of hepatitis B in the US. However, sex-based stratification showed the same prevalence among both females and males in that survey, and also a similar rate among reproductive age adults aged 25 to 49 years. There was difference by country of birth, with US born 0.1% and non-US born 1.2%. And then there was a modeling study, basically, that estimated in 2015 about 0.5% prevalence, or 0.5% of the babes that were born in the US that year were born to Hep surface antigen positive women, of whom 40% were estimated to be US born and 58% were estimated to be among non-US born women over. And the last thing is just in the context of the age stratifications. And yes, absolutely, there's been a generational impact over the last 3 decades of these evolving recommendations among infants and children. The one thing I would say is that the infant vaccination recommendation, which was introduced in '91, actually was also for prior to discharge from the hospital. It did allow for up to 2 months of age, with a preference for administration prior to discharge from the birth hospital. Over.
Thank you very much, and I'm glad that my back of the envelope calculations were very similar to your much more precise calculations. So I appreciate that, and thank you for that information. So we now have Dr. Malone.
We had asked in the past for number needed to treat, and I was wondering if we have number needed to treat to prevent a case of hepatitis B in the child of a non-Hep B positive patient. Do we have that for domestic US population?
Again, I'll see whether or not the SMEs online might have that information.
Hi, it's Carolyn Wester again. No, thank you very much for that question. We do not have that data, but I think it raises a very important question that if there is a delay recommended in the first dose among infants born to test negative moms, that it'll be very important to have modeling data to estimate the potential harms given unrecognized potential exposures during childhood, during pregnancy or early childhood, as were outlined on slides 10, 11, and 12. Over.
So I'm really simple. I'm not as sophisticated with epidemiology as Retzif or Martin or many of the others here. But it seems to me to be able to have a reasonable assessment of risk benefit, we need to have more granular information about number needed to treat for the healthy, non-antigen positive mothers, children, as well as the risk assessment associated with this product, which, did I miss the risk analysis? Do we have a clear analysis here of potential adverse events associated with this and their incidence, these vaccines, as part of this presentation?
Again, this is Carolyn Wester. If you're asking if there's been a risk assessment of the new cases associated with delaying the current recommendation to 1 month of age, no, we do not have that data.
Does FDA have any information about this? I'm not trying to put you on the spot, but so is it okay to say no? So.
Yeah, so I'm here. This is Tracy Hogue. I'm glad you asked this question. This is a really good discussion, and I would just say that the initial clinical trial data that we have from the 1980s that are on the label, it did have really short-term follow-up, 4 and 5 days for the currently approved products, and I think, we can, in terms of comparing, giving it in terms of the safety risks, giving it when it's a newborn versus, not newborn, later in early childhood, we can't really do a direct comparison. I was glad to see all these studies listed. I would like to know sort of the studies that were presented by the CDC, how many applied to neonates, and also echo Dr. Levi's question about the follow-up in terms of safety data when the vaccine is given to newborns, and looking at risks of more long-term conditions and sort of what the data are there, especially when we're talking about population that is, infants that are born to mothers who are not positive for hepatitis B, sort of what the risk-benefit analysis there would be, and that we should have some humility and consider that we may not know all of the potential safety issues. And when it's a very low-risk situation for the infant, we really do need to have some robust safety data, and that should be considered, and long-term, to consider in a risk-benefit analysis.
Thank you, Dr. Hogue. And I think now we have Dr. Griffin.
Yes, thank you. I was going to address Dr. Stein. She was asking about safety, and I had read the CDC itself confirmed as early as 2020 that there were no cases of transmission of hepatitis B in a school setting, elementary, middle, or high school. So that's school setting. I was wondering in the presentation in slide 6, could you go back to that? Discussing that the IOM said safe and effective. I had read, what year is this from?
So there are multiple reports that stated that the vaccine was safe from 1994, 2002 through 2004, 2012, and 2013.
Okay. I had read in 2012, at least, the IOM Institute of Medicine had said a review of hepatitis B vaccine safety studies conducted by the IOM found that the evidence was inadequate to rule out the possibility that hepatitis B vaccination leads to more than 24 neurologic and autoimmune disorders. So perhaps this slide is from 2013, but I wonder how do we reconcile the phrase safe and effective with this statement from 2012?
Medicine, that you said?
Yes. I'm not sure who that question would be posed to.
This is Carolyn Wester from DVH again. So as Dr. Langer said, there are a number of IOM reports. Yes, the 2012 did say there was no evidence to accept or reject a causal relationship. On top of that, there's obviously extensive body of literature over the last 4 decades. And I think our colleagues in the Immunization Safety Office will be providing more data on this and in a better position to respond.
The next up is Dr. Hebron.
Yes. Great. We have a question before us to vote on whether or not regarding the age of 1 month of a child, and saying that potentially the question is the first dose of hepatitis B vaccine should not be given until the child is at least 1 month of age among mothers who are negative. I'm unclear if we've been presented with any safety or hazard data comparing before 1 month to after 1 month. And I'm wondering why 1 month was selected as our time point, and if there are data to help to inform us if there's greater risk of adverse effects before 1 month or after 1 month at all, let alone in negative mothers. Thank you.
In terms of the 1 month, I think that currently in the schedule, the second dose is recommended at 1 to 2 months old. So it would mean that the first dose will be at the same time maybe as the second dose or later. So that is, I think, a question there. But your other more important questions, I think it's better for somebody from CDC to answer.
Right. If we're voting on a question as to whether or not the first dose should not be given until the child is at least 1 month old, what is the data? Are there data saying that less than 1 month is somehow more adverse than older than 1 month?
Can I piggyback on that? Do we have any data on a gradient of adverse events as a function of age post-birth? Is that kind of what you're getting at?
Well, the question we're supposed to vote on,
I understand,
is 1 month.
Yeah.
So do we have comparative data on adverse effects before 1 month as compared to after 1 month?
Or 2 months or 5 months?
No,
That's why I say the gradient.
As 1 month.
I understand that's what's put towards us, but my point is only that feeding off of your key point, not only do we have data on the discrete time point of 1 month, saying that 1 month, if we had to select some point, 1 month is the one because there's a clear inflection in risk, or do we have some continuous risk that decreases over time? We don't know anything about any of that. Did that make sense to you, Retzev?
Don't we have a safety presentation next?
Yeah, maybe we can do that at the safety presentation.
Right.
And we move forward. We have 3 more. We have Dr. Petsworth now.
Well, I want to say that there are, and I'll bring this up again with the safety presentation about what the IOM concluded, but what I'm concerned about is on slide 11, where 12 to 16% of women not receiving prenatal care to the prenatal screening for Hep B. So am I to understand that these women actually give birth and we don't know the mother's Hep B status at the point at which the child is born? Because it seems to me that it ought to be possible to get a titer on the mother and the hospital, a Hep B titer within an hour or two. So is there any reason for any child to be born in the US and not know the mother's Hep B status? Because this has implications for the care that the infant needs beyond
So
just.
I can address that
So,
question.
yeah, so there's no reason why it shouldn't be close to 100%. The reason The test usually takes 1 to 3 days. So if the mother come in just before giving birth, you can't do the test before the birth because it takes 1 to 3 days.
But I was looking and it said that you can get a stat Hep B titer in 1 to 2 hours. Is that not true?
I can speak to this as an obstetrician gynecologist. You are correct. The screening test takes literally 30 minutes. Once it is spun, that takes 10 minutes. 30 minutes to run the test is what the laboratory managers tell me. And I had called several obstetricians across the nation. This is replicable. So in under 1 hour, the laboratory is getting the screening test, which is hepatitis surface antigen screening test. In the US, in the developed world, 98 to 99% of women develop in a hospital that has a laboratory. And in the US, most women have prenatal care. Now, the March of Dimes does report in 2023, there were 7% of women who did not have prenatal care. But I can tell you what happens is when a patient comes to deliver her baby, automatically they are assessed for what laboratory results they have. And if they do not have hepatitis B, then that is automatically tested. And we find the results same day, within hours.
Can I ask just a clarification question on this? So I'm imagining that there is an informed consent discussion with the mother whether to give the vaccine to the baby or not. So it seems that there should be by structure, if we are following informed consent, there should be an opportunity to test at that time. You can also test that mother, right? Am I missing something about the operationalization of how things are actually working on the ground, assuming that there is an informed consent discussion, which I assume there is, or should be at least?
Well, and to further explain the maternal experience, women are then typically stay on average at least 24 hours in the hospital for their postnatal care. So there is opportunity for us to detect and offer, and of course, then run confirmatory testing and provide either vaccination for the baby along with the immunoglobulin. So this does pose a very important question because to your earlier point of looking at the statistics, if we are better at immunizing the high-risk population, and that may be what is lowering our prevalence, then the bigger question is, are we asking our babies to solve an adult problem? Is that the ultimate question? Are we trying to lower the prevalence of hepatitis B in a high-risk population by vaccinating them on day one?
Dr. Langer?
So we actually did look into this question, and we talked with a number of laboratory experts, including the lead of our own laboratory here at CDC. And I think what you're describing with that 30-minute, 1 hour turnaround is an ideal response. So you are not necessarily accounting for the women who don't give birth in a hospital, and there are such women, as you know, of course, very well. There's the possibility that the laboratory is backed up and doesn't have the time to do a stat hepatitis B test. If the test is positive, you are supposed to do a confirmatory test, which does take longer. Yes, it is certainly possible that in an ideal situation where the laboratory is not backed up and the clinician thinks to order it and the woman gives birth in an acute care hospital and all of these things, that you could possibly get a test result back within the 12 hours that is recommended for vaccinating for a woman who is positive. Or you cannot have to worry about all of those different things that could go wrong, and you could simply give the vaccine because there is no data available that says that there is any harm that would come to a newborn compared to a 1-month-old infant. And also, even if you were to start at 1 month, I mean, we want the child to get the vaccination series anyway. So the only thing that we're discussing here is there some benefit or removal of harm that comes from waiting a month? And I have not seen any data that says that there is any benefit to the infant of waiting a month, but there are a number of potential harms to the infant of waiting a month.
So just to clarify, so in terms of the testing, and I'm certainly not the expert here, so there's first a very quick test, and if that quick test is negative, then it's negative. If it's positive, then it will take longer to confirm that it's positive.
That's my understanding, but let me call upon the experts online to make sure that I'm explaining it correctly.
And Dr. Griffin?
That is correct. The confirmatory test will take longer. But at this point, you've identified, and that's the whole purpose of screening. You have identified somebody who you may have that is at risk, and that allows for this window of counseling the patient and for informed consent.
Because in terms of this, what we're voting on today, we only need to know if the woman is negative. And that we know then within a few hours, but then.
Correct. And when I said hours,
Yeah.
I mean, you said you were correct. If in an ideal situation, it takes 30, 40 minutes. So accounting for the logistics that you mentioned, we're talking a few hours, definitely less than 1 day, during which time the patient is in the hospital.
But that's all we need to know for making the decision here, because we only need to know if they are negative. We don't need to know if they are positive and then if it was confirmed or not, because then if they are positive on that first test, we just assume that they are positive.
Correct.
So I think we're going to go with the list here. So we have Dr. Pollack.
Thank you. One of the data sets that I think was missing here, and as suggested by single center data in this country, that children who are not vaccinated in the perinatal period have, with a hazard ratio of 3, will not come back to be vaccinated later on if the mother and baby are discharged. And that particularly affects single mothers and women of low socioeconomic status, and those, persons of color, and also high-risk groups such as Alaskans, First Nations, and so on. So perhaps somebody at the CDC can tell us, for those children who are not vaccinated by birthday 1 or 2, infants say under 2,000 grams or who have other contraindications to be vaccinated, what is the follow-up data on the rate of recidivism of mothers who don't come back to have their children vaccinated? Because that will speak to the issue of when these children should be vaccinated.
And to answer the question, there is an association between receiving the birth dose vaccine and completing the rest of the series in a timely manner. One can sort of discuss whether or not that's because the parents are more or less likely to want to adhere to recommendations, but there is definitely an association that has been found. And the opposite, the inverse is true. If you don't give the vaccine, then that particular infant is less likely to receive it later.
Excuse me, isn't that confounded by the fact that some people might choose not to have their child vaccinated and then they wouldn't get later vaccines as well? Then that would be by choice, not because they weren't captured initially. I think that's a fair confounder of look at trying to assess motive for a parent.
And that's exactly what I was trying to say, is that no one is saying that there's some kind of causative effect of giving the first dose that causes the parents to come back for the second and third dose. It may well be that parents who are more likely to agree to receive the first dose parents who agree to receive the first dose at birth are more likely to want to finish the series. But the question was, is there an association? And the answer is yes.
We have a few more, and then we have to go to the safety presentation because that's very important. So Dr. Griffin.
I'll wait till the safety presentation. Thank you.
Thank you. I appreciate that. Dr. Milholm? Appreciate that. Dr. Levi?
A range of policies from 2 months to 11 to 12 years. And I'm wondering if studying if the different provinces pan out differently in terms of outcomes and incidents to see if there is any evidence that postponing the use of this vaccine to later ages is making any materialistic on children that were born to Hep B negative women. Is that making any visible impact on the incident of Hep B, because these provinces seems to actually deploy different policies. So it's interesting to compare.
Thank you. I'm just going to go forward here with, and we're not going to put any more people on the list, with Dr. Meissner.
Thank you, Dr. Kildorf. And I've been listening to this really interesting conversation, and I would just like to emphasize points that I think have already been made. But number one, I think we've learned with many vaccines that the more we try and define a target group to vaccinate, the less successful we are. And the optimal approach seems to be to have a standard recommendation, number one. Number two, it's very hard to identify, as we've seen, very hard to identify people who are most likely to be exposed and infected to hepatitis B, such as IV drug abusers or sex workers. You can't find them. Homeless people, you can't, it's hard to get them vaccinated. And next is the hepatitis B vaccine at birth and then subsequent 2 doses according to the immunization schedule is probably lifelong. Even though antibodies may wane and not be detectable, we know that there's cellular immunity and that when someone is exposed to hepatitis B, that person is likely to experience an anamnestic response and still will be protected from disease. So I think I think that you can make an argument for lifelong immunity. And then finally, the issue that's been raised, why would immunization at 2 months or 3 months, if we begin immunizing children at an older age group, I don't think there's any, I'm not aware of any data that suggest it's a safer vaccine, because this is an absolutely safe vaccine. The risk of a severe allergic reaction is probably 1 in a million, or perhaps even less. So why? I mean, I don't understand what the concern is by administering a vaccine dose, because when the vaccine was developed, as we heard, and you tried to identify high-risk groups, it doesn't work as well. So I'm not sure what we're gaining by avoiding that first dose within 12 to 24 hours of birth. Over.
Thank you, and Dr. Hebel.
Thank you. I wanted to be clear that many other people can infect the child besides the mother. Is that correct, that the virus holds on to surfaces and comes from many different people, not only the mother? Is that correct?
I actually don't think there is any documented data that that's actually happening, unless people are willing to share that. But I don't think I've read on any data that actually suggests that it's actually happening, that kids are being infected in those mechanisms. Maybe there is,
we
but
do.
I just did not see that data.
If you recall during the presentation, I discussed the study that was done among the US-born children of immigrant mothers who had a documented negative test at the time that the child was born, so you can rule out perinatal transmission. And yet 7 to 11% of those children later tested positive for hepatitis B surface antigen, which means that they got it at some point after birth. They did not get it from mom because mom is negative. They got it after birth, and they were certainly far too young to have a sexual exposure or a injection drug exposure. We do have data that proves that the virus can live on surfaces for at least 7 days on an indoor surface. So we do have data that says that it can happen and that it is likely to happen. Can I point to any one particular case and say, I guarantee you that I know exactly how this particular child was infected? No, I can't. But I can tell you that it didn't come from the mother, and it didn't come from injection drug use, and it didn't come from sexual contact. So that means that it had to have been some kind of casual contact.
But to be clear, those are percentages of cases can be attributable to those non-mom cases. That's not an incidence. That's not a raw, like, what is the actual count? I understand that's still really important, attributable risk is a really important metric, but it's not the same number that we're asking for.
Well, I'm not asking for a number. I'm asking for this information in order to answer our question. And the question divides mothers by being antigen negative or antigen positive, as if that was the only way that the child was going to get infected. And it said the question we're going to vote on is that the first dose of hepatitis B, if the mother is negative, the first dose should not be given until the child is at least 1 month old. Infants may receive the dose by decision-making processes, but this assumes implicitly that all the infections are coming from moms, whether they're positive or negative. And this is obviously not the case. So the most prudent thing would be to vaccinate and protect as many people as possible. And you can't decide on that simply by the mother's status. You would have to look at the entire household status, which is why I was asking.
Hence informed consent, speaking to the patient and asking them about what their risk factors are. That's part of our social intake,
But
social history intake.
if people can't know, if half the people don't know that they're hepatitis B positive, how can you get informed consent?
Agreed, but isn't this the
From
basis-
prevalence of exposure?
Isn't this the basis of medicine? Is interviewing the patient and us on the front lines being the boots on the ground that identify those risks. Dr. Meisner, I appreciate your bringing this up, is these groups are difficult to identify. So we, the physicians, boots on the ground, should be asking these questions, and then we should be documenting them in our sophisticated EMRs, electronic medical records, which can then be assessed by sophisticated AI technology.
Well, I wouldn't know how to ask a patient how many people in your family or the household are hepatitis B positive.
We should be asking.
Well, how are they going to know? If
they'll
nobody
say they don't.
knows, if 50% of people don't know that they're hepatitis B positive, you can ask all you want, and
Agreed.
nobody knows.
Well, we ought to start somewhere.
So, but if we're looking for lifelong universal protection from hepatitis B in a vaccine that has virtually no side effects, we'll assess that as we've been presented. We'll assess that, but why should we necessarily stratify then just by whether the mother is hepatitis B positive or negative, since there is obviously room for infection throughout the lifetime from many other sources?
We're going to go to the,
Martin, can I make one point here? This is Cody.
Okay.
Can I, I'm sorry. And you see, I think what people are forgetting is that medicine is not precise. You cannot, by asking, determine whether someone has a risk factor for hepatitis B. It's the same with HIV. You just can't do it. And I think the other point that we have also said is that testing the mother is not perfect. There will be situations where there are problems with transcription. There will be problems with the assay. There will be problems in differentiating hepatitis B surface antigen and surface antibody. I think that's already been clear in the discussion that we've had here. There's a big difference. When you talk about a hepatitis titer, I think you're talking about surface antigen. You're not talking about antibody. So we're dealing with humans, and nothing is going to be 100% in identifying people who are hepatitis B surface antigen positive when they deliver.
Dr. Colt.
So we are going to have to move forward to the next presentation, and then we'll continue the discussion after that, and we can bring up some of the same issues. So I would like to ask, I think it's Dr. Sue now, who will present on hepatitis B vaccine safety updates. So please, Dr. Sue.
Thank you. I actually have two presentations. The first one will be on birth dose vaccinations. So next slide, please. So CDC received the following request from the ACIP chair for safety data for hepatitis B administration within 24 hours of birth from CDC's vaccine safety data link and from FDA's biologics effectiveness and safety system. Include mild and serious adverse events, all-cause morbidity and mortality, short-term and long-term safety, both specific outcomes of predetermined concern, as well as results from data mining where large numbers of potential adverse events are evaluated, and both combined results and results stratified by sex. If some of these types of safety studies aren't available, please mention that. Next slide, please. To address the ACIP request, CDC performed a rapid systematic review of safety data on hepatitis B vaccination within 24 hours of birth. The key question for the systematic review was, what is the safety of the hepatitis B vaccine administered within the first 30 days of life? To ensure a broad search, the review included studies where vaccines were administered within the first 30 days of life, rather than just the first 24 hours. This search was performed on July 31st, 2025, using the PICO criteria listed in the table on this slide. Electronic databases searched included Medline, Embase, CIN, AHL, and Cochrane. Next slide, please. This slide outlines the inclusion and exclusion criteria for the rapid systematic review. Criteria for inclusion were newborn infants receiving a hepatitis B vaccine at birth, i.e. less than or 30 days old at dose 1, a randomized controlled trial, observational studies, case series of 10 or more patients, data from surveillance systems. Outcomes included safety, adverse events, serious adverse events, and side effects. Criteria for exclusion of studies were non-English language articles, animal studies, any population that did not receive hepatitis B vaccine at 30 days or less, a case series of less than 10 patients, clinical trial protocols, conference abstracts or posters, conference proceedings in the title or journal title, titles starting with a number or posters. Next slide, please. And next slide. So this search identified 1,916 studies, excluding duplicates yielded 1,907 studies. Screening of titles and abstracts excluded 1,678 studies that did not meet inclusion criteria. After full text review, another 158 studies were excluded because they did not meet inclusion criteria. Of the remaining 71 studies, 20 were of birth dose alone or included results stratified by birth dose. The following slide describes these 20 studies. Next slide, please. The study characteristics, including study design, vaccine manufacturer, if specified, and timing of vaccination, are listed in the table on this slide. Of the 20 studies identified, 5 defined birth dose as hepatitis B vaccine administered within 24 hours of birth, including 1 study conducted in the Vaccine Safety Data Link. 4 studies, including 1 from VSD, used other language to indicate that vaccination occurred shortly after birth, including given at birth, birth dose, and within 120 hours of birth. 1 study stated that 85% of infants received hepatitis B on date of birth, and none received the vaccine beyond 8 days of life. The remaining 11 studies allowed for vaccination during the entire first month of life and are not described further in this presentation. However, these studies were included in the systematic review that was provided to ACIP as briefing materials. Next slide, please. The next few slides describe evaluation of local reactions. 1 study evaluated pain after hepatitis B vaccination given within 24 hours of birth. In this randomized control trial, parents reported 7.7% of infants experienced pain with movement or pain with pressure within 5 days of vaccination. 3 studies evaluated pain after hepatitis B vaccination given at birth dose, or within 120 hours of birth. For simplicity, these studies will be referenced as within 0 to 5 days of birth for the remainder of this presentation. Pain or soreness within 4 days of vaccination was reported for less than 10% of newborns, with few reports of severe pain. Next slide, please. 1 study evaluated injection site redness or erythema after hepatitis B vaccination given within 24 hours of birth. In this randomized controlled trial, parents reported that no infants experienced redness or erythema within 5 days of vaccination. Among 3 studies in which hepatitis B vaccination occurred within 0 to 5 days of birth, redness or erythema was reported for 8 to 20% of infants within 4 days of vaccination. There were no severe reports. Next slide, please. 1 study evaluated injection site swelling after hepatitis B vaccination given within 24 hours of birth. In this randomized control trial, parents reported 7.7% of infants experienced swelling within 5 days of vaccination. Among 3 studies in which hepatitis B vaccine was given within 0 to 5 days of birth, swelling within 4 days of vaccination was reported for 0 to 4% of newborns. There were no severe reports. Next slide, please. 1 study evaluated any local reaction as a single outcome after hepatitis B vaccination given within 24 hours of birth. In this randomized control trial, parents reported 2.8% of infants experienced local reactions within the week of vaccination. Next slide. The following slides describe studies evaluating systemic reactions. 4 studies evaluated fever after hepatitis B vaccination was given within 24 hours of birth. 0 to 5.6% of newborns experienced fever after vaccination, ranging from during birth hospitalization to 21 days after birth. Among 3 studies in which hepatitis B vaccine was given within 0 to 5 days of birth, fever was within 4 days of vaccination was reported for 0 to 5.9% of newborns. Few reports were severe. Next slide, please. 1 study evaluated anorexia or decreased appetite after hepatitis B vaccination was given within 24 hours of birth. In this randomized control trial, parents reported no infants experienced anorexia or decreased appetite within 5 days of vaccination. Among the 3 studies in which hepatitis B vaccination occurred within 0 to 5 days of birth, anorexia, feeding issues, or decreased appetite within 4 days of vaccination was reported for 2.6 to 16.5% of newborns. Few reports were severe. Next slide, please. One study evaluated diarrhea or vomiting after hepatitis B vaccination given within 24 hours of birth. In this randomized control trial, parents reported no infants experienced diarrhea or vomiting within 5 days of vaccination. Among 2 studies in which hepatitis B vaccination occurred within 0 to 5 days of birth, diarrhea or vomiting within 3 days of vaccination was reported for 8.1 to 11.7% and 4.4 to 22.3% of infants, respectively. Next slide, please. One study evaluated irritability or fussiness after hepatitis B vaccination given within 24 hours of birth. In this randomized control trial, parents reported 11.5% of infants experienced irritability or fussiness within 5 days of vaccination. Among 3 studies in which hepatitis B vaccination occurred within 0 to 5 days of birth, irritability or fussiness or unusual crying within 4 days of vaccination was reported for 1.5 to 22.1% of infants. Few reports were severe. Next slide, please. One study evaluated irritability or fussiness after hepatitis B vaccination given within 24 hours of birth. In this randomized control trial, parents reported 11.5% of infants experienced irritability or fussiness within 5 days of vaccination. Among 3 studies in which hepatitis B vaccination occurred within 0 to 5 days of birth, irritability or fussiness or unusual crying within 4 days of vaccination was reported for 1.5 to 22.1% of infants. Few reports were severe. Next slide, please. No studies evaluated sleep disturbance. I believe, yes, sir, thank you. So no studies evaluated sleep disturbance among children who received hepatitis B vaccine within 24 hours of birth. Among 3 studies in which hepatitis B vaccination occurred within 0 to 5 days of birth, drowsiness or sleeping more within 4 days of vaccination was reported for 5.1 to 32.4% of infants, and restlessness or sleeping less within 3 days of vaccination was reported for 16.9 to 31.1% of infants. Few reports were severe. Next slide, please. One study evaluated allergic reactions after hepatitis B vaccination given within 24 hours of birth. In this VSD cohort study, there were no differences between vaccinated and unvaccinated newborns in the proportion of those who received care for an allergic reaction in the first 21 days of life. No studies evaluated allergic reaction or atopy for newborns who received hepatitis B vaccine within 0 to 5 days of birth. Next slide, please. One study evaluated infections after hepatitis B vaccination given within 24 hours of birth. In this VSD cohort study, newborns vaccinated against hepatitis B were less likely to be evaluated for possible sepsis and less likely to have a positive blood or cerebrospinal fluid, or CSF, culture. No studies evaluated infection for newborns who received hepatitis B vaccine within 0 to 5 days of birth. Next slide. 2 studies evaluated other adverse events or infections after hepatitis B vaccination given within 24 hours of birth. In a VSD cohort study, hepatitis B vaccination did not appear to affect risk of seizures or other neurological disorders. In a cohort of preterm infants identified in Australia's surveillance of adverse events following immunization in the community system, hepatitis B vaccination appeared to have a slight protective effect on bronchopulmonary dysplasia, or BPD. In one cohort study in which hepatitis B vaccination occurred within 0 to 5 days of birth, there was one report of a serious adverse event, a cough requiring hospitalization 37 days after vaccination, which was deemed unrelated to vaccination by study investigators. Next slide, please. One study evaluated all-cause mortality after hepatitis B vaccination given within 24 hours of birth. In a cohort of preterm infants identified in Australia's surveillance of adverse events following immunization in the community system, there were no differences in all-cause mortality within 3 months of life among preterm infants who received hepatitis B vaccine and those who did not. 2 studies evaluated mortality after hepatitis B vaccination given within 0 to 8 days after birth. In one randomized control trial, there were no deaths reported during the 7-month follow-up window of infants who received hepatitis B vaccine within 4 days of birth. The second study is a VSD cohort study and will be described in more detail on the following slide. So next slide, please. To assess the relative risk of neonatal death after hepatitis B vaccine vaccination, VSD performed this study, which included more than 350,000 live births in a birth cohort of infants born during 1993 through 1998 in the Southern and Northern California Kaiser Permanente health plans. All deaths that occurred in infants less than 29 days of age were identified, and study investigators conducted medical record review. Now I'll have to blow up my slide here just a little bit. Unexpected deaths were defined as those among deaths among extremely low birth weight neonates, death because of lethal congenital anomalies or other genetic conditions, death from multiple cardiac or multiple individually non-lethal conditions, potentially fatal conditions present at or within several hours of birth, such as neonatal sepsis or severe respiratory distress syndrome. Unexpected deaths were those that had no apparent pre-existing conditions. Hepatitis B birth dose vaccination was defined as vaccination within 29 days of birth. However, 85% were vaccinated on the day of birth, and none received vaccine beyond 8 days of life. The proportion of deaths among neonates who received hepatitis B virus vaccine at birth and neonates who did not were compared. There are 1,363 neonatal deaths identified during the study period. Among all deaths, only 5%, or 72 neonates who died, received hepatitis vaccine at birth. There are no significant difference in the proportion of expected or unexpected deaths, or deaths due to the sudden infant death syndrome, or SIDS, among newborns who received hepatitis B vaccine and those who did not. Next slide, please. Limitations for this rapid systematic review include the following. Limited studies were available on hepatitis B administration within 24 hours. Many studies evaluating the hepatitis B birth dose did not specify timing of administration. Studies used heterogeneous approaches to data collection, data analysis, and reporting, limiting the ability to conduct a meta-analysis. Also, studies that met the inclusion criteria of hepatitis B administration within 24 hours focused on short-term outcomes like reactogenicity after vaccination or mortality within 30 days of vaccination. Studies evaluating long-term outcomes after hepatitis B administration did not meet the inclusion criteria of vaccination within 24 hours of birth or at birth. Next slide, please. To summarize, the studies identified in this rapid systematic review of hepatitis B vaccine administered at birth did not identify an increased risk for allergic reaction, all-cause mortality, expected or unexpected deaths, deaths due to sudden infant death syndrome, seizures, or neurologic disease other than seizures. Compared to infants who did not receive hepatitis B vaccine birth dose, there was a reduction in risk of invasive diagnostic procedures and positive cultures and bronchopulmonary dysplasia among infants who received a hepatitis B birth dose. The results from studies evaluating reactogenicity within the week of vaccination varied by study. Next slide, please. This slide lists references, including studies where hepatitis B vaccine was administered within 24 hours of birth and within 0 to 8 days of birth. Next slide. This slide lists studies where hepatitis B vaccine was administered more than 8 days after birth and within the first month of life. Next slide. So that concludes my presentation on birth dose hepatitis B, and we can proceed to the next slide set on nonspecific effects following hepatitis B vaccination.
Yes, please move forward with the next presentation before we take questions and answers.
Yes, sir.
Yeah.
Or if you'd rather, we could do questions now.
No, I think we move forward.
Okay.
Thank you.
Thank you. Next slide, please. So the ACIP chair requested that the Immunization Safety Office present the results of the study by Garley and colleagues from 2004 titled Hepatitis B Vaccination Associated with Higher Female Than Male Mortality in Guinea-Bissau, an Observational Study. Next slide, please. This presentation will provide a brief review of nonspecific effects following vaccination, summarize the Garley 2004 paper, and then provide the results of a rapid systematic review of available evidence related to mortality following hepatitis B vaccination. Next slide, please. Nonspecific effects of vaccination are defined as effects of vaccines beyond protection against their target pathogen, which may be the result of changes in the immune system. They are distinct from adverse, cross-protective, or downstream indirect effects. Clinical manifestations of nonspecific effects include all-cause mortality, susceptibility to unrelated infections, and risk of allergic and autoimmune disease. Live attenuated and non-live vaccines may have different nonspecific effects. Next slide, please. So the following slide summarizes the Garley 2004 article. Next slide, please. Garley and colleagues noted that several studies have examined the nonspecific effects of vaccines on all-cause mortality. Few have examined a potential impact of hepatitis B vaccination on mortality. The objective of this study was to address if hepatitis B vaccine is associated with sex-specific differences in mortality. Next slide, please. The study was conducted within a trial of a 2-dose standard measles vaccine within the Bandim Health Project surveillance system in Guinea-Bissau. Birth cohorts from March 1994 through February 2000 were enrolled in this trial. Children born during March 1996 through February 1997 were eligible to receive hepatitis B vaccine given at 7.5, 9, and 10.5 months of age. Hepacin B, the hepatitis B vaccine used in this study, is a human plasma-derived vaccine and is not licensed for use in the United States. Next slide, please. 3 mortality comparisons were performed, as shown in the table on the slide. Across all birth cohorts, mortality among children aged 7.5 to 12 months was compared to mortality among children aged 1.5 to 7.5 months. Among children in the 2-dose measles vaccine trial eligible for hepatitis B vaccination, mortality was compared among children who did and did not receive hepatitis B vaccine. Among children in the 2-dose measles vaccine trial who received measles vaccine, the female to male mortality ratio was compared among children who did and did not receive hepatitis B vaccine. Next slide, please. The mortality rate ratio was 0.97, comparing hepatitis B virus vaccine unvaccinated cohorts aged 7.5 to 12 months and 1.5 to 7.5 months. The year in which most children received HBV at 7.5 months of age, the mortality rate ratio was 1.62 with a 95% confidence interval of 1.09 to 2.41, comparing 7.5 to 12 months to 1.5 to 7.5 month age groups. Among 5,441 children enrolled in the measles vaccine trial, the mortality rate ratio for children aged 7.5 to 12 months was 1.81 with a 95% confidence interval of 1.19 to 2.75, comparing HBV vaccinated to HBV unvaccinated children. Among 5,061 children who had received measles vaccine in the trial, when followed through 12 months of age, the female to male mortality rate ratio was 1.66 with a 95% confidence interval of 0.8 through 3.45 in the cohort who received both hepatitis B vaccine and measles vaccine. When followed through 24 months of age, the female to male mortality rate ratio was 2.2 with a 95% confidence interval of 1.07 through 4.54 among the cohort who received both HPV and measles vaccine, and 0.96 with a 95% confidence interval of 0.7 through 1.32 among the cohort who received only measles vaccine. Next slide, please. The authors concluded, using 3 different tests of the same intervention, that there were changes in the mortality pattern after the introduction of hepatitis B vaccine in a high mortality setting. They found a higher mortality between 7.5 and 12 months of age among children who received hepatitis B vaccine compared to children who did not receive hepatitis B vaccine within a 2-dose measles vaccine trial. This effect was observed to be stronger for females than for males. They conclude that hepatitis B vaccine may have sex differential nonspecific effects. Next slide, please. The authors noted limitations and implications for these analyses. These analyses were not planned when the trial was designed, so the study was not randomized, and an unbiased comparison of hepatitis B vaccinated to unvaccinated children during the same period could not be made. Hepatitis B vaccine was given at 7.5, 9, and 10.5 months in the study. Effects of hepatitis B vaccination may differ when given at birth or with other vaccines, such as BCG. Also, an increase in the female to male mortality ratio could also represent a reduction in male mortality. Next slide, please. For additional context, a rapid systematic review on the nonspecific effects after hepatitis B vaccination in children was performed. Next slide. The key question guiding this review was, what are the nonspecific effects of hepatitis B containing vaccines administered in childhood? Next slide, please. The rapid systematic review included studies published through August 20th, 2025, among infants and children through 6 years of age who received a hepatitis B vaccine either alone or as a combined vaccine with any or no comparator. Outcomes included nonspecific effects in any setting and across any time frame. Next slide, please. And next slide. Thank you. The inclusion and exclusion criteria shown here were used to identify relevant publications. Inclusion criteria included clinical trials, observational studies, surveillance reports, systematic reviews, infants, children less than or 6 years of age, hepatitis B vaccines, outcomes including any of the following, such as nonspecific effects, all-cause morbidity, all-cause mortality, non-targeted infection, allergic and atopic disease, autoimmune and immune-mediated disease, and malignancy. Exclusion criteria included case reports or case series, narrative reviews, animal studies, children older than 7 years of age, adults, other vaccines, or any other outcome. Next slide, please. Of 2,068 studies identified, keyword screening yielded 237 studies. Screening of title and abstracts further excluded 221 of these studies. Full text was retrieved for the remaining 16 studies. 8 were excluded upon review of the full text. The remaining 8 studies were included in the review. Next slide, please. Of these 8 studies, 4 evaluated hepatitis B vaccine and a pentavalent vaccine, and 4 studies evaluated monovalent hepatitis B vaccine. Among the 8 studies, 7 were cohort studies, and 1 was a nested case series. 6 studies were conducted in low and middle income countries, 2 were in high income countries. Among the 8 studies, 4 evaluated mortality, 5 evaluated sex differential mortality, and 1 evaluated another nonspecific effect. The following slides describe results from studies evaluating monovalent hepatitis B vaccination. Next slide, please. Among the 3 studies that evaluated mortality, 2 cohort studies in high-income countries showed no association between all-cause mortality and hepatitis B vaccination. 1 cohort study in a low to middle-income country observed an increased risk of all-cause mortality after hepatitis B vaccination. Next slide, please. Evidence is inconsistent about sex-specific mortality after receipt of hepatitis B vaccines in lower to middle income countries. 1 study observed both no difference and an increase in the female to male mortality ratio. 1 study suggested no difference in mortality by sex. Next slide, please. 1 cohort study evaluated cancer-related and cardiovascular-related mortality in a high-income country and found no difference or no effect of hepatitis B vaccines on these outcomes. Next slide, please. In conclusion, there are few studies to inform the nonspecific effects of hepatitis B vaccination. 2 cohort studies in high-income countries showed no association between all-cause mortality and hepatitis B vaccination. 1 cohort study in a low and middle-income country showed an increase in risk of all-cause mortality after hepatitis B vaccination. Evidence is inconsistent about sex-specific mortality after receipt of hepatitis B vaccines. Next slide, please. Nonspecific effects may be impacted by setting of vaccine administration and might be potentially influenced by different background mortality rates and infectious disease burden. Nonspecific effects may not be generalizable across immunization programs. Effects might also differ by vaccine product used. Hepacine is not licensed for use in the United States, and in the United States, hepatitis B vaccine is given earlier and often in combination with other routine vaccines. Also, biological, molecular, and immunologic mechanisms underlying nonspecific effects are not fully understood. In particular, the interval between vaccination and the onset of any nonspecific effect and how long that effect persists are uncertain. The duration of a vaccine's nonspecific effect may also be complicated by subsequent vaccine given. Next slide, please. For further reading, please see these references. Next slide. Thank you. And that concludes the presentation on nonspecific effects. So thank you, and I'll be happy to take questions.
Thank you, Dr. Su, for those 2 presentations, very informative. Before we go to the questions and answers, we're going to do the hepatitis B vaccine manufacturer statements. They're not very long, so we'll do those now before we do the Q&A. I think we have 2 manufacturers, no? Only 1?
Hi, it's Rick Haupt. Do you want me to go?
Yes, please state name and affiliation, please.
Yeah, sure. This is Rick Haupt again from Merck. As a reminder, I head up ID Vaccines Medical and Scientific Affairs. I would refer back to Dr. Langer's presentation that clearly defines the rationale and importance of routine newborn vaccination as a crucial public health strategy to prevent chronic viral hepatitis and its severe long-term consequences. The risk of developing chronic hepatitis B infection is strongly age-dependent, with up to 90% of infants infected at birth progressing to chronic infection, which can lead to chronic liver disease as well as liver cancer. This transmission may occur from an infected mother, as well as a result from close contact with an infected family member. In fact, the CDC has reported that 1 in 2 people are unaware that they are infected. Merck Recombavax HB was first approved in the US in 1986, and it's been a foundation of hepatitis B prevention with over 330 million doses distributed. As was presented, over the time period from 1990 to 2019, universal infant and childhood vaccination for hepatitis B resulted in a 99% decline in reported cases of acute hepatitis B among children, adolescents, and young adults under 19 years of age. Vaccines are our best defense against many serious diseases, and the scientific evidence supporting their use is clear. The reconsideration of the newborn hepatitis B vaccination on the established schedule poses a grave risk to health of children and to the public, which could lead to a resurgence of preventable infectious diseases. Thank you.
Thank you. And Dr. Ayman Shid from Sanofi?
Yes. Oh, can you hear me okay?
Yes.
Yes, okay. Yeah, Ayman Sheet. I head up the Medical Affairs Department at Sanofi Vaccines here in the US. So thank you, Dr. Koldorf and ACIP members for the opportunity to address the committee. Sanofi shares your commitment to prioritize public health and evidence-based medicine. Our top priority remains ensuring access and availability to safe and effective vaccines. The hepatitis B birth dose and vaccination early in life remain the most effective option for prevention of hepatitis infections in infants and children. Scientific evidence overwhelmingly supports the safety of hepatitis B vaccines, as well as combination vaccines that include hepatitis B. Before and after approval, these vaccines are continuously monitored by manufacturers as well as the public health agencies and regulators. In contemplating changes to the hepatitis B infant schedule or any changes to the vaccine schedule, impact on implementation is an important factor for consideration. Combination vaccines, for example, have the benefit of reducing the number of injections infants receive, improving workflow in healthcare provider offices, and limiting the opportunities for administration errors. If a change is made to the recommendation for one of the included vaccine components, the benefits afforded by the combination won't be realized. Providers would need to stock single antigen components in addition to combination products, which can pose challenges. These include ensuring adequate stock and supply at the provider level, storage and handling, administration, documentation, all of which are critical components that impact vaccine administration and safety. Delaying hepatitis B vaccine puts infants and children at risk of hepatitis B infection. Delays beyond the birth dose, that's been the center of the discussion today, so any delays beyond that birth dose, reduce options for families to choose combination vaccines that include hepatitis B and will cause significant supply disruptions for a year or longer as production of vaccines is adjusted given the long lead time required. These supply challenges would extend beyond combination vaccines to include standalone components like Hib and polio vaccines. In closing, we encourage ACIP to maintain current recommendations for hepatitis B vaccination so that infants continue to be protected early in life and high-risk infants don't fall through the cracks. Also, combination vaccines that include hepatitis B remain widely accessible, and parents continue to have the choice to protect their infants from vaccine-preventable disease. Thank you all for the opportunity to talk to you today and present these comments.
Thank you very much. We'll now go to questions and answers. We do have the obligation to first hear from ACIP members and ex officio members, but we also want to hear from the liaison members. So I would ask the ACIP members to speak at most once before we go to liaison members. So we do have a few members of the ACIP in the list, and then hopefully we can go back quickly to the liaison members. So first we have Dr. Griffin.
Thank you. Regarding the first presentation, I believe, how many of those studies were based on a thimerosal included, thimerosal containing vaccination?
If I may, I'll defer to people who performed the review in the SME speaker room.
Thank you for that question. This is Ann Haas in the Immunization Safety Office. I don't have the number on hand, but if you give us a few moments, we'll get it for you. Thank you.
Okay, sure. I just asked because we did not have a hepatitis B vaccine containing thimerosal since 2001. So I was wondering, I believe I counted at least about 5 or 6. So I was just wondering if there was a rationale for including those studies. I was wondering, those studies, were there any of the studies set and designed to have safety as the primary endpoint?
Sorry, could you repeat the question, please?
If any of the studies were designed to have safety as the primary endpoint? Because I see a lot of immunogenicity studies. I was wondering if safety was the primary endpoint for any of the studies.
I know that safety was part of the study. Whether it was the primary endpoint, I will defer to colleagues in the SME room, please.
This is Ann Haas again, Immunization Safety Office. There were several studies that evaluated safety as the primary endpoint and a number of randomized control trials that also included it.
Okay, do you know how many of those were?
I believe
And
there
it's,
there
ahead.
were 3 that were looking at safety as an outcome specifically.
Okay, 3 out of the 20. Okay. Would you mind going back to slide 23? And that was in the first presentation.
To clarify, that is 3 out of 9 studies that we were presented in these slides.
Okay, thank you. Is it possible to pull up slide 23 from the first presentation? I believe, yes, this summary slide, thank you. The commentary on bronchopulmonary dysplasia, I was wondering, I had found one article out of the set that was evaluated, Morgan et al. 2025. Is that the only study that was used to make this summary on bronchodysplasia, bronchopulmonary dysplasia?
That's correct.
Okay, thank you. My concern with this study is the authors declare 7 significant limitations, and this concerns me. I mean, I could go through all of the limitations, but 7 significant limitations sounds pretty significant to me. I will mention one is, the first one they mention is inability to control for confounding factors in several areas. The use of our secondary data did not allow for a data collection of other potentially confounding factors identified in the directed acyclic graph, including infections and the type of respiratory support administered. Second, and I'll quickly read this, clinician perception of the overall clinical stability of the newborn may affect the decision to vaccinate at birth, with newborn infants perceived as well as more unwell on their first day of life, particularly with those with bacteremia and respiratory support being less likely to receive the birth dose vaccine. If true, decisions to withhold vaccination could lead to an underestimation of the association and mask the increased risk of bronchopulmonary dysplasia as a result of birth dose HPV vaccination through confounding by indication. So I just wonder the rationale in using a study with these. This is one of 7 confounding factors, or 2 of 7, I'm sorry, limitations in the study. Do we have any other studies? I guess my question is, do we have any other studies that show this bronchopulmonary dysplasia finding?
Thank you for those questions. So this study was included because it met the criteria for the systematic review. There were no other studies identified in the systematic review that met the criteria that had bronchopulmonary dysplasia as the outcome.
Thank you. So now it's Dr. Pepsworth.
Thank you for that presentation. I wanted to start with slide 15. That was from the first presentation on studies evaluating systemic reactions, irritability, fussiness, or crying with rates of 22% of study participants. To my mind, that seems very high, particularly in light of the fact that they may be early symptoms of neurologic problems that will need to be followed up, and we don't have any sort of long-term follow-up data on the babies that had those symptoms, which brings me to wanting to comment on what has been said about the Institute of Medicine reports. And I just want to clarify exactly what the IOM did say. And there were 3 Institute of Medicine reports that have worked on hepatitis B over the years. The first one was in 1994. The last one was in 2012. I brought the chapter on Hep B in case anyone's interested. But the IOM, to my mind, in my opinion, did not conclude that hepatitis B vaccine was safe, as it has been said here. What the IOM did is they looked at a number of conditions. They provided assessments on the weight of epidemiologic evidence, mechanistic evidence, and causality conclusions for each of these conditions. The conclusions for encephalitis and encephalopathy, their conclusion was that the evidence is inadequate to accept or reject a causal relationship between hepatitis B vaccine and encephalitis. Conclusion number 8.2, evidence is inadequate to accept or reject a causal relationship between hepatitis B vaccine and encephalopathy. And in this report, if I counted correctly, I believe they looked at 26 different conditions, and this was the conclusion for at least 24 of them. The conditions they evaluated were encephalitis, encephalopathy, seizures, acute disseminated encephalomyelitis, transverse myelitis, optic neuritis, neuromyelitis optica, multiple sclerosis, onset in children and adults, relapse in children and adults, demyelinating events in children and adults, Guillain-Barré syndrome, chronic inflammatory disseminated polyneuropathy, and it goes on to list quite a few other conditions: lupus, vasculitis, polyneuritis nodosa, psoriatic arthritis, reactive arthritis, so on. So that is the IOM. So to me, that means that the answer is that they don't know whether hepatitis B vaccine is associated with these conditions or not. I want to mention 2 studies, and then I will stop talking. They're a subgroup of the infants that would be vaccinated prior to discharge are preterm infants. I didn't see this study on the list of papers that were evaluated, but it is a paper from 2024 on the safety of hepatitis B vaccines, monovalent, or as part of a combination in preterm infants, a systematic review. Their conclusion was, we found no publications investigating the timing of the birth dose of hepatitis B vaccine, and adverse events following immunization. Reporting was exclusively short-term, hours to days following administration. Research focusing on the safety of hepatitis B vaccine in preterm infants, specifically within 7 days of birth, is lacking, particularly regarding long-term morbidity risk. And on the question of biologic mechanism, I'd like to draw your attention to a study published in 2016, and this is in a mouse model. Neonatal hepatitis B vaccination impaired the behavior and neurogenesis of mice transiently and early early adulthood. The conclusion to the study is, the study demonstrates that early hepatitis B vaccination impairs the behavior, hippocampal LTP, and neurogenesis of mice in early adulthood, which has not been previously reported. One possible mechanism of these underlying effects is in the alterations in the brain neuroimmune milieu following the systemic Th2 bias. So the point is, I think that there are gaps in what we know and understand about the effects of hepatitis B, particularly on very young infants. And I think that the conclusion that we know that it is safe is perhaps premature.
Thank you, Dr. Pepsworth. Dr. Levi?
Yeah, just one.
The microphone.
One quick question. First, I think the Garley paper is really one of the most well done exploitation of what is called natural randomized experiment that nature is giving us an opportunity. But one of the results that I remember, I kind of read it a few times throughout my career, but one of the results that I remember from there is that 7.5 children that were vaccinated between 7.5 months and 12 months showed substantial, like almost 80% higher mortality rate compared to other cohorts. I think I haven't seen that result. Is that because we just focus on early stage? Trying to understand why it was not discussed.
I'm sorry, Dr. Levy. Is this in reference to the Garley paper?
Yes, this is on related to the presentation there. Yes.
Sorry, I'm reviewing my slides here.
Sure, maybe I missed that. It's fast, so I apologize in advance if I missed that. So,
while you review the slides, I think we can go to Dr. Milhouse.
A couple of things. I think it's good to declare biases, and I am an advocate for children. Okay. And to answer some people's questions, the neonatal period is a very sacred period, and interventions at those periods are very cautionary, and you do everything you can to avoid things in the neonatal period. Often because if things happen, then the events that we need to do to evaluate and possibly treat the child often are very invasive. And there's a very interesting handoff between Dr. Griffin and myself as she takes a pregnant woman through the birth of her baby, and then we transition care from her taking care of mom and baby to pediatrician taking care of baby. In that transition, we're watching for very many things very, very closely. And any change in the baby's behavior or fever take us down a completely different road of how we care for that baby. Okay? When we do anesthesia on a baby, within the first 6 weeks, or premature, all the risks are higher. Right? We do a surgery, all the risks are higher. So my bias is that public health often favors the patient as well, but it doesn't always favor the individual patient. And I think that when we make decisions on the most vulnerable, we have to have an abundance of caution. Okay. A basic question going back: have we looked at seroconversion numbers starting at, let's say, 2 months going forward? Because you look at if you start at newborn, the number was 26%. So I'm always looking at these things that we're doing to try to get to a population of 95%. But that is being put on children who might have already had a full seroconversion. And if we're looking only at antibodies, or have we started looking at T-cell immunity, which is often much more robust in the early ages than they are later ages. So that's my other thought in terms of sort of a big view of vaccines. Is it time for us to look at how many doses a child gets in view of what is their seroreactivity versus what we're trying to do to make sure the population gets to 95%? Because one is a public health and one is a personal discussion between a doctor and a patient. So when I think about these things, I think that I would be interested if that, do you guys have that number? How quickly children get to seroconversion? Not as a population, but as individuals?
I think the numbers were 25% after the first dose, 63% after the second dose, and 95, if I remember correctly.
And that's birth and then 1 or 2, and then at 6 months?
I would defer to our experts in the SME speaker room on that.
So I guess if we start at 2 and then go to 6, what's the seroconversion rate for the population if 2 doses starting at 2 and going to 6? Because what I'm asking is if we do things earlier, do we have to give more doses? And can we look at this creatively in other ways? I'm not trying to say not vaccinate kids. What I'm trying to say is, can I just decrease risk? Because everything that I inject into somebody has a risk. So is there any?
Well, that's a question regarding
seroconversion.
Correct, which is outside of the scope of vaccine safety, which is why I'm referring to the SME room.
All right, well, I'll just put that out there, hanging out there. The other thing I would like to say is I'd like to go back to that 23, page 23, regarding the summary of death. Page 23. Yeah, thank you. I think rather than trying to say that there's some positive effect of hepatitis B, I think what you would just say is that if kids are well, they're more likely to get vaccinated by the neonatal team or a pediatrician. And so what you do is you find that these kids are less sick, their lungs look much better, and you're less likely to do a sepsis workup on these kids. So I don't think this is I think this to me sounds just like you're selecting, this is purely selection, not a positive finding for hepatitis B.
There is a name to this. It's called healthy vaccine effect.
Yeah. So the other thing I would just like to mention about this is that sometimes when I find the outcomes here, I'm wondering what wasn't said. So I see no allergic reaction, all-cause mortality. What I wondered, did anyone need advanced care? Or was anyone coded?
Dr. Su?
I don't have that information in hand. I would defer to the investigators of the paper on that one.
Okay, thank you.
Thank you for that. And we'll move forward now to Dr. Blackburn.
Thanks. I had a question and comment. So can anyone enlighten me as to how we decided on the language to be 1 month versus 2 months, as is in the majority of other countries who recommend delaying for negative mothers?
I think it has to do with that the second dose is recommended in the US between 1 and 2 months.
Do we know who made this question?
I think I was involved in that. So there was a discussion between me and various people at CDC.
Well, it's a pretty definitive time point. Don't give a vaccine until 1 month has passed. So I think it's a proper investigation as to what is the thinking that developed that.
Well, I do have some a point that I guess could actually make the case for it. But when reviewing the safety data, I was more concerned about the fever and poor feeding. So clinically speaking, and from firsthand experience with one of my children, any fever in a newborn under 28 days is considered a medical emergency and usually prompts a full sepsis workup, spinal tap, hospitalization, empiric IV antibiotics. And so given that context, I think we should consider that as we're considering the risk and benefits. And then as being a mother who breastfed both of my children, the feeding and decreased appetite, I would just have concerns on, that early feeding is so essential to successful breastfeeding in the early days of life, that we just should consider that as well.
Well, I agree we should be concerned, and these might be indicators, but they might not be indicators. And we can't vote on speculation. We have to vote on where there's data of concrete harm or concrete benefit. I appreciate Dr. Pebsworth's view that irritability may or may not, in some cases, be an early indicator of neurological disturbances, but it may or may not be an indicator of further neurological difficulties. Then to extrapolate to an IOM study that discussed neurological difficulties, but also found that there was no evidence to make a causal link for or against neurological difficulties. We're going beyond data and we're turning into a discussion of speculation and possible clinical outcomes for which we have no data. And I just don't think we should make votes and determinations on possible clinical outcomes. We need data on real risks and benefits.
Thank you. And now to Dr. Meissner.
Thank you. I would, looks like my video is not working here. I'm not sure why, but
we can see you. So.
Oh, okay. That's all it counts. Couple of points here. Association or lack of association with bronchopulmonary BPD, bronchopulmonary dysplasia, has nothing to do with the hepatitis B vaccine. Remember, BPD occurs in preterm babies who are born typically more than 10 weeks early. They're less than 2 pounds, and they're often mechanically ventilated, and it's the barotrauma, or the trauma that's associated with mechanical ventilation that results in BPD. I mean, it's biologically implausible that the hepatitis B vaccine could have any relationship with that. So I wouldn't place too much concern there. Secondly, the Garley study that was cited, and Dr. Su, 2 excellent presentations, and thank you for such clarity. But did you say that was a human plasma-derived vaccine for hepatitis B? I think you did.
There we go. That was with regard to the Garley paper where that the hepatitis B vaccine was plasma derived.
Yes. So, and I'm not sure if everybody understands. Initially, the hepatitis B vaccine was made from the plasma of people who had chronic hepatitis B, and their plasma was inactivated either by heat or chemically, so that it was not infectious. And then they received a concentrate of that plasma. So that is very, very different than the hepatitis B vaccine that's used today in all the vaccines. It's the hepatitis B surface antigen that's used today is cloned in yeast, and it's a very, very clear, clean, well-defined vaccine. So I think the vaccine that was used in the Garley study was something completely different it was a different vaccine than what's used today. So I don't think we can place emphasis on that. And then finally, if we change the recommendation for a neonatal administration of a hepatitis
It's 4 o'clock.
what will happen is that we will increase the risk of harm based on no evidence of benefit, because there will be fewer children who will get the full hepatitis B vaccine series. The vaccine, if it's begun in the hospital, we know that at least the first dose is administered. And as people have asked, why would we pick 1 month? Well, why 2 months? I mean, there's no evidence that it's safer at a later time. It's an extremely safe vaccine, a very pure vaccine. So I think we will be creating new doubts in the mind of the public that are not justified. There is no evidence of harm from administering the neonatal vaccine that I've heard presented or that I'm aware of from my readings. So I would be concerned if we were to change the recommendation for that neonatal dose. Thank you.
Thank you. And Dr. Malone?
Press and hold.
I might just let you. There, now it works. It's got a temperament of its own. I completely agree with Cody that this BPD signal is pretty overtly artifactual. You seem, I must have misinterpreted your inference here. The paper, as I understand it, indicates a improvement in the risk of BPD, and that just cries out for a healthy vaccinee bias, reporting bias. I also concur with your point about the paper involving the historic hepatitis B vaccine, which was associated with a variety of adverse events that are historic. And I'm not going to talk about your third hypothesis. That's a kind of a almost a moral ethical issue, an opinion issue. What I didn't hear were the data on premature infant risks, and there's a number of euphemisms: immunogenicity, effectiveness, seroconversion. So can you kind of clarify what we understand? Because we're bundling preemies in with healthy, normal newborns in terms of this kind of blanket recommendation for dose at birth. So is there a difference in safety and effectiveness or immunogenicity or seroconversion between premature infants as a group and healthy, normal?
So I can speak to the safety aspects of that question. And to that effect, we were limited, the data are limited to those studies that met our inclusion criteria. So which of those addressed, I think that a few of them addressed adverse events during prematurity, but I'll defer to experts in the SME room who have further knowledge on that particular topic. And I would also defer to the SMEs with regard towards seroconversion in premature infants as well.
Thank you. This is Ann Hausen, the Immunization Safety Office. There was only one study that met the criteria for the systematic review that looked at premature infants, and that was the Morgan study that had the outcome of bronchopulmonary dysplasia. While I have you, we do have that answer for thimerosal-containing studies. There was only one study that specifically lists the use of a thimerosal-containing hepatitis B vaccine. Thank you.
So I think what I hear, please correct me, is that we have insufficient data to assess safety, immunogenicity, seroconversion in the premature infant. Is that fair?
So I just want to point out that in the current recommendation for newborns less than 2,000 grams, we actually, born to mothers who are negative, we actually say don't vaccinate them at birth. Wait.
So it's already not recommended.
It's already not recommended for infants less than 2,000 grams where the mother is test negative. We recommend that you wait until 1 month.
Thank you very much.
Thank you, Dr. Stein.
That 1 month gestational age or 1 month corrected?
I will actually ask the SME to address that, just because I don't actually know for certain. So
I think it's until at 1 month or until discharge from the neonatal unit to home.
That's correct, Dr. Meissner. Dr. Stein?
My question is actually about all this extensive data that you provided. It's in this big PDF with a lot of summaries of a lot of studies. And I don't want to mention the results because they might not be appropriate. Can you explain and so these are the summary of evidence, and it's a very detailed summary of every single study ever. Could you explain what is meant by low confidence?
If I may, I'll defer to the SMEs who performed that systematic review.
Thank you for that question. This is Ann Haas, an ISO. Each study included in this presentation was reviewed for risk of bias and grade using standardized tools used in systematic review. So these results did vary by study when it came to risk of bias, particularly by study design. We are happy to provide the details of that to the committee after the meeting.
And then just wanted to point out that there's a number of studies that show potential long-term risks, but again, as they're pointing out, that they there may be some bias in them, and without having read them all, I can't tell.
Thank you. This is Ann Haas again. There are a number of studies that do examine longer-term outcomes in our greater systematic review. However, they were not included in this presentation because they did not include the hepatitis B birth dose that was given within the first 24 hours of life, which was the request of ACIP. Again, we're happy to provide those studies. Thank you.
Thank you. And we're now going to go to the liaison members. I want to thank for your patience and apologize that it took some time to get there. So please, Dr. Middleman.
Thank you so much for recognizing us. I have two questions. The first question is really a question that some of your voting members have actually asked as well. I'm wondering what problem exists in the current schedule that has prompted this entire discussion. It's been a fascinating discussion. Drs. Langer and Sue have done such a lovely job of presenting the evidence. We all know, I think, that there are always some risks and benefits, and we vet those risks and benefits and compare them. We have an immunization schedule for hepatitis B that has proven to be incredibly successful. We know risk-based approaches for vaccination have historically not worked with multiple different vaccines and vaccine approaches. And we're now at a great space with Hep B vaccination rates with a benefit to risk ratio that's quite high. It doesn't mean there's no risk, but it's quite high. So I'm just trying to figure out what the question was that really prompted this. And my second question is, it's really more of a comment. You know, for those who don't know, liaison members have not been included anymore in the working groups. And obviously the liaison members have been involved in vaccination for a long time. Obviously, Dr. Koldorf mentioned the fact that we want to make sure we have rigorous discussion among all members and all points of view. And the liaison members represent the patients that they serve. So in terms of knowing whether there's adjuvant in measles or knowing whether, the birth dose is given under 2,000 grams in a neonate. A lot of our liaisons have a wealth of knowledge about those issues. And, when we're creating vaccine recommendations, obviously, I know as a parent, I want to make sure that the most knowledge possible is going into the decision. So my question is, one, what is the problem we're addressing with the hepatitis B discussion? As far as I know, there hasn't been a spate of bad outcomes. And two, how can we make sure that we add the liaison members back into the working group so that they can contribute on behalf of their patients and their knowledge base? Thanks so much.
So as the chair, I'm going to answer the second question, and then I hope somebody else here can answer the first one. So regarding the second question, that's actually a FACA policy across CDC, not to include liaison members in the working groups. So this is a policy across all of CDC that is sort of outside the control of this committee. In the past, ACIP did not meet this FACA requirement, which is a formal legal requirement. So we were, no, not legal, but it's a formal FACA requirement. So ACIP was not in compliance with that. So that is something that is outside the control of ACIP. I agree with your statement that it's enormously valuable to have input from the liaison members. In the working groups, we do have many outside experts that we call in. So the working groups include at least a couple of members of the ACIP. It includes staff from CDC and then outside experts that are assigned to these working groups. So we do have outside expertise, an abundance of outside expertise in this working group. But in order to and these experts can certainly be affiliated with any of the organizations that have liaisons member here, but they're not representing the agencies. Like so, as a liaison member, you are representing the agencies. But when members from this organization serves on the working group, they represent themselves, not the agencies. So that's why we can. So this is a FACA policy. That is outside control of this working group. We just have to abide by that. As for the first question, maybe Dr. Levi can take a stab at responding to that.
Yeah, thank you. So let me start with two personal facts. I personally actually took the Hep B vaccines when I was older, before I traveled to areas where I felt that I'm going to be at risk if I end up in a medical setting. I have 6 children. All of them received this vaccine. Probably on the first day of their life, and I was never asked ever or was discussed before they received it, which maybe tells us something about a sample size of 6 of how frequently we do informed consent around that. But let me just kind of get to a more general point here. So I hear a lot the statement here, there is no evidence of harm. And again, I feel kind of uneasy by that, because I think that the question is if there is evidence of no harm. That's the question that we ask when we talk about safety, especially when we are about to give an intervention to a baby on the first day of their life that is perfectly healthy, and that the risk of not vaccinating them at the first day of life, we can argue about that, but it's probably close to zero, regardless of what kind of assessment you say. Definitely in the next following 4 or 5 months, but I would argue probably on the next several years. So I want to ask the following question: What is the reason? What is the reason that we don't have large and long-term RCTs, randomized clinical trials, to actually figure out the answer and finish the debate? What is that reason? And I think that the reason why we don't have that, in my mind, captures a lot of the things that are currently wrong with our medical system in general, but with vaccines in particular. And again, I want to repeat, I believe that this vaccine is absolutely critical and life-saving for babies that are at risk, for adults that are at risk. I took it myself. But this notion that we sit here with very lousy evidence and argue that there is no problem whatsoever is not building trust, and it's not scientific, and it's not what the public here should expect from us. In this particular case, particularly, there is no moral reason, there is no any reason why we would not have long-term, large-scale RCTs to figure out the answers. And I think that, to me, that's kind of the staggering question that is kind of like the elephant in the room.
Thank you. And before we continue, okay. So now we have Dr. Freihofer, please.
Thank you. I'm Sandra Freihofer. I'm a general internal medicine physician in full-time practice. I'm the AMA liaison, and I'm speaking on behalf of the American Medical Association. And for full disclosure, I have received the hepatitis B vaccine. When I was a medical student, I actually rotated through a hepatitis ward, and those were the sickest patients I had ever seen in my life. And I knew I never wanted to get that. And so when that hepatitis B vaccine was available, I signed up as soon as I could to get it. And I'm so thankful we now have a hepatitis B vaccine to protect our little babies from day one, to keep them healthy. We know that the hepatitis B virus primarily affects the liver, and chronic infection can cause liver disease, cirrhosis, liver cancer, and death. We know that hepatitis B can be transmitted in utero and via bloodborne transmission. And when it's spread in utero, 90% of infants will remain chronically infected. And chronic means just that, the infection doesn't go away. We also know that administering the birth dose of Hep B vaccine has almost eliminated perinatal hepatitis B, with only 13 cases reported in 2022. That's great evidence. We know that the hepatitis B vaccine dose at birth is safe and effective. The American Medical Association strongly urges ACIP to keep the recommendation for newborns to receive this hepatitis B vaccine dose. Thank you.
Thank you for that. And we have a few more on the list, and then after we're going to take a break after that. So, but we're going to continue with the list, the people that are on the list right now. So Dr. Munoz, please.
Yes, thank you so much for the opportunity to speak. My name is Flor Munoz. I am a pediatric infectious diseases physician. I am a clinician who actually has been working on transplant infectious diseases in a institution that performs the largest number of liver transplants in the country in pediatrics. I'm also a clinician investigator doing research in vaccines for many, many years. And I would like to just go back to a question that our colleague just asked, Amy Middleman, that I don't believe was addressed. And has been a question I've had along the day through these discussions as well, which is why? Why are we addressing this hepatitis B vaccine recommendation? Is there really a reason that the committee can provide for making a change? And I would like to also recognize the fact that the data that was presented today has been a very nice review of the actual evidence of the vaccine recommendation. And the data speaks for itself in that we have seen a significant change in the incidence of cases of hepatitis B. And because of that is that we don't see a lot of the effects and long-term effects of hepatitis B disease, not just in young children, but also in adults. And the decay in cases and the decay in other consequences of the disease is due to the vaccine. We also have seen that it's a very effective strategy and safe, and that it is implemented in many, many parts of the world. in that we have data from the United States that actually shows that this could be a disease, an infectious disease that could be eliminated. This is not something that we can say lightly from any infectious disease, and it is through vaccination that this has been done. And I would like to also point out the fact that although we are looking at hepatitis B vaccine for all newborns that could be potentially also at high risk, the system is not perfect, as has been pointed out by several members of the committee, where the different strategies and the different ways of implementing this strategy have been addressed in the past, and this is how we ended up with this recommendation. I would not want to see, again, vertical hepatitis B transmission in anyone or adolescents that did not receive their vaccine and become at risk. We have no control as to what would be the different risks that a baby or a child or an adolescent is going to have throughout their lives, and they are protected from birth. This is a very safe vaccine. And I think that, I would, last point I would like to make is that those that are our greatest risk are actually going to be the ones that will have the most serious consequences of making any change in their recommendations. It's not a very a error-proof system when you have the potential for false negative tests, for inadequate antenatal care, for no access of the vaccine, or lack of understanding of the real benefit of this vaccine. And this is really just a plea for the committee to continue to keep the recommendation as it is, because we do need to make sure that we protect individuals, but that we also protect the public in general, especially those that are most susceptible and vulnerable. Thank you.
Thank you. Dr. Paulson?
Hi, thank you very much. I'll be brief in the interest of time because I know you have the public comment. My name is Grant Paulson. I am the liaison with the Pediatric Infectious Disease Society. I agree wholeheartedly with the concerns raised from the ACIP in the full discussion with respect to protecting children. The newborn period is a very sensitive time. I'm not going to reiterate what Dr. Munoz and others have just said, but the Hep B birth dose, from my perspective, does come down to sort of risk and benefit. We've had two excellent presentations from the CDC on both the benefit and the risk. The risks are consistently felt to be low. I understand, I've heard Dr. Levy and understand from my perspective what the CDC has been asked has been with respect to this infant dose, not necessarily all of the safety data. And I guess I would ask the CDC or the ACIP to confirm that or make sure I'm interpreting that correctly. Specifically, people raise the question of fevers in infants, and that does prompt a sepsis workup and LP. As part of the CDC data presented, the risk is actually lower in infants that receive that Hep B vaccination within 24 hours. They have a lower risk of needing that sepsis workup, including a lumbar puncture. I'm not going to go forward into the other details, but my shortest version is the benefits are avoidance of a lifelong chronic vaccine preventable infection. And in a perfect world, we would know everybody that has Hep B, they would all be under care. Labs at a birthing hospital would all be done quickly, easily, and transparently. Unfortunately, we live in an imperfect world and have to decide public policy based on what's best for everyone, not just the anecdotes of my hospital or yours. And so I guess I will just sum up with my hope is that we're not asking the ACIP to approve a vaccine or pursue a vaccine to solve an adult problem. We're really hoping that the adults, meaning the ACIP decision makers, will continue to prevent this infection in children. And thank you very much.
Thank you. Dr. Buchanan?
Good afternoon. Thank you for acknowledging me. I am representing the National Association of Pediatric Nurse Practitioners, and I just wanted to echo and reiterate the safety of the vaccine. I, having taken care of many, many children and their siblings, and just administered the vaccine in clinic, and there's been no one that has had harm under my care. So my personal experience with the vaccine being administered in real time, as you all are giving your personal accounts about things. Also, please answer the question about why we were looking at this, because I think that everyone is wondering with the vaccine, with the history of safety for so many decades, is now being brought to the forefront. So please let us know.
Thank you. Dr. Hayes?
Yes, Carol Hayes with the American College of Nurse Midwives. It's my understanding that in most facilities that when the woman who is in labor signs the consent form, she's signing a consent form for vaccine hepatitis B birth dose, and that it's typically, in my experience, it's a refusal. So you know, someone can refuse the hepatitis B vaccine, but it's part of the universal consent form, is my understanding.
Thank you for that. Dr. Schley?
Yes, hi. A couple of comments. First off, I'm a family physician and I take care of prenatal patients as part of my care. We do hepatitis B screening often early in pregnancy, and so risk can change over the course of a pregnancy. The second thing I wanted to bring up was the uninsured population is growing in both people that used to have commercial insurance as well as the Medicaid population. And so we're going to have more and more people who will present without care, who present at delivery, which will make it risky for us to get those tests done, to know who should get the vaccine at birth for the baby and who should not. I also believe that most people do not share their risk information. They're embarrassed and they don't want to. And then lastly, if we have differential approaches to vaccination of babies based on risk, we also stigmatize the mothers as to you are risky, the other one's not. And so by universal vaccination, everybody is treated the same, and that creates equity in how we do our care. Thank you very much.
Thank you. Dr. Hopkins?
Thank you very much, Dr. Koldorf. I think the issues that raise greatest concern for me arise around equity and around lack of knowledge. If 50% of adults that present for delivery, or 50% of our adults in the population don't know their hepatitis B status as far as illness, and we continue to have children with congenital hepatitis B infections, and we remove the birth dose, we increase the risk to our population. We need to consider the domain of equity, which is critical in our evidence to recommendations framework. We need to use our work groups to get the best evidence. And to Dr. Levy's point, if we need additional long-term data, does it make sense to take away something that's successful while we're getting that data and be in a rush, as opposed to getting data and making a mindful decision based on the full set of data? Thank you, sir.
Thank you. A very good question. We are now, to everybody's delight, I think, going to take a 10-minute break. So please be back here at 4:35. Well, you are host. Okay.
That's true.
I think we'll be clear. So it's time to move forward, and I hope you enjoyed this short break. So if you can please be seated, and we will move forward with the agenda. We had an unanswered questions from the liaison members. So if Dr. Malone maybe shortly can I think Dr. Levi already responded, and we can have also a response for Dr. Malone.
So let me restate the question, and thank you, that was sarcasm, to the chair for the opportunity to field this very challenging question that was put forth to the committee repeatedly, particularly by the affiliate members. And the question, of course, restated is why this question, why now? Why the question now to defer the birth dose to 1 month when there isn't an obvious safety signal that's been detected associated with the birth dose? And I think that the question, to me, it sounds a little disingenuous, or at least self-evident, in that it's clear that a significant population of the United States has significant concerns about vaccine policy and about vaccine mandates. And in particular, one of the things that significant cohort in the United States has concerns about is the immediate provision of this vaccine at the time of birth, often in a context in which no true informed consent has been provided. We all know, and I know as a father times two, that the events around birth are really challenging. It makes it challenging for everybody to have clear thinking, make clear decisions. It's extremely stressful. It's extremely exciting. But the position that many in the United States encounter with this birth is that a medical professional acts in a unilateral fashion to perform a medical procedure and injection without substantial informed consent. And as we know, exacerbated by the events around COVID, there has been a significant decrease in public support for vaccination and a significant increase in concerns about public health and the ability of the population to rely on public health. And the hepatitis B birth dose has been a focus of folks that have these types of concerns. This is further exacerbated by the example, for instance, in Sweden, where there are no vaccine mandates and there is no hepatitis B birth dose, and yet the vaccine uptake in Sweden is perhaps, I think, the best in Northern Europe, and the infectious disease outcomes in Sweden is the best in Northern Europe, pretty much. And one might ask the question, why? Why, in the absence of vaccine mandates, is there such high vaccine acceptance and infectious disease outcome measures? And the answer is because the Swedish people trust public health in Sweden. And I think that that's what's really, in my opinion, underlying this. And I think many of us already know that. I think the question in my mind is a little disingenuous. The signal that is prompting this is not one of safety, it's one of trust. And it's one of parents uncomfortable with this medical procedure being performed at birth in a rather unilateral fashion without significant informed consent at a time in particular when there has been a loss of trust in the public health enterprise and in vaccines in general. So that to my mind is the reason why this is being brought to fore now, is because there is a substantial population of Americans that have decreased trust and increased concern in the provision of an invasive medical procedure immediately after birth at a time when they know that their children are particularly sensitive and susceptible to potential risks. Hopefully they are comforted by the data that have been provided, but I suspect that many concerns will linger. So that's my understanding of why we're seeing this right now, why this has been brought up. And I should say, I've had no direct communication with CDC leadership or HHS leadership about why this is a priority, bring it up right now at ACIP. So I'm just inferring based on what I understand about public opinion. Over. Thank you.
Thank you for that good answer to a good question. Very much appreciated. We're not going to put the proposed recommendations up on the screen. And then we are also going to take public comments. And we appreciate those of you who are waited to give your public comments. But there are actually two votes on Hep B. The first one is all pregnant women should be tested for hepatitis B infection. That is the first vote. And then we have the second vote as well, if we can put that on the screen. And that is the pediatric vaccine schedule should be updated to reflect the following change. If a mother tests hepatitis B negative or HBsAg negative, the first dose of the hepatitis B vaccine is not given until the child is at least 1 month old. 2, infants may receive a dose of hepatitis B vaccine before 1 month according to individual-based decision-making. That means that if parents choose to have that first dose on day 1 or before 1 month, even if the mother is negative, they can do so, and it will be covered by CMS, Medicare, Medicaid, as well as other health insurance companies. So those are the voting questions for hepatitis B, the 2 voting questions. And I think we are now going to go to the VFC presentation, similar to that we had for the MMRV vaccine. Yeah. This is always nice to have a little bit of pause for silence. That's always nice for the mind.
What are we waiting for?
Mr. Chairman, do we need a motion to vote or a motion
No,
to
not-
discuss?
We are not right now. We are waiting for the VFC presentation. I think it's ready to go.
Ah,
So thank
very
you.
good. Thank you, sir.
Hello, again, this is Jeannie Santoli, and we're going to walk through the hepatitis B resolution update. Next slide, please. So again, where you see red font or highlight, that's where you'll know where the changes are from the currently approved version. Next slide, please. So the purpose of this resolution is to update the recommended vaccination schedule and intervals section to reflect updated ACIP recommendations about the birth dose of hepatitis B vaccine. Next slide. There is no change to the eligible groups. Next slide. For the recommended vaccination schedule and intervals, there are some changes to the infants table. So you see here, the table's broken into two parts, but this is for infants who are greater than or equal to 2,000 grams. And for the infants whose mother is hepatitis surface antigen status negative, there's a change when the first dose is given. The first column shows for children who are only receiving single antigen vaccine. The second column is for children who might receive a combination of single antigen and combination vaccines. And there are some footnotes. We'll look at those in just a minute. And then there's also a change in the first column. That was 1 to 2 months previously, and it is now 2 months for the second dose. Next slide, please. So these are for the smaller infants who are born at less than 2,000 grams. And here again, you'll see a similar, the first dose is given at 1 month. And we're going to look at those footnotes too in just a minute. Those are the only changes to the table, but we're going to pop down now and look at the table notes. Next slide. So the first footnote is actually changed to recognize that the only single antigen hepatitis B vaccine can be given at less than or equal to 6 weeks of age. That previously said at birth, but with this change, that we've made this change to the footnote as well. And next slide, please. So there are 2 new footnotes, and these reflect the language about individual-based decision-making. So the first footnote is for infants greater than or equal to 2,000 grams who are born to hepatitis surface antigen negative mothers may receive 1 dose of hepatitis B vaccine before 1 month under individual-based decision-making, also referred to as shared clinical decision-making. That's another term that there'll be familiarity with. And the second footnote is infants less than 2,000 grams born to hepatitis B surface antigen negative mothers may receive 1 dose of hepatitis B vaccine before 1 month under individual-based decision-making, also referred to as shared clinical decision-making. Next slide, please. This is the table about children's vaccination. There are no changes. Next slide, please. These are the table notes to that table. There are no changes. Next slide, please. This is some additional guidance about what to do when what interrupted schedules and minimum dosing intervals, and this isn't related to the birth dose, so there are no changes here. Next slide, please. This is about revaccination and when that's necessary, and there's guidance here. None of that has to do with infants who are born to hepatitis B surface antigen negative mothers. So there are no changes. Next slide, please. And no changes here as well. Next slide, please. The recommended dosage, no changes. Contraindication and precautions, no changes. Next slide, please. And then this is that statement, similar statement that we saw in the other resolution about if something is published within 6 months, it will be incorporated into the resolution by reference. And that concludes the VFC resolution.
Thank you. So there will be 2 votes on hepatitis B. There is a slight discrepancy in these 2 votes. So I think what we're going to do, we're going to work on that and do the hepatitis B vote tomorrow. But before that, we're going to now move forward to the public comments. And we have 9 speakers, and we appreciate you taking the time to speak to us. And you have 3 minutes each. And the first one is Ms. Anu Hosangari, and you can please specify if you're from an organization or if you're speaking as a private citizen.
Thank you. Hello, my name is Anu Hosangari, and I'm speaking on behalf of the Hepatitis B Foundation. I'm here today to remind the committee about the remarkable safety profile of the hepatitis B vaccine, one of the most rigorously studied vaccines of all time. Since its introduction in 1982, over 1 billion doses have been administered globally, with decades of clinical, epidemiologic, and post-marketing surveillance demonstrating its efficacy. The body of evidence is unmatched. A vaccine safety data link study compared newborns vaccinated against hepatitis B to unvaccinated newborns and found no differences in mortality between the groups. CDC's own review of theirs from 2005 to 2015 failed to identify any new or unexpected safety concerns, and the overwhelming majority of reported events were extremely mild and temporary, such as low-grade fever or slight redness at the injection site. Hundreds of studies reinforce this safety record. In the early 1990s, CDC examined healthy full-term newborns receiving hepatitis B vaccine to evaluate fever, sepsis, and neurologic complications. The study found no increase in any of these outcomes. A subsequent 4-year case series, the largest review of hepatitis B vaccination among newborns and infants, found no serious health problems linked to the vaccine. Hundreds of millions of individuals have received the vaccine worldwide, and rigorous studies consistently demonstrate no causal link to severe consequences such as multiple sclerosis, autoimmune disorders, asthma, seizures, or sudden infant death syndrome. The vaccine's safety is further reinforced by decades of real-world use. Recombinant hepatitis B vaccines are highly immunogenic, providing seroprotection greater than 95% in healthy infants, children, and young adults. Even when the antibody levels decline over time, immune memory persists, providing long-term protection against both acute and chronic infection. Serious adverse events are extremely rare. The Global Advisory Committee on Vaccine Safety continues to monitor all reports and has repeatedly affirmed that the vaccine safety profile is excellent. Pregnant and breastfeeding women, low birth weight infants, and HIV-positive individuals can safely receive hepatitis B vaccination. This committee has repeatedly professed its responsibility to uphold the highest standards of vaccine safety and evidence-based practice. Maintaining the universal hepatitis B birth dose is a proven, safe, and life-saving intervention. The science backing universal vaccination is indisputable. Thank you for your time.
Thank you. And I will also remind everybody that there are also many very valuable and interesting comments that has been submitted in writing. So I would encourage everybody to read those as well. So now we move forward to Samantha Sears. Please go ahead.
Hello, and thank you. My name is Samantha Sears, and I'm representing the National Consumers League. Since its founding in 1899, NCL has worked to advance consumer protections in several areas, including healthcare, where we have focused on increasing public awareness and confidence in immunization and other preventative health measures. We appreciate the opportunity to present public comments today. NCL urges the committee to ensure its recommendations are grounded in medical science and proven safety and efficacy. At a time of heightened public scrutiny, declining immunization rates, and growing distrust in the federal health institutions caused by those who have continued to challenge longstanding evidence of efficacy and safety, it is essential for the health of the American public and, most importantly, for America's children that ACIP decisions are based in science and advance the protection of public health. It is crucial now more than ever to preserve the strength and integrity of our highly successful immunization system and infrastructure. The U.S. has seen a decline in immunization rates for preventable diseases, in part because of a decline in confidence and a growing distrust of public health systems. Misinformation must be countered through trusted messengers and experts in the field. Without them, consumers across the nation are left confused about where to get accurate, scientifically backed data and recommendations to guide their decision-making. ACIP has always and must continue to play this role. NCL has significant concerns about potential changes to the childhood vaccine schedule. The existing childhood vaccine schedule is firmly grounded in decades of rigorous scientific evidence and has been crucial in reducing and eliminating deadly diseases in the U.S. Altering the schedule has serious real-world consequences regarding insurance coverage or school entry requirements. Altering the schedule by changing recommendations may create gaps in coverage, reduce access for families, and place an additional financial burden on parents seeking to protect their children. Such changes also risk sowing further confusion about vaccines for parents and caregivers. In the short time since the FDA's change in approval for COVID vaccines for children, parents across the country are confused as to what they should be doing to best protect their children. We as an organization are concerned that changes to the childhood vaccine schedule will cause greater confusion among parents and further risk children and their communities. Finally, ACIP should align recommendations with that of medical societies such as the AMA and AAP. Alignment in recommendations from public health institutions and medical societies minimizes the risk of contradictory messaging, ensuring that patients and consumers receive clear, consistent, and scientifically grounded information. NCL appreciates the opportunity to share our views on these important issues and urges ACIP to remain firmly focused on advancing the committee's mission of protecting the health of the nation's children and adults. Thank you.
Thank you very much. And now Dr. Lechuga, please.
I am Dr. Isabel Lechuga, and I am the director of the hepatitis team at NASTAD, a nonprofit that represents health departments overseeing hepatitis prevention and surveillance programs within their jurisdictions. Previous to my switch to domestic public health at NASTAD, I was with NASTAD's global program, overseeing and providing direct technical assistance to public health workers in 5 countries in Central America, Haiti, and Jamaica. The clinicians and public health workers in these countries would request our expertise on how they can continue to grow their healthcare and public health infrastructure to implement robust and evidence-based strategies, including the hepatitis B birth dose. I would include the following. 1991, the year ACIP recommended universal infant hepatitis B vaccination, a result of the US recognizing a strategy that was both simple and universal, resulting from their review of data from the US and globally that demonstrated 1, implementing vaccination for high-risk adults was failing. 2, there are persistent and ongoing perinatal and childhood cases despite maternal screening. And 3, strong immunogenicity of the vaccine in infants that led to the sharp decline in childhood hepatitis B cases and ultimately became the foundation of the US strategy that led to the universal birth dose policy in 2016. A result of American scientists and clinicians quickly recognizing that the ACIP and CDC's hepatitis B birth dose strategy had a swift impact to protect babies, in addition to being both cost-effective and efficient. Hailed as one of the first anti-cancer vaccines, it also protects babies from hepatitis D, a virus that requires hepatitis B surface antigen to form infectious viral particles, which in July of 2025, the International Agency for Research on Cancer classified as carcinogenic to humans. Pre-1991, the CDC and American epidemiologist and physician Dr. Palmer Beasley estimated approximately 16 to 20,000 infants were born each year to mothers with chronic hepatitis B. Post-2016, there are approximately 800 cases of perinatal hepatitis B per year, which are most likely linked to highly viremic mothers and health system failures, such as when maternal screening is missed, late, or incorrectly documented. Less than 300, the estimated number of cases per year if the US stays on course with universal birth dose and antiviral treatment of highly viremic pregnant women with tenofovir, treatment developed by an American company. In conclusion, when I send my previous colleagues in Central America, Haiti, and Jamaica my annual happy holiday greetings in December, I hope I can write to them. P.S. I'm delighted to report the U.S. is still on course to eliminate perinatal transmission of hepatitis B through the birth dose strategy, which means your tireless efforts to implement this same strategy will lead to the same results in protecting your babies. Thank you.
Thank you. We continue with Michelle Montandon.
Good afternoon. I speak today as a family doctor who spent over 15 years working in global health. And until last month, I led CDC's global efforts to end mother-to-child HIV transmission. I also worked as a doctor in Africa and treated children and adults suffering from vaccine-preventable diseases like measles, tetanus, diphtheria, and cervical cancer, diseases that should never cost people their lives. I've heard from physician colleagues in the US that they're facing chaos and confusion in the vaccine space, struggling to reassure families who don't know what information to trust. We desperately need to rebuild trust between the American people and public health, medical, and scientific communities. Secretary Kennedy has stated that he wants to do this, but his actions indicate otherwise. The Secretary said he would not interfere with the work of this committee, yet he fired all 17 members without cause and appointed the new members here today, most of whom have anti-vaccine track records. Secretary Kennedy announced new COVID-19 vaccine guidance on social media, bypassing the usual scientific process and disrupting vaccine access across the country. In a stark reminder of the dangers of vaccine misinformation, on August 8th, a gunman who espoused anti-vaccine ideas fired 500 rounds at the CDC and killed Officer Rose, who bravely protected CDC staff in the child care facility. I've heard from fellow physicians that their work is already changing in this environment. Medical practices and residency programs are conducting trainings on vaccine preventable diseases, seeking out senior infectious disease doctors, since most American physicians have never seen these conditions. I heard about a parent who wanted her child vaccinated, except for the hepatitis B vaccine, because she heard online that she shouldn't get that one. This was not based on new studies or safety data. This was due to escalating vaccine misinformation. In reality, the evidence for the hepatitis B vaccine starting at birth is strong. If it is delayed, some infants will get a lifelong incurable infection that is easily prevented by a safe and effective vaccine. I was recently reminded of something one of my mentors said. Family medicine is not about doing everything at all times. It's about fulfilling the needs that the moment requires of us. In this moment, I cannot sit silently as Secretary Kennedy undermines science, public health, and vaccine access in this country. I urge the public, Congress, and this administration to take proper action and restore the competent science-based leadership at HHS and CDC. For the health and safety of American families, Secretary Kennedy must go. Thank you.
Dr. Stone? Do we have Dr. Judy Stone?
I've been a practicing infectious disease physician for over 40 years, and there is nothing worse, nothing more haunting than watching an unvaccinated child die of vaccine-preventable disease. I still hear this young teen asking me if he was going to die. I'm here today to urge you to make decisions that will decrease, not increase, such deaths and illnesses in our children. Early on, I saw a number of now eliminated diseases. I even had 2 patients with tetanus who hadn't been immunized. That doesn't happen now. Before meningococcal vaccines were recommended, we had a small outbreak of meningitis from that in our town, killing 2 teens and leaving 1 death. I still have nightmares about them. In 1900, nearly 1 in 5 American children died before their 5th birthday from infectious diseases like pneumonia, diphtheria, and measles. We've come a long way since then. These infections have almost disappeared in our country. Through vaccination, hundreds of thousands of childhood deaths have been prevented and millions fewer children have been hospitalized. But even today, in the US, vaccine-preventable infections kill more individuals annually than HIV/AIDS, breast cancer, or traffic accidents. We're already losing to some diseases. Measles, which was essentially eliminated, has now rebounded due to misinformation that has led to vaccine skepticism, the use of potentially dangerous treatments, and plummeting vaccination rates. Measles is one of the most highly infectious diseases and causes illness in 90% of those exposed who are not vaccinated. And it's not just a short-lived rash. 1 in every 5 children with measles is hospitalized, and some die. Yet some propose to eliminate mandatory school vaccinations that have protected our students for decades. Measles can also damage the immune system of children, making them more susceptible to other infections for years. Unvaccinated people exposed to measles are advised to quarantine for 21 days. That means no school for the child and no work for an unvaccinated adult. How many people can afford to do that? And with 20% of infected children requiring hospitalization, how will medical centers maintain adequate staffing? The resurgence of easily preventable infections poses huge costs to society. In public health, we must care about other people. This is part of the social compact we saw during World War II, the 9/11 attacks, and the polio epidemic of the 1950s. We need to continue to support the entire community's immunity. That allows everyone to go to work or school and to remain healthy. Why would anyone want to go back to the pre-vaccine days and destroy public health? This committee must preserve access to vaccines to protect people in our country. It must keep people safe and healthy by dedicating itself to continued access to all vaccines. We must not go back. Thank you.
Therese Tetzel. We'll move forward to Mr. Bertani, and we'll try to go back to Therese Tetzel later. So, Mr. Bertani.
Sure. Hey, thank you for this opportunity. I am Scott Bertani, the Director of Advocacy at Health HIV, a national nonprofit strengthening health systems through education, training, research, and advocacy. And we work for people impacted by HIV, hepatitis, Mpox, STIs, sickle cell, and related health challenges. And I'm grateful to address this newly reconstituted committee as it considers decisions shaping public health for decades. In this transition, your role carries a profound responsibility to uphold ACIP's legacy as an independent, science-driven safeguard for the nation's health. And the agenda before you reflects that weight. Today, you deliberate on MMRV and hepatitis B vaccines that greatly advance public health. Among them, the Hep B birth dose is a clear example, protecting infants from infections at delivery that could become lifelong in over 90% of cases, while timely routinization lowers risk into adulthood. The safety and efficacy applies to combination vaccines like MMRV. But even as you revisit long-established successes, the burden of vaccine-preventable disease, it's compounded by growing chronic conditions. It's heart disease, it's cancer, diabetes, kidney and liver disease, and Alzheimer's, and they now define the leading causes of death. These morbidities fall heavily on immunocompromised and people living with HIV. Vaccines may be on the docket, but the frame widens to include chronic disease, and without strong uptake, people already facing barriers to care and cost, and aging populations remain at risk of spillover threats like COVID, shingles, and RSV. And that's why your work this week, it carries generational weight. ACIP's recommendations, they determine guidance, insurance coverage, pharmacy access, and state law. When recommendations and scientific equity weaken, patients lose access, providers lose clarity, supply becomes problematic, and stigma, misinformation, and confusion spreads across clinics, pharmacies, and schools. So we urge you to, 1, uphold the committee's evidence-based and evidence-to-recommendation processes. 2, keep the full immunization schedule as published in the MMWR. And 3, reinstate universal COVID-19 vaccination for everyone 6 months and older to protect those at risk, their parents, grandparents, and caregivers, and recognizing that VAERS is a signal detector and the vaccine safety data link confirms what's real. Please preserve our future. Thank you.
Thank you. Evan Sachs.
Hi, my name is Evan Sachs, he, him, or user. I am the founder of the Washington Heights Inwood Mask Block and also a member of ACT UP New York and Mask Together America, though I am speaking on behalf of myself as a mutual aid provider today. I am also trained in translating technical subjects for lay people as a journalist and a copy editor, which it sounds like some of y'all need today. See, vaccination is much like rules of the road for driving. Do we only vaccinate when we're high risk? Or do we only wear our seatbelts when we're high risk? Or do we do that when we say, okay, I am perfectly healthy, but I don't want to become unhealthy? That's what vaccines are for, just as that's what seatbelts are for. And we only say, well, drive on whichever side of the road you want, and only follow the speed limit if you personally trust your city council members? Or do we say, if you go over the speed limit, you risk a ticket? That is why public health is so important to say, yes, you must do this where other people's health is concerned, because saying you can drive however fast you want on whichever side of the road you want doesn't just endanger you, but it endangers other people, just as communicable diseases endanger both yourself and others. Vaccines are safe. Are they 100%? I don't think anything is 100%, but neither is seatbelt wearing or driving on the right side of the road. Yet we don't see people complaining about that for good reason. It's pretty darn effective. And if we demand 100% from everything, we'll get nothing done. We also need to realize that many vaccines, because they're not 100%, also require additional layered protections, such as masking during this demonstrably ongoing pandemic, because they're not 100%. Not being 100% is still great, but also means we need layered protections and to be smart about this and not risky. Thank you.
Thank you. And we will move forward to Melissa Kadri.
Hi, I'm a master's of public health student, but I'm coming as a private citizen, and I want to talk about my uncle who was in his 40s, healthy, and with no pre-existing conditions when he died earlier this January. This man was the patriarch of the family. He organized every outing for us. He took care of everyone. He'd walk in the neighborhood and everybody would say hi to him and ask him how he was doing. Everybody loved him. Everybody respected him. And when he died, it left a hole in the family. My aunt, his older sister who was dealing with cancer, saw his body of her baby brother in that casket and it broke her heart. That grief is what killed her a few months later, earlier this year. If the family was a table, its legs were broken, and now the whole family feels like it's on the verge of collapsing. He was a breadwinner of his family, and he leaves behind his 21-year-old son, my cousin, who now has to step into the role of a provider for his mother and his two younger sisters. He died of COVID. He couldn't access the vaccine because of a combination of money, healthcare, accessibility. He was a healthy man, and he died still. And this summer, I visited some family who live overseas. As I was walking in the street, I saw a man with a body I can only describe as mangled walking past me. And I'm not the kind of person who gets scared or spooked easily, but it disturbed me in a way I cannot get out of my head to this day. And I had never in my life seen anything like that. I have never heard of any type of disability or seen anything like that. My friend told me, that was with me at the time, that man had contracted polio. Polio, something we as Americans are privileged as not even thinking about because of the mass vaccination and because of the herd immunity those vaccines provide. And that herd immunity is what is at risk with changing guidelines. When you restrict guidelines and extend the age of the childhood vaccine, a baby that needs that vaccine to 4 years old, it's against the science. You kill people, you kill their future. You kill their families with grief. With the hepatitis B vaccine getting extended, the likelihood an infant child gets that illness is 90%. 25% of those people who will now contract those illnesses, and these are children, they'll die prematurely. Do you want to do that to the mothers and fathers across this country? There's a reason we mandate the vaccines. We might not see the impact of a decision to restrict and extend the age it's needed for years. It might be 3 years, it might be 5 years, it might be 10 years. But don't do this. Do not put the blood on your hands. Thank you.
Thank you. I'm going to try again to see if we can get Therese Tetzel. If you're there, please. I think we don't have Therese Tetzel there, so this concludes our public comments. I'd like to thank the the speakers. And also I want to thank everybody in the public who submitted a written comment. We very much appreciate that, and we encourage everybody to read those written comments. The next step is to vote on the MMRV vaccine. If there is a motion to do so, and there will be 2 votes. Do we have a motion?
So move.
Yes, can we put the motion up for the MMRV vote? Do we have a motion? Thank you. Do we have a second?
Second.
Thank you. And we will vote. I think Dr. Malone will not vote, so but we can start then with Dr. We have a proposal for an amendment.
That we change the language from is not recommended to MMR plus V is preferred.
Do we have a second for that? Well, actually, that is the current policy. So if you think that is
Okay,
then you should just vote no, I think.
I move that we go back to the existing language.
Yeah.
And then add in the shared clinical decision making.
So if that is your view, then you should vote no to this motion, because that means that there's no change. So I think, can we start with Dr. Pagano? And do they have a conflict of interest?
Yes, please state.
So state your name, and then if you have a conflict of interest, and then a vote yes or no.
Yeah, James Pagano, no conflicts of interest. Yes.
Thank you. And Dr. Malone?
Kirk Melhone, no conflicts of interest. Yes.
Dr. Blackburn?
Hillary Blackburn, language as is, no.
Thank you. Dr. Stein?
Kathy Stein, no conflict of interest, yes.
Dr. Griffin?
Evelyn Griffin, no conflict of interest, yes.
Dr. Pollack?
Raymond Pollack, no conflict of interest, yes.
Dr. Hibble?
Joseph Hibbelin, no conflicts of interest, no.
Dr. Petsworth?
Vicki Pebsworth, no conflict of interest, yes.
Dr. Levi?
Retzef Levy, no conflict of interest, yes.
Dr. Meissner?
I have no conflict of interest, and I vote no.
And you state your name?
Cody Meissner.
Thank you. And I'm Martin Kuldorf, no conflict of interest. I vote yes. So that concludes the first vote of the day. Thank you. And we also have a vote on the MMRV VFC. If we can put, do we have that on the screen also?
Point of order.
Yes.
Have we addressed both components of the vote?
Pardon?
Point of order, have we addressed both components of that vote? Were they 2 separate issues on the MMRV, or was that one issue?
We had one vote, but this is the follow-up vote for the VFC vote to make sure that everything is covered under CMS, Medicare, and Medicaid. Actually, before on the first vote, we also have to have formally vote for Dr. Malone to say that he abstained.
Robert Malone, no conflicts of interest, abstained due to pre-existing legal agreements.
Thank you so much for that. Dr. Pagano?
The yes vote here will ensure that the vaccine for children will compensate for the resolution we just passed.
Yeah, correct. So it ensures that children, the vaccination will be covered for children for the vaccines. Yeah. Yeah, and that reflects the language of the first vote.
Yes. Dr. Pagano, I want to, what I heard you say, and it might not have been what you said, so I thought you said a vote yes here will compensate for, and I just wanted, that was a verb I wasn't expecting. So a vote here that's a yes will align with the recommendation vote that was just taken and will mean that the combination vaccine is not covered in VFC for the children who are under 4 years of age. I wasn't sure what the word compensate meant, and that's why I wanted to just clarify.
I really appreciate that clarification. So thank you so much. Yeah. Do we have a motion? Oh, sorry, there's from CMS also.
Mr. Chairman, just to confirm on the tail end of colleague here comments that the same would apply for Medicaid, CHIP, and also the individual and small group markets as well, where the combined shot under 4 years of age would also not be covered.
Thank you so much. It's a technical, very important issue. So,
order. This is Cody Meissner. I'm still not quite clear. So if we, the first vote has passed already, and if we vote no on this item, then what happens? VFC will not cover it?
A yes vote here will align the VFC resolution with the recommendation. A no vote here will keep things as they are for VFC, and there will still be the same coverage that there is today, which does cover the combination vaccine for ages 12 months through 12 years.
Thank you.
Thank you for that.
Mr. Chairman, might I ask that in the future we have full written information on each of the things we're voting on. We did have full text of the first component of this vote.
Yes.
And we did not have full text of the current item that we're voting on. And it's, although the presentation was excellent, it's very difficult without a full written record of what we're voting, a written description of what we're voting on and its consequences.
Right. Thank you for that comment. Can you respond to that?
So the challenge is it was hinging on which direction that you were wanting to go. So that actually, my work got finished last night around 11 p.m. once I understood what you were going to propose. So there's not the opportunity to give you the written document before because I was trying to align it. Maybe we could do something different at a future meeting, but with the timing, it was reacting to the language that the committee had been considering and was going to vote on.
Dr. Santo.
Thank you,
Martin.
And thank you for working very late last night. We appreciate that.
This is Cody once again. Martin, if I can ask Dr. Santoli, thank you for all of your efforts on this. But I still want to clarify. So if we vote no on this, the previous reading in terms of giving the vaccine will still be covered by VFC. That is if we vote no on this, there is no change to the standing situation. There will be funding for children. Is that correct?
So, right, so for VFC, if there's a no vote, it will say as it is, which is that the combination is covered. However, VFC and CMS wouldn't be doing the same thing here because CMS is going to be tied to the recommendation. VFC is tied to the resolution. So it is possible to have two different things, but there is a potential area for confusion, right? When it's covered differently under one program than others.
The current VFC resolution does not impact the CMS. The previous recommendation of the ACIP committee overall is what implicates the coverage decision for Medicaid, CHIP, and individual markets.
Thank you for that, Dr. Pagano.
Okay, just so we can try to just get this completely cleared up. If we recommend something here, it automatically then falls into the category of being reimbursable. Is that correct?
I think my understanding, there are two parallel decisions. One is what we just voted, and the other one that is now.
Oh, right.
And as long as you don't approve something else, the previous decision on that dimension stays. And
Cody and I share the same confusion here, okay? Because traditionally, we recommend something, it then automatically gets covered. Here we are not recommending something and we're being asked to put in a no vote on something to allow it to be covered. It's very convoluted.
Can I clarify something from both of you? So, under CMS is CHIP, correct? Okay. And under VCSF is sort of all other vaccine payments for children.
No, VFC is Medicaid, uninsured, American Indian, Alaska Native, and children who are underinsured, so they have cost sharing with vaccines when they're served in a federally qualified health center. So that's who is covered under the VFC resolution.
And CHIP is a separate thing out of CMS.
CHIP.
So if we were to vote no, then CMS would go back to old funding and CMS or VCF, sorry.
VFC would go to the.
VFC would go to.
We're doing now.
Say would do it, but CMS including CHIP, right, would.
CHIP and the individual markets are not affected by this vote.
I see.
Are affected by the previous vote.
I see.
Do we have a motion? Thank you. Do we have a second?
Second.
Thank you. So we'll do the same order, but we start with Dr. Malone.
Dr. Malone has recuses himself from this, has no conflicts of interest, and will abstain.
Thank you. Dr. Pagano?
Yeah.
Point of order, sir. Did not Dr. Malone recuse himself from all MMR?
Yes, so he is, because of that, he abstained, yeah.
Okay, very good. I'm sorry.
He has to say that formally.
I'm sorry, sir. I didn't hear appropriately. Perhaps I'm getting tired.
I think we're all getting tired from a long day. So Dr. Pagano?
Dr. Pagano, I'm going to have to abstain on this.
And do you have conflicts of interest? Conflict of interest?
No conflicts.
Dr. Malone?
Kirk Milhone, no.
And do you have a conflict of interest?
No conflicts of interest.
And your vote was?
No.
Dr. Blackburn?
Hillary Blackburn, no on this to maintain access.
And do you have a conflict of interest?
No.
Kathy Stein, vote no, no conflicts of interest.
Dr. Griffin?
Evelyn Griffin, no conflicts of interest. I vote no.
Dr. Pollack?
Vote no, no conflict of interest.
And your name?
Joseph Evelyn.
Sorry, can you state your name, Dr. Pollack? Can you state your name?
Raymond Pollock, vote no, no conflict of interest.
Dr. Hibbel?
Joseph Hibbelin, I have no conflicts of interest. I vote no on this proposition.
Thank you. Dr. Pepsworth?
Vicky Pebsworth, no conflicts of interest, no.
Dr. Levi?
Retzef Levy, no conflict of interest, no.
Dr. Meissner?
I'm still confused. If we vote no on this, we're essentially saying there will be different recommendations for children who get the vaccine through VFC compared to children who do not. Is that correct?
It's coverage. It's coverage, it's coverage, not recommendation. I
Yeah.
think it's two different things. If I understand correctly, this is about coverage, not about
They need to
recommendation.
unlink stuff.
I know.
You're right.
I understand that, but if it's not covered by BFC, then they will continue to use the current recommendation.
So Dr. Meissner, if I would like you to vote, and if it's confusing at this point, I think we have to conclude the voting. So you're welcome to abstain if you want, or you can vote yes or no.
Thank you. Sorry to prolong it. I'm going to abstain because I'm not quite sure what I'm voting for here. I don't want discrepancy between the children who get their vaccine from VFC and the children who don't get their vaccine through VFC. That's not right. And
thank you. My name is Martin Guldorf. I have no conflict of interest. I vote yes. That concludes the vote, and that concludes today's. We will tomorrow. We'll wait. So the hepatitis B vaccine vote we will do tomorrow, and we will also do the agency updates, which we were not able to do today. We'll do that tomorrow as well. So I thank you all very, very much, and appreciate your hard work and your endurance today. So thank you very much, and hereby close the meeting for today.
Point of order. Point of order. Should we be having a motion to table this vote until tomorrow because it was scheduled to be made today? And if we table this vote, does that require a vote by the committee to table it?
For the happy vote?
Yes, we have
No,
that
we can
vote
just do that.
scheduled for today.
We can just do it tomorrow. That's not a problem. It's a combined meeting.
Do we need to have a vote to table this
No.
for today until tomorrow?
No, we don't do that vote.
Can't table something, just.
And we are reconvening tomorrow at 8:30. But what I do need is I need to read the results of the vote. For the first vote, there were 8 yes, 3 no, and 1 abstain. For the second VFC vote, there was 1 yes, 8 no, and 3 abstain. So thank you so much. And this concludes the meeting now. Thank you.
So that preserves the funding for both vaccines, but not recommending the combined vaccine.
Yes.
Right. Goodbye, everyone.
Who's got?